in today's world of internet and online, I think many more people reach out and use these than we think about. While I also highlighted the issues of equity in access, there certainly is use for such apps. And I think the launch of this app would be a very important way to push forward the objectives of the International Union for Patients. So, with that, I wish you, Dr. Gupta, and colleagues and the app makers all the best.
Good morning, everyone. A very warm welcome to each one of you at the International Patients Union Conference 2026, India's only patient focused, patient driven, and patient led national conference. It is an absolute honor to host this gathering of visionaries, advocates, clinicians, policymakers, and most importantly, patients and caregivers, all united in one mission to reimagine healthcare by keeping patients at the center. What began in 2023 as India's first and only patient focused conference has grown into a movement that says patients are not passengers in the healthcare system, they are the destination. The International Patients Union is committed to making healthcare more accessible, affordable, and high quality, ensuring that patients are not just recipients of the care, but active participants in healthcare decision making. Our mission is to transform healthcare into a system that is पेशेंट ड्रिवन एंड आउटकम ओरिएंटेड. हर साल हम एक मंच पर उन आवाज़ों को एकत्र करते हैं जो अक्सर अनसुनी रह जाती है. As we come together to celebrate World Health Day 2026, this year's theme, Healthy Beginnings, Hopeful Futures, reminds us that every patient's journey matters from the very first step. At IPUC 2026, our theme, Voices to Action, Action to Impact, takes this vision a decisive step forward. IPUC 2026 marks a shift from dialogue to action, turning patients' voices into tangible, system-level impact in an increasingly digital and evolving healthcare and landscape. ये सिर्फ आवाज़ उठाने की बात नहीं है, बल्कि उन आवाज़ों को प्रभावशाली कदमों में बदलने की जिम्मेदारी है. ऐसे कदम जो स्वास्थ्य सेवाओं को और अधिक सुलभ, ट्रांसपेरेंट और मरीज केंद्रित बनाएं. Before we begin, let us look back at how far we have come. Please direct your attention towards the screens for highlights from IPUC 2023, 2024, and 2025. So, with the 2023, the theme was Patients, the Missing Voice. We continued with the same insights with a theme for the next year, 2024, which was leveraging technology for patient engagement and improving treatment outcomes. We continued with the same vision in 2025 with our theme Serving Patients in Digital Age. With different themes every year, this makes a record of real voices that shaped policies, of patients who stood up, and of systems that began slowly to listen. IPUC 2023 की शुरुआत एक बीज की तरह थी. IPUC 2024 में वो बीज पेड़ बना. IPUC 2025 में हम उस पेड़ की छाया में आए और आज IPUC 2026 में वो पेड़ फल दे रहा है. Now, before we jump into our sessions, let's quickly go over a few house rules to make sure everyone has a smooth and engaging experience today. All sessions will take place in the multipurpose hall, Kamla Devi Complex, India International Center. If you lose your entry pass, present your email with your QR code at the registration desk to receive a duplicate badge. Delegate kits will be distributed at the time of registration. Participants will receive their certificates via email within 15 days of the event, including 8 CPD hours. Meanwhile, nursing professionals will receive 5 CNE hours and 1 CNE credit. Networking opportunities are available during tea breaks and lunchtime. When posting about the conference, please use the hashtag IPUC 2026. Speakers are requested to strictly adhere to the allotted time. No session can exceed stipulated time, as 15 minutes must be reserved for audience Q&A. After each session, attendees can ask questions and rate the session at Mentimeter by scanning the QR code which is present on their tables as well as on their lanyards. For any assistance, feel free to contact us at office@patientsunion.org, or you can contact us at +91 99 111 00665. The IPU team is here to help. We have an insightful and thought-provoking day ahead, covering some of the most pressing issues in healthcare. Today is a working day for most of you, and you chose to be here. That itself is a statement. Make it count, speak it up in open mic session, ask questions, use the notepad provided to jot down your key takeaways. This platform is yours. Let's make today's discussion engaging, insightful, and transformative. Now, it is my privilege to welcome to the stage the personality who is, in many ways, the reason we are all here today. A visionary, a policy architect, a relentless champion of patients' rights who has spent decades asking the question that this conference is built around: who speaks for the patient? Dr. Rajendra Pratap Gupta, sir, founder, International Patients Union. Sir, may we please have you on the stage?
Good morning, and thank you, Dr. Harsh, for this opening remarks. After this year's conference, we'll be in our 5th year. And when we started this, people said, this will not last because no one will support. I said, we are not here for people's support. And we are also not an activist organization. We are a catalyst organization. We work in the system, not against the system. So all the years that people would have come, you would have seen that top people from the policy join us. In fact, they seek us. What did patient tell? What do you want us to change? This was something that Dr. Vinod Paul told me. Rajan, mujhe ye batao, what do you want as change? Give me the inputs of your conference. You have seen people coming, and I think one thing is very clear that we fail to accept the broken health system. We have started appreciating the problems, and I think the time is that we should accept first that there is a broken health system. If there is a system, then only we can change it. I see many of my friends sitting who do phenomenal work in this area. I really thank them for joining us. So typically how we work is we go by what we have done. Our goal is primary studies before. We don't want to make opinions here. So I'm going to present to you 2 studies that we have done, running up to this meeting. One is a study of 105 patients, another is 54. We all think that cost is a basic issue with lower middle class. Actually, it is not. I mean, if you look at this study, upper class, 7 out of 10 people feel that healthcare is expensive. So affordability is not just limited to lower income or lower middle income or middle income. Even upper class feel the pinch. If that is the status, just think where we are headed. This is a study we have done ourselves, so it is not a secondary research. And second thing, at the end of it, the way you enter a health system, it is about cost, communication, and that's what leads to trust. 7 out of 10 don't even understand the prescription. See, that's the only thing they will take from you in healthcare to look up, take decisions on what they have to do as a course of correction for what their problem is. So you can see from this that we asked them, kitne log prescription samajhte hain? 7 out of 10 don't understand it. So I think there are some basics of, I would say, hygiene that we need to correct. And we need to first understand where we are. And look at why people get into healthcare. Why do they go to a doctor? And this has become such a scary thing, and I can confess that even people like me who have been into the health system at highest levels, if we have a problem, we'll try to save time and say, "Theek ho jayega, phir jayenge." When you actually get to a situation when your body stops functioning, or you get into a real scare, then say, "I think we need to do something." So what have we created out of this healthcare? We have to see that. Dr. Reddy, good morning. And I'm happy Dr. Reddy has come, the man who wrote the high-level report for universal health coverage. Acute 42% will go. So just imagine that 6 out of 10 will not even go to anyone. What is happening to them? You think about the fate of those people. 30% of people with chronic diseases. I can tell you, being a diabetic, I am managing it myself for years. Calibrating, even now, I moved to insulin myself. Well, my doctor is a doctor from NHS who actually is one of the best doctors I came across. So what is happening to them? These are actual data coming from the patients. This is the voice of patients. Only 23% people go for preventive care. And I guess that's mostly because companies sponsor it. In our organization, every single person has access to a preventive health checkup paid for by the company. I think that 23% is there. So just imagine the huge opportunity for us to move towards preventive care. And Dr. Reddy must be a happy person, because I think, Dr. Reddy, you said 75% of the budget should go to primary care and prevention, right, in your HLEG? So it is exactly collaborating with the data that we have, because just 23% will go, sponsored by their probably companies or their employers, mandated. And what do you think about quality of care? This is the verdict patients gave. 1 out of 2, fair to poor. So I think quality improvement is one of the fundamental things we have to look at. And then what constitutes quality is another challenge. I've been on NABH for many years, accrediting thousands of hospitals. Dr. Shuchin is on the board of NABH and also runs hospitals. So for us, it is imperative. This is another, moment of truth for us, a mirror for us, that even double digits is tough to get when it comes to quality of care. So just look at where the best of hospitals are supposed to be in metros. 8% believe the care is excellent. Just 8%. If in metros this is a situation, what do we talk about villages? So there is a little contradiction in terms of 40% in village saying excellent. I think it's a question of illiteracy or literacy, whatever you may want to call it. But nowhere, the numbers go like 0, 5 and 8. Just towns is 0% excellent. So we ask people, where do you stay? How do you rate the quality of healthcare? We can't even touch double digits. If we are in healthcare, just imagine what kind of respect we must be getting, what kind of perception people must be having if they come and they pay for the services. Even if you become very, very big person in healthcare, at the end of the day, this is what people are thinking about healthcare. So this is what is communication. 65% didn't receive the communication, that they should on healthcare. In fact, if I look at it, only 1 out of 5 get clear communication about their care. 4 out of 5 don't. So we want to build trust. We want to have people understanding us, but we don't want to give them time to understand. We don't want to explain to them. Whenever I go to a healthcare, I never tell where I'm coming, no reference. Recently, there has been a medical emergency for last couple of months, someone grappling with Alzheimer's. The person is known to us, but we walked as a normal patient. Spending 3.5 lakh in a month, no one tells what is to be done. And the bill could go up to 6 lakhs. No one will tell. Then we say and get a discharge saying it's not going to work for us. So you can pay money, but the only assurance you will have that bill will come on time, rest will not come on time. Bill will come before time, you have to pay the advance, but outcomes are not guaranteed. So this is another moment of truth for people in healthcare. Overall quality rating based on perception, I think almost 80% are saying it's average or poor. And this is what I think I wrote a blog. This study came out, I think we were analyzing it yesterday, that what technology is doing is replacing average care that we deliver. Technology is not doing anything. I mean, you challenge a system, technology will come and try to solve it. So if there's an average care, so technology will try to give you better than average. So we have created a problem that now we are facing. Yesterday I was at a conference and it was all doctors. I said, if doctors created something, they will have to be prepared for it. It looks like getting a stage of irreversible situation where technology will be your first point of contact, doctor will be your second opinion eventually. It's not going to be far off, it's 2028 max. It's not going to be far. It's getting that level of clinical, I would say, accuracy. So we also ask people what are the biggest challenges. This is actual people telling us what the challenges are. So from cost to, I think inequality is not something people relate to so easily because there's no comparative thing, but wait times, trust in the system, lack of information. So it's like 1 out of 2. That's how we are. So people have given their verdict of what they feel about health. As Patients Union, our job is to tell our own system, our own government, our own people in the system that, look, we need to address them. So what defines quality of care? That's another thing. I mean, my interest here is simple that with so many initiatives, I remember when I was at the end, we gave financial incentive for being NABH accredited. You take NABH accreditation, you get 50% extra, one fun 5. But look at what people's verdict is. Doctors' knowledge and clinical skills is 87% feel that's quality care. Cleanliness and hygiene, which is rightly so. Accuracy of diagnosis, 70%. Speed and efficiency, 69. Clear communication, 69. Nurse staff and empathy, 61. We are actually doing, in fact, the largest study ever done in India on role of nurses and what they do in terms of contributing to the outcomes of care in healthcare. Affordability and billing, 56. Just imagine money is coming towards the mid. If you delivered good care, people probably would not have complained of affordability. So you can see the levels at which it is going. And respect for privacy and dignity, 46%. Physical environment, 41%. Of course, we put others as outcome, but we didn't see that. But I think eventually what people are going to look at is, how are the outcomes for which I went to a healthcare facility? I think that's going to be critical. This is also like a paradox. So this is what people have said on one side, hospital billing perception, and this is what 1 out of 2 believe that it's a fully corrupt nexus. Today in the, I think, second half, we are going to discuss one of the panels like, if we started taking doctors at minus scores in NEET, what will this survey show? I am not really sure. So I've asked some of our senior doctors to come and also share their ideas on what we need to think about this situation. So I think the biggest challenge I see that we have somewhere reached a stage of, being irreversible. How do you change this 46% which says there is a fully corrupt nexus? I'm sure that most people don't do that. But some people do it so blatantly that entire system gets painted in the same color. So I think it is something that everyone has to look at, that what do we need to change? And if everyone comes together, hopefully in next 3 to 5 years, we should be able to bring it down drastically. But if we don't, then I can assure you that something is going to replace someone. And that is something that we should be prepared for. So this is NABH, my favorite topic. I think eventually I started coming to believe that, do we really need NABH? I mean, I had put, I think few years back, I asked one of my colleagues to put an RTI that, did NABH ever do a study on the effectiveness of NABH in terms of outcomes? They said, no, we have not done. Then when Atul Mohan Kochar met me, he said, sir, we have after that started the study, but I've never seen the findings so far. I mean, there is a line written in National Health Policy that all healthcare facilities, private or public, should disclose mandatorily the treatment and success rates. I think eventually that's where we'll get to. But NABH is something that they have to reorient, and I think the board member is sitting here. Not intended for you, Sachin, but you landed here at the right time. So what patients want to change? Of course, very clearly, first highest priority is cost, then quality, wait times, communications, information, access to health, policy, governance, accountability, and equity and fair treatment. I think cost is a universal barrier. You have seen whether rich, middle class, poor is same. Communication is a big crisis. Quality gap is gender agnostic. We try to relate whether female and male would have a difference, not actually. And trust deficit is a common denominator across all people that we spoke, rural, urban, age groups, gender. And tech-savvy generation paradox, those who are in that bracket, they have the highest information gap. That's coming actually as our key finding. We can't change that. We have to go by what we see. And of course, enforce patient rights education. That's missing. NABH needs a revamp. I think sooner the better. Thank you so much.
Thank you, sir. Thank you for those words. Those are realities which we have to look up to. And that is one of the reasons why I believe that we have so many people in this room today. Thank you once again. So, before we move into the next session, I know there are people coming in, but I would like to ask a question. How many of you actively use, AI models, AI platforms for health apps in your healthcare journey? Yeah, including me. Okay. Yeah, we have a good number. And how many of you have ever entered your symptoms online to look for a possible diagnosis? Yeah, that's a huge number. Thank you. Thank you. We will be dwelling something about it very soon. Patient-centric is a phrase we hear often. Hospitals put it on their brochures. Pharma companies mention in their annual reports. But what does it truly mean to be patient-driven? What does it mean when the patient is not just at the center, but in the driver's seat? Today's session features real voices, patients, caregivers, and advocates who lived the healthcare systems from the inside. They are political, they are personal, they are policies. The session is not just about listening, it is about ensuring these voices drive meaningful policy changes. A report compiled today's insight will be submitted to Niti Aayog and the Government of India to consider its inputs for incorporating for future healthcare policies. To introduce the speakers and the panelists, I would give a brief introduction and I would request the panelists to join us on the stage. To allow me to introduce the distinguished panelists for session 1. They have come here to share their lived experiences, their stories that need to be used for transformation. No one here is sponsored. Everyone has consented to share their lived experiences. Now I invite Dr. Harsh Agarwal, Project Director, International Patients Union, who will share his own lived experiences within the healthcare system. I request Dr. Harsh Agarwal to join us on the stage. Dr. Aqsa Sheikh, Professor of Community Medicine, Hamdard Institute of Medical Science and Research, who will share about her journey as a transgender doctor. Mr. Arman Ali, Executive Director, National Center for Promotion of Employment for Disabled People, speaking on the challenges faced by persons with disabilities in accessing healthcare. Mr. Ram Narayan, a TB survivor, a plumbing technician, and devoted caregiver to his wife. Mr. Salim Malik, a caregiver to a family member living with ADHD. And Mr. Abuzar Abbas, a student and a remarkable survivor living with HIV/AIDS, metastatic cancer, and tuberculosis. I request all the speakers, all the panelists to join us on the stage, and I request the audience to put a round of applause for the panelists. I request Mr. Ram Narayan, sir, to join us on the stage. I request the tech team to provide the codeless mic. The session will be moderated by Dr. Harsh Agarwal. Over to you, Dr. Harsh.
Good morning, everyone. I'm delighted to moderate this session. So, This session is about the patient centricity and the patient driven. And we all are gathered here together to share our stories, our perspective. What healthcare challenges did we had, and what changes needs to be done? So I'll start with one of my story. So it was during that time when there was a summer of 2013 when I was in the class 10th and my life changed forever. My mother developed pneumonia. Like any family member, I trusted the system. We took her to the reputed hospital. She was admitted, started on antibiotics, IV fluid, and other medicines like bronchodilators. Everything seemed normal until it wasn't. So the blood reports were done. The blood reports came and it showed that the hemoglobin was less than 8 gram. And thereafter, the treating doctor advised that blood transfusion needs to be done. Inherently, we didn't think much. The blood was, but that one step, something so routine in medicine, it became life threatening. The blood was not tested for the compatibility in the way it should have been, which resulted in acute anaphylactic reaction. Her kidneys failed, her liver gave up, and thereafter, even the lungs had pleural effusion, which means uh, the lungs had fluid retention within itself. I still remember the moment when the doctor told us that you just have few hours that your mother will die. I, as a child, imagined the situation, hearing that as a child, but we didn't give up. Day after day, we watched her fight. She went on dialysis, procedures were done, surgery was done to drain the fluid. Machines were breathing for her, she was put on ventilator. But somehow we sustained the positivity. It took around 8 to 9 months for her to completely come out of it. And by God's grace, she is doing well now. That experience has led a permanent mark on me, and that has led me to pursue medicine itself. But with the medicine, with the vision that I pursued, I thought that I'll be helping people, I'll be changing the community, the healthcare community as a whole. But I realized it is not just a person's problem, it is a system's problem. Like while I was doing my MBBS, during the internship, when I was seeing the OPD, so within a single OPD of 4 hours, we were two doctors posted, and we had to see 800 patients. Just imagine 800 patients by two doctors in 4 hours. That's the situation in a government hospital. Now, if we calculate in maths, so that will be less than a minute per patient. So how can we diagnose correctly? I mean, within 1 minute, we can't even hear the complaints, hear the complete symptoms of the patient. We can't show empathy towards the patient. And that is when I feel that the systems need to change. So within the government hospitals, I saw patients waiting endlessly, struggling to get even basic medicines. In one of the cancer hospital where I have worked, the basic medicines like anti-vomiting, diarrhea medications, normal saline even, it was not available. So we used to write letters, we used to ask staff that when are these medicines available, when are these medicines going to be available? But hitherto, we used to tell the patients that these medicines are not going to come, you have to buy it from outside. And imagine a cancer patient getting the medicines from outside, even when they are fighting for the cancer. And similarly, when I have worked in the private hospitals, the situation was very different. They immediately in the interview, they asked how many ICU admissions, how many CT scans. This is your target, 400 to 500 CT scans. This is your target for every month, and you have to reach this. So within each and every government, private, be it anything, there are some things which need to be changed. Because I want to ask you today, is this the healthcare system we are building? A system where one side lacks basics and the other risks overuse. I entered this profession with a noble purpose, but somehow between intention and implementation, something is breaking. Because this is not just about doctors, this is about patients, rights, dignity, and voice. We need accountability in systems, and that is why forums like International Patients Union Conference matter. Because of so, and most importantly, time, empathy, and respect for every patient matters, because at the end of the day, a patient is not just a number, not just a file, not just a target. They are someone just like my mother, and no family member should have this fight to system for fighting for their life. It's time we move from the silence to voice, to action, and to impact. Now, I request our panelists. I'll start with Mr. Armanali, sir. So, since healthcare is expensive and, and even essential aids like wheelchairs can cost up to 7 lakh INR, making accessibility a major challenge. Sir, you represent millions of persons with disabilities facing barriers in healthcare and inclusion. So, what inspired you to start NCP EDP? We request you to share your story and perspective.
Thank you, Dr. Harsh. I didn't start NCP EDP. I'm the executive director of NCP EDP, and we are a cross-disability organization focused on disability rights and inclusion. What was your first question?
So, we would just like you to share your story
No, no,
as well as.
yes, I think okay. The tragedy with disability is that the moment people figure out that you have a disability, you are labeled as somebody who is sick, and the entire world wants you to fix. There's no concept of wellness, for example, in Indian health system. And imagine the plight of person with disability in that way, who are perceived to be sick and incapable, and that word invalid also is used for many purposes in government documents. And for a person like that to get an, for example, if I have fracture, for example, the doctor who's treating me has no understanding of my condition of having a disability and being a wheelchair user. What treatment would he give it to me with my lifestyle? So the onus is everything is on me, like, and you go very apologetically to somebody, even if it is something minor, to get yourself treatment. And I am particularly in NCP EDP, we are very focused on health insurance for people with disability because of, like Dr. Saab presented in the morning, and I resonate with whatever he spoke about the cost of healthcare in this country. And if you look at the data that you have collected, and if you dig into it, sir, you'll find disabled people in them, and the poorest of the poor will have some form of disability. And I didn't have health insurance till 2020, 23, I think so, 24. It took me 7 years to get a health insurance. So 7 years just to get a private health insurance where I am willing to pay a premium. I pay a premium of 40,000 rupees. My health coverage is 5 lakh rupees only. My friend who pays 40,000, his health coverage is 1 crore rupees. So this kind of disparity is I think criminal, and NCP-EDP has been continuously trying to build evidence, and Dr. Gupta is aware, and we did a white paper on health care and access to insurance for people with disability. And in Karnataka, we did 2 studies, and right now, we are about to release another report, similar lines for disabled people in Mumbai city. We spoke to about 750 plus people with disability, and out of this, 80% people earn less than 1 lakh rupees per annum, and they're paying premium more than 40,000 rupees. They have a health expenses of around 5,000 rupees per month. So how do you figure out life? What is the this data which comes to you? It's completely kind of gets you to think, how do you survive? You're not even participating on an equal basis with others. Imagine plight of disabled people, and this came to us as an organization during the COVID times, where everybody was going to get a top up for COVID. We figured we don't even have insurance. So how do you bring the voices of millions of people with disability who are invisible, who are in villages, who are not able to get access to any basic healthcare service? I will bet anyone in this room, if they can get an access to go to any of these government hospitals here. The law says that you are to be treated on priority if you have a disability, no queue, nothing. You won't even pass the security guard, I'll tell you. Forget a doctor, forget it. I think it's in shambles. We must very immediately put disability insurance, including the assistive technology, on priority, and all disabled people, all ages, all income groups.
Sir, I completely agree with your opinions. Since the insurance doesn't cover the disability as much as they do the normals. As Mr. Ramanali sir has said, since the disability, let's say if I have any disability, so definitely the insurance, the premium, that will be much higher, and we need to cater that needs. Thank you, Mr. Ramanali. The intersection of disability and healthcare access is the one that a system has for far too long been ignored. Next, I move to Dr. Aksar Sheikh, Professor of Community Medicine at HIMSR. Dr. Sheikh brings both a clinical and a community lens, leading healthcare transformation as a transgender doctor to make the system more inclusive and equitable to marginalized sections of the society, such as LGBTQ community. Dr. Sheikh, can we please hear your healthcare society story and perspective?
Thanks, Harsh, for first of all thinking about the LGBTQ community when we are talking about patient voices. मैं हिंदी इंग्लिश में मिक्स बोलूँगी तो कई बार क्योंकि जब हम बात करते हैं मार्जिनलाइज या वल्नरेबल सेक्शंस ऑफ द सोसाइटी की तो उसमें ट्रांसजेंडर लोग या क्वेयर लोगों की हम आवाज़ भूल जाते हैं. सो फर्स्ट ऑफ ऑल थैंक यू फॉर डूइंग दैट. एंड इस चीज़ को समझना इसलिए भी ज़रूरी है क्योंकि जब हम ट्रांसजेंडर, गे, लेस्बियन इन सब शब्दों के बारे में बात करते हैं इन द हेल्थ केयर सेटअप तो अक्सर हमारा ध्यान पहुंच जाता है HIV, STI या बहुत हो गया तो सेक्स चेंज सर्जरीज के बारे में हम सोच लेते हैं. और कहीं ना कहीं वही एक कल्पना रह गई है कि एक ट्रांसजेंडर व्यक्ति अगर अस्पताल में आ रहा है तो शायद वो HIV, STI का इलाज कराने या सेक्स चेंज सर्जरी कराने ही आ रहा है. एंड अमिट्स ऑल ऑफ दिस वी फॉरगेट कि उनको भी बुखार आएगा, उन्हें भी ट्यूबरकुलोसिस हो सकता है, उन्हें भी मलेरिया हो सकता है, हाइपरटेंशन हो सकता है, एंड दे कैन ऑल्सो कम फॉर दैट. And very importantly, because of the society in which we live, they are also having a lot of stress that we give to them, and therefore mental health care services is something that they need a lot. And उसकी वजह से डबल वल्नरेबिलिटी हो जाती है. एक तो आप क्वेयर भी हैं और दूसरे आप एक मेंटल इलनेस से भी जूझ रहे हैं और जिसके लिए इलाज मिलना मुश्किल है. और इस बात को समझना इसलिए भी ज़रूरी है क्योंकि अगर हम थोड़ा सा ही पास्ट में जाएं, ज़्यादा नहीं, कुछ दशक पहले ही चले जाएं, तो हम देखें कि ट्रांसजेंडर क्वेयर लोगों को पैथोलॉजाइज किया जाता था, यानी कि इससे माना जाता था एक बीमारी से हम प्रॉपरली ICD में एक डिजीज के तौर पे लिखते थे. इनफैक्ट आई रिमेंबर कि ड्यूरिंग माई MBBS डेज व्हेन आई फर्स्ट got my gender identity on paper, the title given to me was gender identity disorder. और मुझे कहा गया था कि एक डिसऑर्डर है और जब हम डिसऑर्डर कहते हैं तो उसका इलाज करने की भी कोशिश करते हैं और वो इलाज एक कन्वर्जन थेरेपी के तौर पे भी हो सकता है जिसमें हम किसी को स्ट्रेट बनाने की कोशिश कर रहे होते हैं. इस चीज़ को इसलिए भी समझना ज़रूरी है क्योंकि हिंदुस्तान में कुछ सालों पहले तक होमोसेक्सुअलिटी एक क्राइम था और एक क्रिमिनल का इलाज कैसे आप एक डॉक्टर के तौर पे बिल्कुल इक्विटी के साथ कर सकते हैं, ये सवाल हमेशा रहता था. और ये हमारी मेडिकल टेक्स्ट बुक्स में भी पढ़ाया जाता था कि एक सेक्सुअल परवर्जन है. तो उस मरीज के लिए मेरे जहन में चाहकर भी शायद रिस्पेक्ट आना मुश्किल हो जाए अगर मुझे ये पढ़ाया जा रहा है. इन बातों को समझना इसलिए बहुत ज़रूरी है क्योंकि अब हम कानून की भी बात करते हैं ना. कुछ दिन पहले ही हिंदुस्तान ने ट्रांसजेंडर अमेंडमेंट एक्ट पास किया जिसके तहत ये कहा गया कि आपको ट्रांसजेंडर अपने आप को कहने के लिए एक मेडिकल बोर्ड के सामने जाना होगा और वहाँ से आपको सर्टिफिकेट लाना होगा. जबकि हम भूल गए कि ट्रांसजेंडर कोई बायोलॉजिकल चीज़ नहीं है, राइट. और ये इसलिए भी इम्पॉर्टेंट है समझना क्योंकि हमारे मेडिकल करिकुलम में ट्रांसजेंडर लोग कौन है, इंटरसेक्स कौन है, DSD क्या है, ये नहीं पढ़ाया जा रहा है. और जब डॉक्टर्स को ये नहीं पढ़ाया जाता है तो उन्हें कहाँ से ज्ञान मिलेगा. तो अक्सर हम देखते हैं कि या तो बहुत फेटिश हो जाती है उनकी बॉडीज़ की कि हमें ये जानना होता है कि लोगों के कपड़ों के अंदर क्या है, या हम उसको बिल्कुल इनविजिबलाइज कर देते हैं. और ऐसा ही कुछ एक्सपीरियंस मेरा भी रहा जब कोविड के दौरान मैं अपने ही अस्पताल में 10 दिन के लिए एडमिटेड थी एंड आई वाज बीइंग ट्रीटेड बाय रेसिडेंट्स हु वर माय फॉर्मर स्टूडेंट्स जिनके सामने ही मेरा ट्रांजिशन एज अ ट्रांसजेंडर पर्सन हुआ. एंड आई रिमेंबर कि किस तरह से उस आइडेंटिटी को नहीं ऑन रिकॉर्ड लिखा गया जिसकी वजह से कुछ मेडिकल एरर्स भी हुए. एंड दैट इज़ व्हेन वी स्टार्टेड सेइंग कि वी नीड टू टॉक अबाउट दिस, कि हमें इनविजिबलाइज भी ना किया जाए एक तरफ और दूसरी तरफ ये भी ना किया जाए कि हमारे बारे में आप पढ़े ही नहीं या हमें पागल घोषित कर दिया जाए. सो ये सारी चीज़ें बहुत इंपॉर्टेंट है जब हम पेशेंट ड्रिवन चीज़ों की बात करते हैं कि इफ़ आई एम नॉट बीइंग टॉट अबाउट दिस, आई शुड आस्क द पेशेंट, आई शुड लर्न फ्रॉम देयर स्टोरीज। और ये ह्यूमिलिटी भी मेडिकल करिकुलम में पढ़ाना बहुत ज़रूरी है, जो करंटली अभी हमारे इसमें नहीं पढ़ाया जा रहा है। सो इट्स वेरी इंपॉर्टेंट कि अगर हम ट्रांसजेंडर या क्वेयर समाज की हेल्थ की बात कर रहे हैं तो वो उनके साथ मिलकर ही करनी बहुत ज़रूरी है।
Thank you, Dr. Aksa. That was quite insightful. I mean, the intersection of clinical, community, and advocacy to lead a healthcare system where everything and everyone is benefited. Now I move to Mr. Ram Narayan. Access to care has multiple dimensions: geographical, financial, clinical, as well as quality. The presence of a hospital does not guarantee that it is a good healthcare system that is present. A facility that is easy to reach must also be the one that truly heals. We now move to Mr. Ram Narayan, a caregiver supporting his wife through TB treatment. He returns this year to share a follow-up on his journey and the challenges caregivers continue to face. May I request Mr. Ram Narayan to share his experience?
हेलो हेलो। अभी जो ये मैम बता रही थी बहुत अच्छे बात बता रहे हैं, मगर वहाँ सब लोग फॉलो नहीं करता है जी। हॉस्पिटल में आज के डेट में आप चले जाइए, आपका यदि अप्रोच नहीं है तो आपका लाइन लगाते लगाते दौड़ते दौड़ते थक जाएंगे। आप प्राइवेट नौकरी करेंगे, बच्चे पालेंगे कि अपना मरीज को दिखाएंगे। डॉक्टर को उसको जो है पाले तो टेस्टें लेते 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 उनको 6 महीना बीत जाता है, मगर दवा एक भी नहीं चलता है। यदि आपको अप्रोच नहीं है तो एम्स रोड पे मेडिकल हॉस्पिटल में चले जाइए, रोड पे रात भर पड़े रहते हैं, कोई देखने वाला नहीं है। रिपोर्ट जो आती है तो उसको सही तरीके से कोई डॉक्टर समझाता नहीं है। ऐसे रिपोर्ट देखते हैं जैसे नोटों में मशीन गिनती करते हैं, बस रिपोर्ट लिए धड़ धड़ लेकर चले जाते, जाओ चलो सब ठीक है अगले हफ्ते आ जाना, 15 दिन बाद रिपोर्ट एक और टेस्ट होना है। तो ये करते करते जी 8 महीना तो बीत गए, मगर दवा अभी तक नहीं चला। देहाती भाषा में बोलते हैं कि झोला छाप डॉक्टर, जो सीख कर कंपाउंडरी करके जो लोग करते उनकी दवा असर कर जाती है, मगर एमबीबीएस डॉक्टर जो पढ़े लिखे हैं, बहुत बड़े बड़े लोग हैं, उनकी दवाई कोई असर नहीं करी, क्योंकि वो दवाई लिखते नहीं है जब तक उनका 8 महीना 10 महीने जब तक रिपोर्ट नहीं बने। कभी शुगर का जांच, कभी इसका जांच, कभी उसका जांच करते करते 8 महीना बढ़ जाता है। वो बीमारी ठीक होता नहीं है तब तक और बढ़ता ही जाएगा। टेस्ट लेते रहेंगे, 25 बार टेस्ट लेंगे, 25 बार सिरिंज से ब्लड खींचेंगे। 34 किलो मरीज का वजन है, आप 25 बार टेस्ट ले लिए, 25 सिरिंज ले लिया, ब्लड तो बनता नहीं है, तो उसमें मरीज का और बीमारी बढ़ेगा या घटेगा? या तो उसको समझाइए अच्छे तरीके से कि हाँ आपको ये ऐसा ऐसा बीमारी है, इस तरह से इतना टाइम लगेगा, इसको ऐसे किया जाए, तब तो आदमी समझे। वहाँ कोई समझाने वाला भी नहीं है। हॉस्पिटल में चले जाइए, यदि अप्रोच नहीं है तो आपका जो वो अपना कंपाउंडर रखते हैं, क्या है, पैसे वो रखते हैं गेट पे, वो पहले अपने रिश्तेदारों को, दोस्तों को, सबको, रिश्तेदारों को, सबको पहले भर देते थे। उसके बाद जो है आपका नंबर आएगा, वो भी आपका नंबर आते आते बाद में होता है कि अब डॉक्टर साहब का टाइम हो गया, चलेगा जी, अब तो कल आ जाना, तो इस पर टाइम डलवा लो। तो सबसे बड़ा समस्या यह है कि ये पहले जब तक ये सुधार नहीं होगा सर, ये यहाँ कुछ नहीं होना है। प्राइवेट आदमी जॉब करने वाला को भी परेशानी रहेगा। मंत्री लोग हैं, बड़े बड़े हस्ती है, उनके घर पे डॉक्टर पहुंच जाते हैं इलाज करने के लिए, उनके क्या चीज़ की कमी है? लाख रुपया 2 लाख रुपया दे देते हैं, वो लोग पहुंच जाते थैले लेकर के, बैग लेके। मगर प्राइवेट वाला कहाँ देगा कि वो 5,000 500 700 रुपये की दिहाड़ी कमाएगा और 50,000 रुपया कहाँ से देगा वो? तो सबसे समस्या है कि सर ये सरकार को जो है ये सब चीज़ सुधार करना चाहिए, जो कि या तो अच्छे तरह से समझाइए या तो सीधा बोलिए कि इस हॉस्पिटल के अंदर जांच नहीं है गरीबों के लिए। सिर्फ ये मंत्री है, वकील का, जज का लिए है, बड़े हस्ती के लिए, प्राइवेट नॉर्मल आदमी के लिए इलाज नहीं है। तो ये सब सिस्टम पहले चेंज कीजिए, उसके बाद ही जो है इसका कुछ सुधार हो सकता है सर, नहीं तो ऐसे चलता ही रहेगा सर। धन्यवाद सर।
थैंक यू मिस्टर रामनारायण। आपने अपनी स्टोरी शेयर की हमारे साथ, आपके पर्सपेक्टिव शेयर किए, उसके लिए आपका बहुत बहुत थैंक यू। Healthcare today can become extremely expensive. Hospital admissions can alone cost from 1.5 lakh to 5 lakhs, a huge burden for many families. ऐसे में एक आम आदमी इस स्थिति को कैसे संभालता है, ये समझना बेहद ज़रूरी है। We now invite Mr. Salim Malik, who has been the primary caregiver for a family member living with ADHD, a condition that is widely misunderstood and undersupported in India. So, may you please share your story?
थैंक यू डॉक्टर। मेरा नाम सलीम मलिक है। मेरी एक बेटी है मायशा मलिक, जो ऑटिज़म और ADHD से ग्रसित है। जब वो 2 साल की थी तो बिल्कुल नॉर्मल थी सर। और ना वो औरों बच्चों के मुकाबले जल्दी बोलना और जल्दी चलना सीख गई थी, जो नॉर्मली उसे होता है। लेकिन सर धीरे-धीरे एक बार उसे बुखार हुआ। बुखार में मैं उसे ले गया तो उसके हाथ-पाँव थोड़े नीले से पड़ गए और होंठ भी नीले पड़ गए। तो जब मैं उसे डॉक्टर के ले गया सर, तो वो डॉक्टर के जाते-जाते बिल्कुल नॉर्मल हो चुकी थी। लेकिन जब मैंने वहाँ टेस्ट कराया तो 102 बुखार था सर। जब मैंने उसे चेक कराया तो उन्होंने कहा ठीक है, आप दवाई लीजिए, अब हो जाएगा जो भी ठीक है। तो सर वो ठीक तो हो गई 2-4 दिन बाद, लेकिन जब मैंने उसे नोट करा तो उसमें कुछ बिहेवियर चेंज थे सर। जैसे अकेले में रहना, शोरगुल से बचना और अपने टॉयज़ों को बिल्कुल लाइन से लगाना, तो ये मुझे थोड़ा डाउटफुल लगा सर। तो मैंने थोड़ा यूट्यूब पे सर्च करा तो देखा कि उसे ADHD या ऑटिज़म के कुछ सिम्पटम हैं। तो फिर मैंने डॉक्टर के ले गया, डॉक्टर ने बोला दवाई दे दी उसे और बोला कि सर ये 5 कुछ बच्चे लेट बोलते हैं, तो हो सकता है ये थोड़ा लेट बोले। तो सर मैंने वेट करता रहा, 1 डेढ़ साल उसकी मेडिसिन चली। लेकिन सर मुझे डाउट और हो गया, क्योंकि वो और अकेला रहना पसंद करने लग गई और ही ज़्यादा ही चिंतित रहने लग गई और अपने ही में मगन रहने लग गई सर। तो मुझे और डाउट हुआ तो फिर मैंने सोचा अब डॉक्टर चेंज करना चाहिए। फिर मैंने अपना डॉक्टर चेंज करा। उन्होंने बोल दिया कि इसे थेरेपी कराइए। सर मैंने थेरेपी कराई। अब थेरेपी करने के बाद उसमें कुछ सुधार सा हुआ, लेकिन इतना नहीं हुआ जितना मैं सोच रहा था। तो फिर किसी ने मुझे, पड़ोसी ने बताया, आप एक काम कीजिए, आप इसे इबास हॉस्पिटल ले जाइए। मैं इबास हॉस्पिटल ले गया सर। मैं वहाँ 8 बार गया। 8 बार सर मेरी तो कोई सुनवाई हुई नहीं। बल्कि और मैं वहाँ पूरे दिन खड़ा रहता था लाइनों में सर, और पूरे दिन दोपहरी में ही हो जाता वहाँ पर मुझे। फिर एक दिन बाय चांस मेरा नंबर आ गया, मैंने वहाँ चेकअप कराया तो उन्होंने कहा पहले इसकी एक BT थेरेपी होगी, उसके बाद आपको हम मेडिसिन लिखेंगे। मैंने मेडिसिन लिखवाई। उन्होंने कोई सोने की दवाई दी थी, मैं नाम भूल रहा हूँ सर उसका। उसके बाद मैंने BT उसकी थेरेपी का टेस्ट कराया। टेस्ट कराने के बाद उन्होंने कहा कि आप 15 दिन बाद आइएगा। सर मैं 15 दिन बाद फिर दोबारा गया। वहाँ गया तो सर वो डॉक्टर नहीं आते जिन्होंने जो थेरेपी की रिपोर्ट देते। तो सर मैंने कहा वहाँ से आया हूँ, हापुड़ से आया हूँ, फिर दोबारा जाऊँगा। सर फिर मुझे अगले दिन आया तो अगले दिन मैं पूरे दिन खड़ा रहा, लेकिन वहाँ कोई ऐसा व्यक्ति नहीं मिला जो मेरी रिपोर्ट मुझे दे दे। क्योंकि जब लास्ट 2 बज गए तो उन्होंने कहा कि भई अब तो ये ऑफ़िस बंद है, अब आपको ये नहीं मिलेगी रिपोर्ट। तो सर मैं परेशान हो गया, मैंने कहा अब मैं आज के बाद आऊँगा ही नहीं। फिलहाल उसका जो ट्रीटमेंट चल रहा है मीमंस में चल रहा है, मेरठ में। अब सर मैं बताता हूँ इसकी थोड़ा-सा समाज के लिए। सर जैसे हम इसे पार्क में ले आते हैं तो थोड़ा कोई बच्चे जैसे हँसते हैं उसे देखकर, या कोई पेरेंट्स, औरों के पेरेंट्स उसे देखकर थोड़ा सोचते हैं कि हीन भावना लाते हैं। तो सर मैं ये कहना चाहता हूँ जैसे कि वो थोड़ा कम बोलती है, ना के बराबर ही बोलती है। तो सर जैसे मैं देखता हूँ औरों के बच्चे जैसे अपने माता-पिता से ज़िद करते हैं कि पापा मुझे ये चाहिए, मुझे ये एक रंग की चीज़ चाहिए। सर वो नहीं कह पाती है क्योंकि वो बोलती नहीं है। मैं चाहता हूँ कि सर जो कभी मुझसे वो भी बोले, मुझसे कहे कि पापा मुझे ये चाहिए। अब मैं उससे दिलवाऊँ तो मुझे खुश हो या मुझसे लिपट के कहे पापा आई लव यू। इस वर्ड के सुनने के लिए सर मैं रोज़ाना पूरे दिन मेहनत करता हूँ सर, कि वो बोले, कुछ उसमें इम्प्रूव आए। लेकिन सर चल रहा है। अब जैसे कि कुछ लोग होते हैं, हम तो मेहनत कर रहे हैं, हम तो पहले ही इनसे थोड़ा टेंशन में रहते हैं। अब कुछ पेरेंट्स ऐसे होते हैं कि भई ये बोलता नहीं है, ना समझ है। सर आपको पता है जब वो ये वर्ड बोल के जाते हैं तो हम उस रात पूरी दिन सो नहीं पाते हैं, पूरी रात नहीं सो पाते हैं। हम भगवान से ये नहीं कहते सर कि ये बच्चा मेरा नॉर्मल कर दे। मैं ये सोचते इसका फ्यूचर क्या होगा? जैसे बाय चांस अब तो हम हैं, आगे को नहीं होंगे, तो सर उसका देखभाल कैसे होगी सर? इन बच्चों को सर सपोर्ट, प्यार की ज़रूरत है। ये ऐसा नहीं है सर कि ये इनके मन बिल्कुल साफ़ होता है। अब सर कर रहा हूँ जैसे कर रहा हूँ उनके साथ। अब जैसे इबास गया तो सर वहाँ लाइन इतनी है तो सर ये लगता है वहाँ पेशेंट ज़्यादा है और डॉक्टर कम है। ऐसा मुझे महसूस हुआ, पता नहीं ऐसा है नहीं है। लेकिन जब भी मैं गया ज़्यादातर डॉक्टर छुट्टी पे होते हैं, या हम बहुत से मेरी तरह ही मैं देखा हूँ बहुत-बहुत दूर से आते हैं, बेचारे लाइन में खड़े होके चले जाते हैं सर। अब क्या क्या है सर, अब बस कर रहे हैं सर टाइम पास। अब जैसे सर ये बच्चे हैं, मैं सर रोजाना पार्क ले आता हूँ, वो रोजाना कुछ ना कुछ नेगेटिव बात बोलते हैं उस बच्चे के सामने ही सर, लेकिन मैं ढीठ हूँ, मैं फिर अगले दिन फिर जाता हूँ, मैं फिर दोबारा पॉजिटिव के साथ जाता हूँ, फिर दोबारा बच्चों को पार्क में घुमाता हूँ। सर ये बच्चे बोझ नहीं है सर, ये एक गॉड गिफ्ट है सर, ये गिफ्ट भी नहीं मिलता जो इसको झेल सकता है सर। थैंक यू सर।
Thank you, Mr. Salim Malik. Your story reminds us that caregiving for invisible conditions require they carry multiple costs in terms of financial, emotional, as well as social aspects. Now we move to Mr. Abuzar Abbas, a story of extraordinary resilience. Mr. Abuzar has navigated not one, but three serious conditions simultaneously: HIV/AIDS, metastatic cancer, and tuberculosis. His journey is a testament to what the human spirit, combined with the right medical support, can achieve. Mr. Abbas, the floor is yours.
गुड मॉर्निंग सर। थैंक यू सर। सर मेरा नाम अबूज़र अब्बास है। सर मैं एक क्वेश्चन पेशेंट हूँ। सर सबसे पहले HIV हुई थी मुझे, उसके बाद कैंसर हुआ, कैंसर के बाद TB हुई। तीनों का ट्रीटमेंट साथ चलता था सफदरजंग में। तो जब कैंसर हुआ तो मुझे उन्होंने 7 मंथ का टाइम दे दिया था कि आपके पास 7 मंथ हैं, उसके बाद हम कुछ नहीं कर सकते, आप जा सकते हो, आपकी पूरी बॉडी में फैल चुका है कैंसर। उसके बाद मैंने रेफ़र कराया GTB हॉस्पिटल। वहाँ पे डॉक्टर हर्ष से मुलाकात की मैंने। डॉक्टर हर्ष ने मुझे कीमो वगैरह दिलवाई। मेरी 23 कीमो हुई थी, 49 रेडिएशन हुई। सर उसके बाद टीबी की दवाई चली थी मेरी GTB हॉस्पिटल। सर मैं आपके सामने बैठा हूँ ना सर, मैं गवर्नमेंट हॉस्पिटल से बैठा हूँ। सर ये नहीं कि सब डॉक्टर ख़राब होते हैं गवर्नमेंट में। मैं तो अपने आप को बोल रहा हूँ कि सर गवर्नमेंट हॉस्पिटल ने इतनी मेहनत की है मेरे साथ, जब मैं आपके सामने बैठा हूँ। अब जैसे कि अंकल बोल रहे थे कि नंबर नहीं आता, वो नहीं आता, सर मेरे साथ तो हर चीज़ गवर्नमेंट से ज़्यादा मैं यकीन किसी पे करता ही नहीं। सर उसके बाद TB की दवाई चली थी मेरी गुरु तेग बहादुर हॉस्पिटल से। सर लंग्स में TB हो गई थी। उस फिर सर डॉक्टर हर्ष से मैंने बोला था कि सर कैंसर के साथ साथ TB भी है, HIV भी है, इसका क्या ट्रीटमेंट होगा। तो इन्होंने सर सबसे पहले कीमो दिलाई, कैंसर को ख़त्म किया। कैंसर के बाद TB ख़त्म की। सर HIV की टैबलेट चल रही है GTB हॉस्पिटल से, जहाँ से मेरा ट्रीटमेंट चालू है, जहाँ पे डॉक्टर जॉब करते थे। सर आज मैं तो ये कहता हूँ कि सर गवर्नमेंट हॉस्पिटल में डॉक्टर जो होते हैं हर एक जैसा नहीं होता। डॉक्टर हर्ष ने बहुत मेहनत की है मेरे साथ। इन लोगों ने कीमो दिलवाई, सिकाई कराई मेरी, सारे टेस्ट मेरे वहीं पे होते हैं GTB हॉस्पिटल में ही। मैं आज तक प्राइवेट गया ही नहीं, दिल्ली आया जब से। सर मैं एक स्टूडेंट हूँ, BCom स्टूडेंट हूँ सर मैं, यूपी से, मुजफ्फरनगर से। सर मैंने 12th पास की थी कैंसर में ही। सर इधर मेरी कीमो लग रही थी, उधर मैं कैंसर के उसके 12th के एग्ज़ाम दे रहा था सर। यूपी से हूँ सर मैं। सर यूपी से ही मैं BCom कर रहा हूँ मुजफ्फरनगर से। सर
Thank you, Mr. Abuza. So his story is something which is quite, heart touching. Since I have worked in one of the hospital and he was there as a patient. While he was in class 11, so he came to us with a cancer with all the three diseases, TB as well as HIV. We started the treatment, as he mentioned, and thereafter there was this at one point of time when we had to say that the chemotherapies are not working. And thereafter, we did a study, I would say rather a study, because I, along with my senior residents and senior doctors, we concluded that we can start another chemotherapy treatment which was not being utilized earlier. So we started him on the same treatment, and thereafter it has worked wonderfully. I mean, with the metastatic cancer which has spread all over the three organs, lungs, even the vertebrae as well. So it got reduced with the 23 chemotherapy, am I right? So with the 23 chemotherapy of that same regimen, And I highly appreciate his resilience. He was studying. Meanwhile, he was getting treated. He was studying as well. While being admitted in the hospital, I have seen him study. So thank you so much. ये सिर्फ इलाज की बात नहीं थी, ये जिंदगी जीने की एक मिसाल है, जैसे मिस्टर अबूजर ने अपनी जिंदगी जी है. Now we come to Ms. Urvashi Prasad, a lung cancer survivor whose policy expertise is matched by remarkable personal courage. While she is unable to join us in person today, she has graciously shared a video message. Let us hear her powerful testimony.
Thank you, firstly, for this opportunity to share this video for the International Patients Union Conference 2026. Unfortunately, I couldn't be there in person, but it's a privilege to be able to share my thoughts with you. As you might be aware, for those of you who know me, I am a public health professional. I have also worked in the policy space with Niti Aayog as a director in the office of the vice chairperson, and I was there for 8 years. So I worked with all the vice chairpersons, the member health, Dr. Vinod Paul, and also the CEO, Mr. Amitabh Khan. And during this period, I worked on a number of health reforms and also drafting of certain bills, such as the National Medical Commission Bill and the COVID response. I was diagnosed with stage 4 ALK positive lung cancer, which is commonly known as a non smoker's lung cancer, in 2022. So now I've been living with it for about 4 years on a targeted therapy, a pill which I need to take every day, in addition to my supportive medication, of course. And during this period, I've been doing a lot of patient advocacy, specifically in lung cancer, both in India and internationally, with the International Association for the Study of Lung Cancer, where last year I was a recipient of the Patient Advocate Education Award at the World Conference on Lung Cancer in Barcelona. So I wear really all these three hats of public health, policy making, and patient advocacy. Now, I've been asked to address a few key questions, of course, very important questions, but also very broad questions. But here I can only share my answers or responses very briefly. So, I think in terms of healthcare challenges, I think we're facing a lot of challenges with respect to public health and prevention, because that is where I think most of our efforts need to focus. Historically, we've been a very cure focused health system, we've been a very hospital focused health system, and even now we see a lot of investments, both public and private, going into the hospital space. That is important. Of course, we will always need hospitals. But for a country as large as India, as diverse as India, as complex as India, and where we are facing a number of environmental and lifestyle related challenges, we are facing air pollution, water pollution, food contamination. In this kind of a context, most of our focus actually needs to be on public health and prevention, because how many people are we going to be able to treat once they all fall sick and reach the hospital? I don't think we can ever have enough facilities or funds or manpower if people keep coming to the health system in advanced stages of disease, which is what happens currently. If I look at cancer, most people are diagnosed at stage 3 or stage 4, about 75% of patients. At that stage, as we know, the treatment is not only more complex, it's difficult, it is costly, and outcomes are often poorer. So I think prevention, public health, is something which is our biggest challenge and where we need to really invest. Of course, I think human resources for health, so not just the quantity of doctors and specialists, but also the quality. I think that is very important. And I think doctors should also be trained, in addition to the clinical skills, on compassion, on empathy, on how to deal with patients, because I see a lot of tension, growing tension in the health system, a lot of mistrust between patients and doctors. So, this needs to be tackled. A lot of ethical issues and question marks in our healthcare system, which we need to tackle if we need to rebuild that kind of trust that used to exist with doctors. So I think human resources, allied health professionals, nurses, we need to focus on all the different cadres. And of course, the public health cadres. When I was at Niti Aayog, we tried to put a lot of focus on getting states to develop their own public health cadres. I think we still have a lot of work to do on this front, because everything cannot be done by a doctor. There is a lot of work that public health professionals are trained and suited to be doing. So I think that is our second big thing. Thirdly, I think we need much more investment in indigenous research. We need to do clinical trials involving our own patients. We need to come up with drugs, with diagnostics, with vaccines for our own patients. We cannot keep importing expensive drugs which are out of reach for the majority of our population. So we need to invest in indigenous research in a big way. And I think I would also say that for insurance, for health insurance, we need to improve the coverage of modern therapies, immunotherapy, targeted therapies. We cannot keep giving people outdated chemotherapies. We need to give them the latest cutting edge treatments. So I think these are some of the areas which I feel we need to work on, not just the public sector, also the private sector, civil society, and we need very strong patient voices and patient advocates in India. So I really hope that we will be able to see many more such voices in the times to come. Thank you very much.
Highly grateful to Ms. Urshi Prasad. Her courage, both as a survivor and as a policy advocate, is truly inspiring to everyone in this room. Now, Mr. Salim Malik has some more insights to share. So, over to you, sir.
थैंक यू डॉक्टर हर्ष। अ, अभी मैं रास्ते में आ रहा था सर, मैंने देखा कि ऑटिज्म अवेयरनेस के बोर्ड लग रहे थे सर। सर आप एक बात कहना चाहता हूँ, ये अवेयरनेस के बोर्ड सिर्फ बोर्ड तक ही सीमित है, ज़मीनी स्तर पर सर इसका बहुत ही खर्चा है। ऑटिज्म की फ़ीस, डॉक्टर की फ़ीस, मेडिसिन, उसकी रिव्यू फ़ीस, रजिस्ट्रेशन फ़ीस, सर ये बहुत होती है, जो हम जैसे लोग अफोर्ड तो कर पाते हैं, लेकिन सर बाकी खर्चे के लायक और कुछ बचता नहीं है। ये मैं बता रहा हूँ, अपनी जो सोच आया तो मैंने बोल दिया। सर सरकार को मेरी तरफ से सोचना चाहिए ऐसे बच्चों के बारे में, क्योंकि जैसे और डॉक्टर होते हैं, सरकारी डॉक्टर होने चाहिए जो इस विषय में एक्सपर्ट हों, जो डॉक्टर हैं या स्पीच थेरेपी वाले हैं, ऑक्यूपेशन थेरेपी वाले हैं या और सब हैं। सर सरकार को इन बच्चों के लिए थोड़ी सहायता देनी चाहिए, क्योंकि हर कोई अफोर्ड नहीं कर पाता सर इतनी फीस को। मैं चाहता हूँ सरकार से कि यार आप लोगों से कि आप थोड़ा दोहराएं कि या उन्हें बताएं सरकार को कि हर कोई इस फीस को अफोर्ड नहीं कर पाता है, क्योंकि ये जो क्या कहते हैं रोग होता है सर, ये ज़रूरी नहीं कि हम जैसे कोई मिडिल क्लास वालों को, ये कोई ठेला चला रहा है, कोई रिक्शा चला रहा है, कोई फल सब्जी बेच रहा है, इन सबको होता है सर। वो इसका इलाज नहीं कर पाते, क्योंकि उनकी सैलरी यानी कि रोज़ की जो आमदनी है 500-600 रुपये होती है, जबकि यदि वो इस रोग का इलाज कराए तो कम से कम 2000 रुपये रोज़ चाहिए सर। मैं चाहता हूँ सर आप थोड़ा सा ध्यान दें इस बात पर। थैंक यू सर।
Thank you, Mr. Salim Malik. You have definitely raised a good point. Thank you to our extraordinary speakers. I now open the audience for the open mic session. So you can just grab a mic. You can share your story, your perspective. If you have a story about any healthcare system, since anyone in your family, you yourself must have gone to a healthcare. So you can just raise your hand. Our volunteers will provide the mics to you.
Should I get up and speak or?
No, sir, that is completely fine.
Thank you for. My name is Naval Anand and I speak on behalf of the patient community today. I'm a healthcare professional personally, having worked for about 4 decades. And now that I'm into this category, I'll share my own personal experience. I would like to just say that what we always thought, and as I think Salim Malik साहब said कि बहुत सारी चीज़ें सिर्फ कहने की होती हैं, करने की नहीं हो पाती हैं. So I saw that when I became a patient, and I had a incidents which led to quadriplegia and some of the other issues like gut and bladder dysfunction. So thankfully God saved me and I am able to speak. And अब मैं बात कर पा रहा हूँ अपनी आवाज़ से. लेकिन इस जर्नी में जो मैंने एक्सपीरियंस किया जब मैं हॉस्पिटल में था ऑलमोस्ट 2-3 महीने के लिए, तो मेरे को मालूम चला कि बचा तो लिया लेकिन बहुत सारी चीज़ें जो मैंने हॉस्पिटल से ही कैरी करके लेके गया, आई मीन वो थोड़ी अभी तक मेरे को इम्पैक्ट कर रही हैं. और मेरा आउटकम जो है पॉजिटिव था, बट यस आई कैरिड. Additionally, I had to stay for almost a month because of some, Dr. Harsh would agree with me, I got up with Klebsiella. And as Dr. Rajendra said, that hygiene is a very underlooked area in the hospital care system. And I used to be a voice into that before this hit me, and I got impacted. And in real terms, it was a drug-resistant strain of Klebsiella pneumoniae, and I got a UTI. The cascade is that the cystitis, and is still continuing. I have to use the wash area every 2 hours, and it is impacting my life. So, in a way, yes, the stories that I've heard बहुत इंस्पायरिंग है. डॉक्टर आसफा, आपकी स्टोरी मेरे को बहुत डीपली इंस्पायर कर रही है कि मैं शायद और रिस्टोर करूँगा अपने आप को. और आई डोंट नो, मिस्टर अब्बास जी, ट्रूली द एग्जाम्पल ऑफ resilience, I think, and I am trying to work on a resilience, which is the primary need. एक बहुत ज़रूरी है. सलीम भाई, आपका बहुत बहुत धन्यवाद, आपने ये स्टोरी शेयर करी. मेरे ग्रैंड चाइल्ड के साथ ये चीज़ हो चुकी है और मैंने भी थोड़ी पार्टली उस जर्नी को फेस किया है. और राम नारायण जी, बहुत अच्छा आपने कहा. यस, ये अनफॉर्चुनेट रियलिटी है सिस्टम की. जो आपने बोला ये असल में रियलिटी है. जो एक्सपीरियंस करता है उसको पता है ये चीज़. बाकी तो बातें कहने की बहुत सारी हैं.
सर्वे के लिए ऑल इंडिया मेडिकल के अंदर 1 महीना 2 महीने से पहले का आपका डेट नहीं मिल सकता.
बिल्कुल ठीक है, चलिए हम उस बात पे कभी फिर चर्चा करेंगे. एंड अनवानली सर, आई थिंक अगेन आई luckily could save myself from landing into the wheelchair, and I'm sure you have so I have a story which is almost similar, and I'm now trying to be a voice, stronger voice for the people. And I come across where मेरी rehab चलती है. I visit that center for 2 hours, and I'm trying to come back to terms. So thank you very much, and thank you, Dr.
Thank you,
Harsh.
sir. Thank you so much for sharing your insights.
Thank you.
I hope you have good health. Now, can we rotate the mic to ma'am?
Thank you. I'm Sunanda. I'm a developmental pediatrician, and my work largely takes me into the resource-poor peri-urban settlements in Northeast Delhi. And actually, the stories I heard, I resonate well with most of them, because these are the voices I listen to in the community when I go. Even yesterday, when we did an autism awareness workshop for parents, caregivers, in fact, this story of long lines in the hospital and people coming back going again and again. Luckily, of course, we had the professors, the faculty from IBAS in that workshop, and some of the anxieties were addressed. However, it remains true that not everybody gets access easily without an approach, as somebody was mentioning. And plus, the whole system getting computerized perhaps has not helped at this point of time. Digitizing when the people who have to seek services haven't got that kind of a digital literacy has placed a lot of problems on these families, and even to get the dates for the appointments has become difficult for them. So they approach NGOs like us to facilitate, and we find that for children with neurodevelopmental problems, it is a huge issue. It's not that those without problems are having it easy in other hospitals. I think somewhere this is an important issue which can perhaps be tackled by giving good linkages to primary care. The NGOs could actually get access within their neighborhoods from the local government dispensaries or secondary hospitals, for instance, like Jag Pravesh, and all these that we have. They don't have anybody with a knowledge of neurodevelopmental problems. I'm sure that applies to many other conditions as well. Thank you.
Thank you, ma'am. You definitely have raised a good point. That plus the work you are doing, I mean, to help the people, the neurodiverse children and the individuals. Thank you so much, ma'am. Oh, over to you, sir. Can we hear your perspectives?
हाँ, मैं 66 साल प्लस इयर्स मेरी एज है, चार्टर्ड अकाउंटेंट हूँ और BHL हरिद्वार से जनरल मैनेजर फाइनेंस रिटायर हुआ हूँ। 1998 ऑनवर्ड्स मैंने लगभग 24-25 साल डिप्रेशन झेला है, बहुत लंबे समय, और क्योंकि ज़्यादातर बीमारियाँ साइकोसोमेटिक हैं एज पर आयुर्वेद, तो सारे ही डाइजेस्टिव सिस्टम के सारे इफेक्ट देखे हैं। कॉन्स्टिपेशन, एसिडिटी तो नॉर्मल बात है, बट ब्लोटिंग, पाइल्स, प्रोस्टेट, hernia, everything I had seen, and now I am all right. And now I help others because मैंने आयुर्वेद को डेप्थ में स्टडी किया इतने इस सारे पीरियड में। मुझे अच्छे डॉक्टर भी मिल गए जो मुझे हमेशा हेल्प करते थे, और योग और मेडिटेशन, और अब मेरा एम है कि मैं ज़्यादा से ज़्यादा लोगों को सपोर्ट करूं बेस्ड ऑन माय ओन लाइफ एक्सपीरियंसेस। और उस दौरान काफ़ी ह्यूज साइड इफ़ेक्ट हुए एंटी डिप्रेसेंट्स के, विजन पे भी असर आया। उसके बाद से फिर मैंने छोड़ दिया, फिर मैं फोकस इसी पे किया टोटल। और हॉस्पिटल का जहाँ तक सवाल है, इवन आयुर्वेदिक हॉस्पिटल में कुछ प्रॉब्लम मुझे दिखी। फॉर एग्जांपल, फूड हेल्दी नहीं था जो आयुर्वेद के हिसाब से होना चाहिए था, या पेशेंट को जो ट्रीटमेंट आउटसाइड से भी प्रेस्क्राइब किया जाता था उसको हॉस्पिटल सेटिंग में जाना पड़ता था। तो विच आई प्लान टू एड्रेस एज ए इन फ्यूचर एज ए स्टार्टअप फाउंडर।
Thank you so much, sir, for sharing your inputs. I mean, Ayurveda is something as a whole, Ayush. I mean, allopathy has been there for a longer time, but Ayush should be the one which should be integrated. And we will discuss it in further sessions as well. Do we have any more responses? Yes.
Yeah, hello, I'm Dr. Chaya and I work in Shanti Avedana Hospice Care. So I want to share one story. Why? Because I feel that it's very relevant, which is about one patient. So we had one patient, she passed away. She was suffering from CA, buccal mucosa. Actually, there were migrants from other state, and the husband was a disabled person. He had only one limb, and he was an orphan. The interesting part is that she was suffering from cancer, but the literacy, the health awareness, a lot of factors actually determines when the patient, or why the patient, or how the patient approached the hospital. But in her case, it was nil. It was actually she suffered from a fracture. Then the medical care, the healthcare system noticed the cancer. But by the time you have a fracture patient, fracture cannot be repaired because the cancer has been already in an advanced stage, which was actually ignored by the family because of their lack in awareness. Second is that, so this is in a normal setting, this is considered as a very difficult case. You will not touch the patient, you will not operate the patient. So luckily, our sisters, they saw this patient and they told the patient's husband. And once the surgical repair of this thing is, any intervention has been done, come to Shanti Avedana. One more thing is that this person is disabled, and many patients' voice said that it is very difficult to navigate through this whole process. For a disabled caretaker, an orphan with no social support, this is like a mountain Herculean task. I don't know how people are going to do it, but anyway, he came with this wife. It was sad actually. We couldn't do much, and she stayed for a week or so, sister. 1 month, 1 month actually. Only she became aware. She could meet her. She could talk to her. Young children. So I feel that healthcare system, there are a lot of loopholes, there are a lot of failures, a lot of gaps in the healthcare system. But we should also address the structural determinants of the health, which we actually avoid. Because before the patient reaches the doctor, there are a lot of factors. And many have voiced that thing that public health maybe should, because certain things can be remodeled when you address the structural determinants of health. This is what I want to say. Thank you.
Thank you so much, ma'am, for sharing insights. I agree with you. There are multiple dimensions to healthcare system. It starts from the awareness, like ma'am said, and thereafter we should focus upon the hospital, pharmaceutical industry, all the different systems. So, yes, sir.
Thank you. I am Brigadier Dr. Rakesh Datta. I am a ENT surgeon. I am in the army. So I'm not here to tell a story, but I must share something. Last year I was giving a talk in a patient safety conference, the international one, and one of my points was, why are there no patients on the stage? So I think what you people have done as international patient unions, getting patients on the stage to speak, is truly remarkable and something which really has more impact. So today I come as a learner. मैं सीखने आया हूँ to understand various perspectives, so that, as you, Dr. Harshri, rightly said, it's not a question of doctors, it's a question of fixing the systems. So the whole challenge of addressing the system and its weak points is something we need to look at as collaboratively with the patients rather than in isolation. And I think I must congratulate the entire international patient union's thought, as well as the panels and the various discussions, to take not patient-centric, but yes, collaborative. It should be very, very collaborative when we are trying to fix the health system. And I think congratulations for that.
Thank you so much, sir, for your wishes for International Patients Union. There's someone? Yes. I'm happy to see so much responses from the audience member. Yes, ma'am.
Yes. I am actually a PhD scholar from National Institute of Health and Family Welfare. All the narration of all of y'all it resonated with me a lot. I'm a psychologist by profession, and I worked for 3 years with cancer patients in Gujarat. Now I'm in Delhi. Now, I wanted to share in brief about what I felt as a family caregiver. Because 2-3 months back, my grandmother got admitted to the hospital because of pneumonia. But and they said 2-3 days you have to be admitted and you will be going back home. And we were like, okay, we'll be there and we can support her. But after that, they diagnosed her with CKD. After CKD diagnosis, she went for 1 week, she was in the ICU. Then for 1 month, more than a month, she was admitted in the hospital. So all of this, it was like from 1 or 2 days, it went to more than a month. Imagine how the family members are totally hard pressed for time, for doing everything, multitasking. Everyone is running home to hospital again and again. And this is, and then she's actually an elderly person, so more than 80 years. She should be getting Ayushman health insurance as well. But her Aadhaar, but like someone else needs a mobile number and needs to use it, so she cannot get the benefits of health insurance. Private hospital, lack of amount we had caregivers. And then after that, coming back home as well. Now, since 2-3 months, my mother's looking after her. Her health also deteriorated. She had to go for laser surgery for varicose veins. Now I had to rush back from Delhi to Gujarat just to look after both of them. So all the family members get impacted. So it's not one person, the patient.
Thank you so much, ma'am, for sharing your input. I mean, the toll is not just on patients, it's on family members as well. And that should be considered while we are
Healthcare system. Now, the last question, since we are running out of time. Yes, ma'am.
Hello, all the panelists. I'm a final year medical student from Safdarjung Hospital, and you all give a very inspiring and very a thing that we can learn from. So, what I inferred from the 3 experiences that our patients have had, there is a wide variety, like just from my understanding, I hope I'm wrong, that how the rarity, as like the more the rarity becomes of a disease, it gets priority in treatment. As Sir had HIV as well as then it turned to metastatic cancer. He got a better treatment, he got a faster treatment because there is a poor prognosis to that, versus the treatment that Sir's wife is getting for TB, which she has had twice. There is a wide range of waiting time and everything. So how do you think as us as future medical professionals, we can like mitigate this difference and how we can make the health system better, keeping in mind the patient load and the mental stress and the work and personal like relationship, how we should maintain that? Sorry, it got very messed up. So
No, it completely makes sense, ma'am. Thank you so much for sharing your inputs. I agree with all our panelists and even your point of view as a future generation. We should see how the healthcare system should look like. Thank you so much.
Thank you, panelists, for the eye-opening, testimonies, the stories which you shared. I believe there's real impact which is going to happen very soon, and we have leaders sitting here, and I'm sure the future of our nation will be in the right hands. Thank you once again for the speakers. These are the voices from the ground, and if you build a system from bottom-up approach, it will never fail us. The healthcare system is primarily meant to deliver health and not to treat sickness. But should someone fall sick, the system is supposed to bring back the care seeker to health. Thank you once again. A big round of applause to the speaker. And I request the panelists to come forward for the photograph session. Meanwhile, I would request the audience to scan the QR code, which is right in front of you. There's a Mentimeter poll, which I would request the audience to fill it up. And yeah, and I request the, yes, please. I request the audience to fill the Mentimeter poll, and the Mentimeter results will be shown up in the screen in a moment. I request the tech team to, yeah. So these are the voices in the room, and this is what the room thinks, and this is what will go into our outcomes report as well. Yeah. Yes, yes, yes. If you don't find the QR code, you can find the QR code on your line tag as well. Thank you, audience, once again for those engaging sessions. I believe there's more questions coming from you. There's more sessions which is coming up, and we would love to hear your perspective, your stories, your questions. Thank you once again. We move on to another session. We now move to address the next agenda on the care seeker's mind: how to pay for the expenses. Given that now India has 550 million people covered under PMJ, and middle class pay around 4 lakh for medical insurance on an average. So health insurance, two words that are meant to bring peace of mind, yet for crores of Indians, they bring confusion, rejection letter, prolonged waiting periods, and deeply discouraging experience of being let down at precisely the moment they need most help. We should be thankful to the Government of India for providing relief to 3.26 crores claims which were settled in the financial year 2025, worth rupees 94,248 crore. But in the same year, 1,37,000 complaints were filed against insurers, a 41% surge. Coverage and care clearly remain two different things. IRDAI data reveals that 30 to 40% of claim rejections occur simply because patients fail to disclose a pre-existing condition. The question worth asking is, whose responsibility is that disclosure? The patient's or the insurer who sold them the policy? For this vital conversation, I am honored to introduce our distinguished panelist. To chair this session, I would like to call upon Dr. K. Srinath Reddy sir, founding president, the Public Health Foundation of India, and former chair of the high-level expert group on universal health coverage constituted by the Government of India. Next, we have Dr. Sri Vikram Pagaria sir, Director, Strategy and Policy, National Health Authority, handling the world's largest insurance scheme and the largest digital health mission. Next, we have Dr. Suchin Bajaj, founder and director, Ujjwala Cygnus Healthcare, the person who took healthcare to smaller towns. Huge round of applause. Lastly, we have Dr. Amitabh Gupta, Chief Business Executive, ACE Insurance Brokers Private Limited. I request the panelists to join us on the dais. I request Dr. K. Srinath Reddy sir to lead us to the session forward. Thank you.
Thank you very much. Thank you very much. We woke up this morning to some reassuring news that the Third World War is not going to happen. So we can now refocus on whether we can lead long and healthy lives. But in terms of leading long and healthy lives, we have to be very sure that we have systems which are functioning, which will enable us to promote health, to protect and preserve health, and to restore health whenever it is disordered. Indeed, India aims for Viksit Bharat to have a life expectancy of at least 75 years and at least 85 years, and a healthy life expectancy of at least 75 years, which means there's a gap between life expectancy and healthy life expectancy. And while this 10-year gap is generally found everywhere in the world, our attempt should be to try and reduce it. And particularly in women, where the gap between life expectancy and healthy life expectancy is much longer than for men. So there are many issues that still need to be addressed through a health system which must be geared up to deliver on those goals. However, we find that there are still a great deal of concerns. While Ayushman Bharat, which has brought together Ayushman Arogya Mandirs for primary health care, the Pradhan Mantri Jan Arogya Yojana for hospitalized health care being subsidized so that financial protection is afforded to vulnerable groups, the infrastructure mission, which is looking after both healthcare infrastructure and disease surveillance systems, and also the digital health mission, which acts to connect all of these elements competently and to enable and empower people to access healthcare services. All these are elements in place, but there are still some deficiencies and also disconnects which we need to address if we really want to bring about a very committed and competent healthcare system into play. And this is where I believe the call for looking beyond universal healthcare as an insurance-led system to universal health assurance is going to be very important. I think this call was made very clearly about 10 years ago, and now it's being reiterated in the government policy. The idea is it's not just enough to provide coverage on paper, but to ensure that the promised services are indeed delivered in time and with the required quality and in an affordable manner, accessible to everybody who needs it. And that's where the idea of getting health assurance into place becomes absolutely pivotal. And we have a very distinguished panel to address the various facets of these challenges. Now, a lot has been said in the preceding panel about the need for assured and empathetic healthcare. It's also been said it's not easy for people to access healthcare if they do not have connections. And the finger was also pointed at the All India Institute of Medical Sciences, which I had the privilege of serving for a number of years. So let me offer a bit of a defense. It's been an unfortunate feature that All India Institute of Medical Sciences serves as a primary care center for South Delhi, a general hospital for Delhi, and a referral hospital for a good part of North India and other parts of India. This has been the situation till some private tertiary hospitals came up. The fault lies not so much in the overcrowded corridors and overworked doctors and nurses in the All India Institute of Medical Sciences, but in the fact that we have not built an integrated healthcare system which is based on the foundations of strong primary healthcare, both rural and urban primary healthcare, and which is also very well integrated with efficient secondary care, and which only requires tertiary care in a few instances. We also do not have an integrated healthcare system with counter referral or back referral, where people will come back to primary care, where they'll continue the care. So what we need is a strong primary healthcare system, which is providing care at home or close to home, which is providing both chronic and acute care, which is providing continuity of care over time, and also providing connected care to higher levels of care in a bidirectional manner whenever required. Unfortunately, we have not developed that kind of an integrated healthcare system, though we are now trying to use our digital health mission to great advantage in trying to remove some of these disconnects, but we have a lot more to do. And the question was also raised as to whether there is a tendency in public hospitals, particularly and sometimes even spilling into private hospitals, where the rich and the more influential people get prioritized care, and the poor will have to really search for some connections or suffer delays and neglect. This is not a new phenomenon anywhere in the world. It needs correction, certainly, but a British doctor called Julian Tudor Hart called it the inverse healthcare law in 1971. He said the availability of good medical care tends to vary inversely with the need for it in the population served. Those with the greatest health needs often have the least access to high quality care, a phenomenon most produced in market driven systems. The emphasis is on market driven systems, where there is no commitment of public policy to providing assured health care. The market steps in with distortions, and it's well recognized that health and education are market failures, and we need to correct it. But we have also the need for ensuring that the private sector is also brought in, the voluntary sector is also brought in to support the public sector, because we need to use all the available resources. India's healthcare system has evolved as a mixed health system by default and not by design. But all the available resources in society will have to be utilized effectively. And we have a very distinguished panel representing various elements of this, which will address this problem from their perspectives, from their experience, and try and provide those kind of solutions that we can really look at. And certainly, as we are doing this, when we look at the population's needs, we must also look at how we can promote health literacy, nutrition literacy, digital literacy, and insurance literacy. Because without enabling the people with that kind of knowledge, we will be depending entirely on clinical care and cure systems, which are going to be only partially effective. So I hope the panel will address all of these challenges so that we can really provide universal health assurance to the people of India in a reasonable time frame. So to lead the discussion, we have Shri Vikram Pagaria. Sir, your work undertaken with the National Health Authority has been nothing short of historic. Truly, India has now the pride of place in digital health, and many other countries are now trying to emulate India or even try and access India's expertise for building their own systems. With nearly 80 crore Abha IDs registered, the National Health Authority has rendered an extraordinary public service. Building upon that foundation, sir, what is your vision for the next chapter? What are your plans to translate this remarkable reach into a truly transformative, everyday healthcare experience for the Indian patient? You have connected people, but can you also ensure that they get the health care that they demand, desire, and deserve?
Thank you, Dr. Reddy, for the question. In the Ayushman Bharat digital mission that has been implemented since the past 5 years, what has happened till now is that we have been able to put the requisite technology in place, the requisite infrastructure in place. In common language, we have built the roads. What we are now aiming at is we want the vehicles to ply. We want hospitals to use that infrastructure. We want citizens to use that infrastructure. So all of us know about UPI, just the way that UPI is now internalized in our day-to-day life, and whenever we go to any place, we just scan the QR code and it is so smooth. Just the way in which it has solved some of the inefficiencies in the fintech sector, what the motivation or what the immediate next step for us is to create that value so that people use it like UPI. Today, I am in Delhi. Suppose I have to travel to Hyderabad and something happens to me. I don't have to call my wife and say, hey, can you please go to home and get that bag, click those photos and send it to me so that I can send it to the doctor. If I am unconscious, even then the doctor can uh, uh, can can see the health records, um, can see my longitudinal health history, and can provide treatment to me. So, just in the way that digitalization has eased our life in other sectors, um, I had come here from Ola. So I just booked it from my home and came here. So just the way in which it has become so easy for all of us, can we use technology in healthcare and solve some of the, I mean, there are so many inefficiencies in the health ecosystem. We know all our public health hospitals are overcrowded, private hospitals, the access and affordability is an issue. And so many problems in the healthcare ecosystem can be solved. Some of them using technology is the immediate motivation. And some of the work that has been done so far, which I'm very proud of sharing it with you. So many of the public hospitals, you would notice, we have not been able to solve this in AIMS Delhi, but in some of the other hospitals, we have been able to solve this. And what we have done is, when we typically go to a government hospital, we see a lot of people who are just crowding, and the only purpose of that crowd is to quickly get the registration process done. And what happens at the registration counter? Um the patient gives her name, her date of birth, or maybe her age, gender, address, mobile number. All these details are there in your Aadhaar card. So just the way you scan the QR code of a vendor to make a payment, you go to a hospital and you scan the QR code of the facility, and whatever details that are there in your Aadhaar card, they get transferred to the HMIS, the software that the hospital use, and you get a token number 42. And your numbers are displayed there. As and when 42 comes, you go in the queue. They ask, where do you want to show? They will say, the patient will say, I have a problem in my hand. I want to show it to an orthopedic. And then they will print the slip and give it to the patient. The next step is, can we even simplify it? There is RML, there is Safdarjung, there is Lady Harding, there is GVPAN, there is AIMS. The patient, if they want to get an appointment, they can see where they can get an appointment. Can I, like this, just the way we book train tickets, can we have appointments from home? Some of it is going on, but still we know that if you would pass by AIMS at 4 in the morning, there is huge crowd over there, and the only purpose of those persons are to get an appointment in AIMS. Another thing that has really made this possible is the use of artificial intelligence. Um, why is the patient required to go to the counter and say that I have a pain in the hand, and then the counter person refers to them that, oh, it might be a bone problem, so let me send you to an orthopedic. Some patients might be revisit patients, some patients might know, who are educated, they know whom to go, and those who do not, they can interact with a chatbot, share their symptoms, and the system can guide them to the respective OPD. So just like the way we go to what you say, in the airports, we use DigiYatra, we directly go to the security. Just the way like this, I can from my house share my details, share my my symptoms, I can directly be referred to cardiology. Even the example that you were mentioning, sir, is that the AIMS Delhi serves as a primary healthcare center for many people in South Delhi. So with this system, we can also introduce some sort of triage that your symptoms are not too serious. It is better to go to a PHC, and then they get you an appointment at 11 o'clock there, and you go over there. Otherwise, if your symptoms are difficult, the triaging system says that, hey, you go to AIMS. So using technology, we can have such systems, and the main objective or the main emphasis during these upcoming years for us in the digital health mission is to really um, solve some of these inefficiencies, solve some of these pain points, and try to create some use cases which are useful for the doctors, which are useful for the hospitals. Right now, everybody sees this digitization as a burden. They don't want. They say that they are very very busy. They cannot. They cannot write digital prescriptions. There are 500 patients, so even technologies like the patient and the doctor are talking to each other, and the systems are such that they can understand the conversation and prepare a summary, and then the doctor can edit it. So using the way in which we have leapfrogged, developing countries like us have leapfrogged. For example, in the developed country, there were big telephones, then there were pagers, and then the mobile phones came. But in India, we can really use artificial intelligence to directly transfer to mobile phones. We need not go the way in which they have gone. We can directly leverage some of the digital public infrastructure that we have created and use technology to make healthcare more accessible and affordable.
Thank you very much. A short follow-up question. While digital technologies and their application in the digital health mission are really advancing very rapidly, there also needs to be a co-evolution of the healthcare system in terms of the healthcare providers themselves having more familiarity with the use of this, and of people and patients having greater familiarity. How are we actually promoting digital literacy and education among the people who are using it, whether to provide services or to utilize the services?
That's a very important point, and I missed it in the previous remarks. So a lot of awareness is required to be done. For example, if I ask, there are about 50, 60 people in this room, but how many of you know what ABHA is and what is the use of ABHA? I think, can you please raise your hands? We'll get to know how many are aware. And if you are not aware, it's not your fault, it's our fault that the government has not made it easy for you to understand those benefits. So just in the way that RBI कहता है mutual fund सही है, we are also trying to initiate campaigns wherein citizens would be able to understand this, and we find that was not done in the previous 5 years, primarily because the technology was also being made, but we now know that that's a gap that we have to fill. Secondly, sir, what we have also done is we have written to the NMC, the National Medical Commission, to the National Dental Commission, to the Nursing Commission, to the various allied healthcare professional commission, that in your curriculum, if you can introduce a course on digital health, if you can introduce a course on like how to create digital records. So there might be a small course wherein the doctors are given a task of making a digital health record. So the new generation that comes is digital first from the very beginning. They know how to do it. And the rest of the generation that is there, we use tools like the voice to text, um, some assistant, some use of AI technology to help them.
Thank you. Dr. Shuchin Bajaj, as someone who runs a frontline healthcare institution primarily serving government scheme patients, has increased insurance coverage genuinely translated into meaningful utilization on the ground? And given that many patients carry Ayushman cards that private hospitals are not equipped or obligated to honor, what reforms do you believe are urgently needed to make sure that insurance is a delivered service, not a promise on paper?
Thank you very much, sir. And just before I answer your question, I have my Abha ID on my, if you can see it, it's right on my watch here. So, because this is a safety feature I have for myself, because as Pagaria sir said, if you're traveling anywhere, and I keep traveling all the time, we have hospitals in very remote locations all across North India. And the roads in India, we all know, it's kind of a risk that we take every day traveling in cars. So I have this on my wristwatch all the time, that if I have an accident, there should be somebody who could be able to identify me and my medical needs. It's a great opportunity to be sitting here speaking at the International Patients Union conference, because my journey started, and I'm sitting here because I spoke to patients and their relatives a lot, because most of them were my relatives. I was, one of the earliest, the only doctors in the family, which was a family of refugees into India. And they were all struggling with all the issues that were spoken on the stage today, not enough access, कोई सुनता नहीं है, बहुत approach चाहिए होती है. And since I became the first doctor, I became that approach, कि मुझे ही phone करते थे सब लोग कि भाई किसी को heart attack हो गया है, हम दिल्ली ला रहे हैं, किसी को head injury, किसी का road accident हो गया, हम लोग दिल्ली आ रहे हैं, आप मदद कर दीजिए, कुछ help करा दीजिए, bed दिलवा दीजिए, थोड़ा जल्दी करवा दीजिए. So on the one hand, of course, it felt very nice that I was now in such a position where I could, be helpful to all these people. But on the other, it always troubled me that why were these people traveling, 5-6 hours in a hired jeep with a critical condition patient with them, and sometimes they wouldn't turn up. And as Pagaria sir said, at that time, the cell phones were not very common in our usage. So I would keep waiting for them and they wouldn't turn up. And next day morning, I would get to speak to them and they would say, oh, Dr. Sahab, wo to raste mein hi guzar gaya, hum वापस गाँव आ गए अब तो patient. So when I went to the villages to attend the funerals, I had many conversations. Now I know that these things are called design thinking that Stanford pioneered, but I didn't know this term at that time. But my entire journey was shaped by this, that, talking to people in the villages with health conditions. And some conversations completely blew my mind. One conversation was, an old person said, अरे शायद अच्छा ही हुआ ये रास्ते में मर गया, पिछला वाला जो हमारे गांव से गया था दिल्ली, 15 दिन वो रहा हॉस्पिटल में, उसका खेत भी बिक गया, घर भी बिक गए, और फिर वो मर गया. अब देखो उसकी विधवा तो भीख मांग रही है सड़कों पे, कम से कम इस परिवार के पास कुछ तो बचा हुआ है. So this was completely mind blowing, that financial outcomes were as important to this community as physical outcomes. Otherwise, reflexly sitting in this room, all of us would say, अरे patient बचाने के लिए we would do anything. कुछ भी कर लो, patient बचना चाहिए. But it's not the truth for many people in our world. So this is how we started developing this concept of affordable hospitals close to the communities, because both conditions were important, financial outcomes as well as physical outcomes. You should not die on the road, but it should not be that you reach Delhi and then, the whole family dies because the financial outcomes are so bad. So insurance, as you correctly said, sir, we have been champions of Ayushman Bharat, PMJY since the very beginning, since when most private hospitals did not even think of taking it. We were the first ones to take it. The first cardiac procedure was performed in one of our hospitals. When the golden certificates were handed out by the government for high quality Ayushman coverage, out of the first 10, 4 were of our hospitals. So now we run 26 hospitals across 6 states in small towns like Kaithal, Rewari, Bahadurgarh, Kashipur, Sitarganj. Insurance definitely, as you said, has created a massive change. Now, people who were not, afford to do anything at all, at least somebody is paying for them. But the problem is, even if you have PMJY, if you have a heart attack in a town like Kashipur or Sitarganj, is that insurance really going to offer you something, because there's no cardiologist in that entire district, right? So insurance takes care of one A of the various A's that we read about healthcare, affordability, accessibility, availability, accreditation, accountability. So affordability is one part. But then, as you said, quality, timelines, accreditation, accessibility, what do we do to solve that? And the thing, as Rajendra sir said in the very beginning, is the focus has always been on sick care. You also said that primary preventive care is the need of the hour, no? But who's incentivizing that, right? The young doctor from Safdarjung Hospital, when she stood up, she said, and she hit the nail on the head really, because as a resident, I truly hear her when she says the complicated cases, the rare cases will get attention. Because no, hospitals and doctors want to do exciting stuff. And primary care is not really exciting for most doctors, right? Who's incentivizing a person to go sit in a PHC when that doctor is not even confident that that PHC will have an electricity and water connection? They'll have enough transport. What about my safety? What will I do there? है क्या मेरे लिए वहाँ पे? एम्स में तो प्रोफेसर बनेंगे तो everybody will listen to us. It is so exciting that be a neurosurgeon in a top medical institute. Then that is the aspiration everyone has. But who's incentivizing primary and preventive care? And Dr. Rajesh talked about the multiple costs of the disease. It is not just financial, it is emotional, it is a family cost. The PhD candidate from Gujarat talked about how families get affected. It is not just families, it is entire generations getting affected because we are not offering enough quality care. We just talk about direct cost of the disease कि इतना पैसा लगता है जी, इतना खर्चा हो गया इस इलाज पे. Indirect cost, because the families are getting affected, you need, as if you are visually incapable, and India has the highest number of preventable blind people in the world, you also need one full-time attendant with you, right? So it's 2 people who are now out of jobs, not just one. And if you have diabetes, we have around 85 million diabetics in the country. And we know 1/3 of them will end up into kidney failure. We are amputating 1 foot every 5 minutes due to diabetes in India. Now, a patient comes to me with kidney failure and gangrene of the foot. I can pat myself on my back saying, अरे हमारे पास आयुष्मान भारत है, आपका हम फ्री में टांग काट देंगे, फ्री में डायलिसिस कर देंगे. अगर आप दिल्ली जाते तो आपके 5 लाख रुपए लग जाते. But is that 5 lakh rupees truly the cost of the disease? Because now I have taken your leg away, now you're on dialysis twice a week, you can't really go back to work that you were working in the factory or the fields earlier, right? Your future earnings that are lost. Now that cost is something that most people will still recognize. But the intangible cost of the disease, because now you're out of a job, you will pull your children out of school and start sending them to work. मेरे साथ जो ड्राइवर साहब आते हैं मुझे हर जगह ले जाते हैं, तो वो मुझे बताते हैं कि 6th क्लास तक वो बताते हैं सर मैं फर्स्ट आता था 2 सब्जेक्ट में स्कूल में हमेशा, मैथ्स में और सारी रेस में जीतता था और मैथ्स में हमेशा फर्स्ट आता था. फिर मेरे पिताजी सडनली उनकी डेथ हो गई, हमें पता नहीं क्यों. तो माता जी ने बोला कि अब किसी को तो काम करना है तो तुम काम करना शुरू करो. तो started doing odd jobs and now he's driving a car at just a little above minimum wages. If he had been allowed to study completely, he may have been doing something very different.
And this is close to my heart because my father used to sell kites for a living early on. You know, he used to make kites for a living, sell them. Fortunately, he survived for a long time. And I could afford to spend time on study. Even though my college fees was not much, I used to spend, I think, 413 rupees a year for my MBBS fees. And in my MD, I used to earn money actually. But the time that you get to spend without being forced to earn for the family, you know, that is a luxury for most people. Because otherwise, if you're a 20-year-old, you have to start earning. You have to support the family. I did not earn till I was 28, 29 years old. So these kinds of things, I think insurance is very important for sick care, but we really need to understand and prioritize healthcare. And how do we do it? How do we make it exciting enough for doctors? How do we make it exciting enough for governments, for policymakers? Because see, government का incentive है कि aims बना दिए सर हमने 25-30, it is huge publicity, 30 aims हैं, it's a big thing for the government, right? स्वास्थ्य मंदिर, आरोग्य आयुष्मान मंदिर बनाना is not, I mean, they are making it, but it's not, you know, vote catching enough. For the doctors, as I said, working in a PHC, who will do that? I was studying to be a gastroenterologist when all this incident happened, and I dropped out to start hospitals in small towns. My father was so angry at me, he refused to talk to me for 3-4 years. He said, मैं क्या जवाब दूंगा अपने रिश्तेदारों को कि तुम तो बड़े अस्पताल में गैस्ट्रोएंटरोलॉजिस्ट बन रहे थे, अब तुम जाके कैथल और सोनीपत में बैठे हो, इसका मतलब लोग कहेंगे फेल हो गया होगा ये, तभी इतने छोटे शहर में चला गया, वरना तो छोटे शहर से बड़े शहर में आते हैं लोग. I could not explain to him that I dropped out of my own violation. He refused to understand that. He did not visit even one of our hospitals till the day he was alive. Said, पढ़ाई छोड़ के कुछ भी किया, गलत काम कर रहे हो. So how do we make it exciting enough for doctors to go back to villages? How do we make it exciting enough for governments to prioritize primary healthcare? I'll close with a small thing. When we open a heart center in one of the districts we go to, we are usually the first ones to do that, right? अगर हम कैथल में cardiac center खोल रहे हैं, पहले ही हैं. काशीपुर में खोल रहे हैं, पहले ही हैं. Even towns, big cities like, Srinagar, we were the first to offer cancer services. So when we open that, usually the whole town gathers together and we have a meeting like this because, first time a cardiologist is coming into the district, first time a cath lab is being opened. And I asked them only this question, would you rather have a heart attack and be treated very well at this German machine that we are installing here, or would you rather not have the heart attack at all? So unsurprisingly, the answer is always we don't want to have the heart attack. हमें heart attack नहीं चाहिए. But who's incentivizing the doctors, the hospitals to make sure that the patient doesn't have the heart attack? There is no money in it, there is no fame in it, there is no power in it. That is the system we need to change. And I think NHS recognized it in the 1980s when they started prioritizing GPs and nurse practitioners a lot. And when I was studying in London, I read that amazing statistic that, before the GPs and nurse practitioners were empowered, the average rate of admission for a COPD patient was almost once a year. Every year they used to get admitted, be treated by the specialist, go back home and then deteriorate again and come back again. Post this change in the NHS, that I think rate dropped to less than 1 in 5 years. So sick care can truly be completely avoided only if we prioritize the right things.
Short follow-up question. Thank you. Currently, most health insurance schemes are only catering to hospitalized care. Do you think primary care can be brought in and ultimately some model of an integrated insurance package can be developed, like a capitation fee model or something like that?
I truly think that is the need of the hour. We've seen it in Israel where there is a full, end-to-end kind of a subscription model, but very, very small population size. We've seen it in models like the Kaiser. I think the first thing that we need to do to solve for this is build trust within the three main actors in this whole system: the payer, the provider, and the patient. Right now, as Rajendra sir said in his opening address, that trust level is completely gone, right? 46% patients, I think you said, feel that this hospital doctor thing is a mafia, right? They're completely corrupt. So this trust between the patients and the providers, sir saw and showed to us, but there is this mistrust between the provider and the payer also. the government and the third party payers do not have enough trust in the provider. Even in hospitals, there are so many cases of frauds. They feel that if they open it to houses, there'll be no monitoring available at all, and the claim ratio, which is even now very, very unfriendly to the payers, will become completely unmanageable. So, how do we use technology to build that trust into the system is something that I feel has to be at the prime of our efforts. Because, see, I'll ask you a simple question. Who amongst us here have done or know of someone close to us who has ever done shoplifting? Right? I don't think anybody will answer that. But think it in your hearts. सोचिए कि कौन चोरी करके आया दुकान से कभी भी. I don't think any one of us would know even one person, और maybe कोई दुनिया में एक आदमी हमें पता होगा, हमारे 500,000 लोगों को हम जानते हैं उसमें से एक आदमी भी नहीं होगा. But do you know how much that anti shoplifting industry is worth? जो tags होते हैं, जो आप scanners देखते हैं, जो security guards खड़े हैं, जो CCTV cameras लगे हैं stores में, more than $100 billion industry. So prevention overpays and overemphasizes, this kind of fraud system that happens because people feel that inherently there is mistrust. So put in as many resources as you can to detect that, even if it is not very prevalent. So this is right now what's happening. I think with technology, a lot of it can be solved. And if we can solve for it, then I think that will be a game changer for the entire healthcare industry and will truly become healthcare instead of sick care.
Well, that's a great segue to the last panelist, because if you're talking about trying to prevent shoplifting in medicine, quite often you talk about healthcare having become a commercial enterprise. And you pointed out some of the challenges related to insurance as well. Dr. Amitabh Gupta, you bring a truly unique perspective, having trained as a physician and now leading an insurance brokerage. When a TPA or insurer rejects a claim, they're not merely declining a financial package, they are in effect overriding the clinical judgment of a licensed government credentialed doctor. On what authority does that happen? And when the insurer points out to the TPA and the TPA points to the guidelines, where does accountability for that rejected patient ultimately rest? We've seen this happening in the United States with United Health Insurance and sepsis and so on and so forth, where clinicians' judgment were overridden and patients died as a result. Now, I had to different names. I would like to see you defend the insurance industry.
Thank you for having me, first of all. So this is a question which I've been dealing with for the last, I think, 26 years or more, since I started the insurance TPA sector in the country. What we need to understand is a lot of it, in fact, has been spoken. So, I'll come back to the basic thing that we have these three stakeholders. One is the hospital, who wants to maximize their revenues. On the other hand, we have the insurance company who wants to save cost. And thirdly, we have a individual who has two sides. One is the consumer side and the other is the patient side. So while he's at the consumer side, he thinks that let me buy a health insurance product when I need it. And he also thinks that why should I not hide my pre-existing conditions? Dekha jayega jo hoga. See, what they need to understand is that in today's world, some of the insurance companies are covering pre-existing conditions, if they can cover those. And they are saying that there are waiting periods. You wait for 2, 3 years, 4 years, and then, we'll cover those conditions, provided you declare it and we accept the risk. But that is not happening still. It will happen, but it's still not happening. And the other side, when the same person becomes a patient, he goes to the doctor and says, please don't disclose that I have this ailment or a disease before I took the policy. See, that's the basic challenge which the insurance company faces. There's another challenge. He thinks that he's bought a health insurance product, and now he's entitled to all kind of coverages, not looking at the fact that the insurance policy comes with its own terms and conditions, and especially, the conversion of OPD to IPD. So what happens is he thinks, oh, I have to incur these 10, 15,000 expenses on an OPD basis, why I cannot convert this to an OPD, to the IPD thing. So there is this fundamental disconnect. Not every time, but since you posed a question, I'm talking about when we look at these kind of scenarios. So coming back to your question, what happened is that time and again we used to have these small disputes between the healthcare providers, the doctor at the other end, the TPA insurance doctor at the other end, and they used to argue and counter argue. So IRDA actually came out with a dictate saying that, look, let's not interfere in the medical treatment and the medical judgment of the treating physician. He is the supreme guy, and whatever he thinks, should be kind of done. So what today insurance companies do is that they take a guarantee from, on the letterhead of the doctor that this patient is suffering from only this much time, and he actually requires hospitalization. Now, why all this is happening is that, you see, in India, we don't have comprehensive care products. Now, comprehensive care products like in the Western world, which I mean is the OPD and IPD combined products, where some of this problem can be taken away. This is majority, one aspect of the problem. The real challenge lies in the fact that, while dealing with OPD claims, the claims are far too many, and the cashless has to be given at real time. Unfortunately, in the country, nobody has been able to solve this problem and to give cashless on a real-time basis. There are products which talks about, yes, I will give you an OPD cover, I'll give you an IPD cover, but nobody knows how to give cashless for an OPD. And that is the reason as to why these products are not selling and they're not even popular. So once we have something come up digitally for the country, yes, this problem is going to be resolved sooner or later. The other aspect is that we don't have a connected healthcare ecosystem in the country. Now, look at the TPA doctor or an executive who has to dispense of or undertake a guarantee of lakhs of rupees on behalf of the customer and on behalf of the insurance or the organization per se. And they have to do it in 15 minutes, half an hour. And they have to look at all aspects. And, they have to ascertain that this claim is payable. But where do they get this prior information of, prior hospitalizations or whether this patient is normal or not, or, he had any prior diseases? So there is nothing. There's no data, no connected ecosystem. Once that happens, you see majority of the problems will go away, to be very honest with you. Now, coming back to the segments, there are three type of health insurance consumers. One is when we look at mass policies, when we look at Ayushman Bharat and other government, sponsored schemes. There, the challenge is that of a fraud, which takes place, which is rampant. And the other is unbundling of packages. So these are the two main, areas where the challenge is. When we look at group schemes In group schemes, most of the group scheme pre-existing diseases are covered. So this particular aspect of, whether the disease was prevalent or not before taking the policy does not arise. The only challenge is whether it was an OPD case converted into an IPD case. So most of the challenge actually comes when a person holds a retail policy or an individual policy, because there is nobody to, at the back end. He has to fend for himself because he's purchased a policy. And there, the challenges are both OPD to IPD and of course, the pre-existing diseases. So these are so major challenges are faced when there is a retail policy in place. So my suggestion to the audience is that, buy an insurance policy early and hold it. Don't change your insurance company. Don't change your insurance company, because see, what happens is loyalty ultimately pays off. If after 10 years you hold an insurance policy with one particular insurer, and then on the 11th year you change it to somebody else, and there is a claim, God forbid, the challenges come there.
Thank you. Maybe some of the problems that you posed are being addressed by your two co-panelists.
Yeah,
There you
sure.
have ABHA, and then there you have much greater connectivity to smaller hospitals elsewhere too.
Correct.
So I think all of those issues are being addressed, but we need to bring them together.
Absolutely.
Thank you. May I now open up for questions and comments from the floor? Please, sir.
I request the volunteers to pass on the mic.
Hello, I am Colonel Ajay Tomar. Am I audible? Yeah. From Indian Cancer Society. Now here we have lot of survivors, cancer survivors, who have overcome cancer as a disease for 5 to 10 years, but they don't get any insurance policy. Even if they get, the premium is so high that they can't afford. So cancer is treatable, curable. Diabetes, BP, these are not curable, but they get cover. Cancer patients don't get medical cover. Is there any particular reason, or how we can go about it?
Sir, it is all about representing. See, I heard that, because of disability, people are not able to get insurance coverages. You see, a few years back, we had Ayush, department from the government come up to me and said, they said, why is Ayush not covered? We represented to IRDA, we formed a panel, and it took us 3 years to get our own system of medicine covered under insurance. But here it is. So there is a solution to everything. First, we need to understand that the health insurance premium in our country are amongst the lowest in the world. We are very, very fortunate, let me tell you, that the health insurance premiums are rising, but they are still the lowest in the world. If we talk about, survivors of cancer, yes, of course, if there is no recurrence, I mean, there has to be insurance companies who will become bold enough to cover such kind of, patients in the future. We, some time back, people were not ready to cover anybody who entered the health insurance segment or as a consumer above 60 years of age. But then we have now policies who are trying to cover elderly care also. And then we are also going to cover, probably in some course of time, post-hospitalization care, elderly care. The problem, I would close this by saying that the biggest problem in our country is there is nobody to guide the insurance companies that this is the actual data. This is how much it is going to cost you to cover a patient of this nature. And once they are convinced that they are not going to lose money badly, there will be products and there will be a future insurance cover for such kind of people.
Thank you. Is that a follow-up question to this? Okay.
years I'm cancer free. I have now each and every insurance company though and they are not giving me the cover. And the agent says, yes ma'am, we will give you the cover. But when we ask them to give us the guarantee or on paper, and they ran away. They don't give me the covers. Since I'm 18 years since now, I'm cancer free. But no company is giving me the cover.
I think he has already spoken about it, but I think you should also take it up with the IRDA, the Insurance Regulatory and Development Authority.
We can take one more question.
At the back, please.
Thank you, sir, for giving me the opportunity to speak. Good morning, everyone. This is a wonderful panel. I am Amrita. I'm a trans woman. I work for my community almost like 25 years and also for the people who use drugs, the sex workers, people living with HIV. I agree with all the comments and experience you have shared, but I also like to highlight some critical areas. For example, the Ayushman Bharat card. If I talk about my community, recently this has been started, like 2 or 3 months. The problem is actually not the implementation of the digitalization process, but actually the allied services. If I talk about that, if I refer my community to give the names of the hospital where this Ayushman Bharat, all these things, but they are telling me that almost like most of the 50% of the name are given actually in the sites. Those are either do not have the infrastructure, do not have the experts to deal with such situation. So that is one part I would like to share, is the government to look out. And also, as I was telling you, that this is not a single entity, it should be a 360-degree approach. I mean, currently all of us know that for the transgender community in India, we are having severe problem. So many things have been changed, like in the recent this 2026 bill. And government is trying to impose medical boards to prove whether I am a trans person or not. So in such situation, things are going to much difficult now. So I think Bikram says, all of you have to reach out to the organizations, community-based organizations who are actually suffering. I really appreciate that you are serving in the rural area, but also please highlight the people who are underserved, people who are marginalized. Thank you so much.
I think the point is well made that all marginalized, underserved, vulnerable communities must be included if we want
Can I just
universal
say
health coverage to be truly universal.
Can
Yeah,
I just
please,
say one
please, please.
sentence? So that the problem that you highlighted, that on the website where they can see the details of which is the nearest hospital where I can take a treatment if I have an Ayushman card. So a lot of hospitals are displayed, and when the patient actually goes over there, there is denial that we don't treat Ayushman patients, or some of the hospitals, they would treat Ayushman patients, but they would not treat the senior citizens who are now like over 70 and above. They are also covered, but since the cost of treatment is more, so the denial is there. So over there, to advise and perfectly aligned with what you are saying, that we need to work more with associations and with the community. But if you can help in also percolating this, 14555 is the call free number, whatever grievance that you have. And there is a category of grievance where we have a dashboard which we call as SOS grievance. So if somebody says I'm denied treatment, then those have to be fixed in 6 hours, and that escalation is monitored at the highest level. So whenever these things happen, please use this toll-free number. Please also write to this highlighting that problem. Might be that patient's problem might not be solved due to this, but other patients would not face this situation.
Thank you very much. That's a very useful
Thank
service.
you. Thank you, audience. We'll be giving you further chances for Q&A. As we have time constraints, we'll be moving forward. Thank you again, panelists, for this wonderful session. I request the audience to fill up the Mentimeter poll, and I request the tech team to showcase quickly in our screens. Meanwhile, I request the panelists to join us for the photograph session. I request the audience to give a huge round of applause for the panelists. Wonderful session. Thank you, panelists. Thank you for this wonderful session. I request the audience to scan the QR on your line tag or on the table, and please fill the Mentimeter poll. Thank you. Tech team, can we display it on the screen? Yeah, the next question. I request Dr. K. Srinath Reddy sir to remain on the dais as we have a special segment coming up. Thank you. Ladies and gentlemen, I'm honored to make a special announcement. In our journey from coverage to care, we need models, proof that a better healthcare system is possible, and today we are proud to present one such effort. The report, Moving from All for Few and Few for All to Healthcare for All. I had to practice this twice, thrice tonight, today, yesterday. So again, I repeat, all for few, few for all, to healthcare for all, through new AIMS model builds on the vision to the National Health Policy to achieve health for all through a practical, cost-effective, and scalable model. It addresses the current imbalance in healthcare access where quality service are limited to few, placing a heavy burden on the common population. Drawing inspiration from AIMS New Delhi's global recognition, the report proposes the new AIMS model, a framework that can be adopted at the district level to deliver world-class healthcare across India, ensuring equitable, accessible, and high-quality care. I request Dr. Rajendra Pratap Gupta, sir, to join us on the stage for this launch. Yeah, I would request Dr. K. Srinath Reddy, sir, to speak a few about the launch, and then followed by sir.
Whatever we speak, we already spoken a lot. Go ahead.
I think that we can do the launch.
Yeah.
So before the launch, I'll call Ms. Akshita Tyagi, International Patients Union, Associate Project Director of International Patients Union, to join us for the launch. Audience, huge round of applause as we are launching a huge impactful report. Yes, thank you, sir. Thank you so much.
We have digital and physical both.
Yeah, we have digital and physical both. This report can be officially accessed in our Health Parliament app. I request the audience, if you want to read the report, if you want to go through the report, please go to our website, Health Parliament website, Health Parliament app. You will be able to access the report. Thank you.
I have not had the privilege of reading the report, but what Dr. Gupta has mentioned is that AIMS essentially should serve as a model of ensuring that high quality services are provided both with a public sector mindset, but with accessible quality of a private sector standard, and ensuring that those who can afford to pay are provided care in some of the private ward services of AIMS, whereas the wider population gets free or highly subsidized care. He feels that we should be really looking at blended models like this to be evolved for India. Certainly, India's healthcare sector has evolved into a mixed healthcare model by default and not by design. We have a fairly strong public sector since the inception of India, but it grew weaker because of lack of adequate investment, and it decayed and declined in its presence and impact. And the private sector came in to occupy much of the vacant space, filling the vacuum, but that has been mostly in some of the larger cities and in the tertiary care sector. Primary care and secondary care does not see the same level of private sector presence and impact. But certainly, I think what Dr. Gupta is suggesting is we should be really looking at a mix where both are available with assured quality and access, where there is a substantial element of public service type of engagement, but also where those who can afford to pay will be made to pay by providing services which some of the private healthcare hospitals are currently offering. So whether that kind of a mixed model can evolve or not, I've yet to read the report. I cannot really comment much more on that. But ultimately, we'll have to find out how best to utilize all the available resources in our society. The private sector exists, the public sector exists, the voluntary sector exists. What we need is the public sector to be more responsive, the private sector to be more responsible, and the voluntary sector to be more resourceful. If we do that, we'll achieve a mix for India so that we can utilize all the societal resources that are available to provide healthcare of high quality to everybody who requires it. And by high quality, I define with 4 questions and answers. We have to answer those questions. Is the care that's being provided effective? Is it safe? Is it resource optimizing in terms of both financial and human resources? And is it satisfying to the patients, families, community, and to the healthcare providers? We want this kind of disconnect and dissatisfaction that provides a conflict between healthcare providers and the people who are receiving healthcare to disappear. We don't want a confrontational situation. I believe we all should feel that we are part of a healthcare system which is efficient, equitable, empathetic, and economically efficient. So to build that kind of healthcare system, I think the kind of models that are being proposed need to be carefully examined and see how they can actually serve India's healthcare needs well. Dr. Gupta, you are a very forward-looking thinker. I'm sure there must be wonderful ideas that are embedded in this report. I would like to read it with great interest, but even in advance, let me applaud you for your vision and your vigor. Thank you very much.
Thank you, Srinath, sir. This report is not just an academic document. It is call to action for policymakers, hospital administrators, insurers, and civil society to rethink how public healthcare can be delivered at scale with dignity, with quality, and with accountability. Thank you once again, audience. We now break for refreshments. Tea and coffee are being served at the foyer. Use this time well. The person sitting next to you might be building something which to the problem you'll be discussing on. So this is not just a break, it is an opportunity. Network wisely, and we will be commencing with the next session sharp 12. I request all of you to be back on time. Thank you once again.
More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 100 leaders trained. Executive leadership program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional development program in digital health for nurses. Accredited by the Indian Nursing Council with 50 CNE hours and 10 CNE credits. Professional development program in digital health for pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. You're learning your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in. Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online. And self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace from anywhere in the world. More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 100 leaders trained. Executive Leadership Program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional Development Program in Digital Health for Nurses. Accredited by the Indian Nursing Council with 50 CNE hours and 10 CNE credits. Professional Development Program in Digital Health for Pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. You're learning your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
This is not just a summit. This is where the future of healthcare takes shape, where conversations move beyond ideas and turn into real-world implementation. From powerful discussions to actionable insights, from innovation to execution. Welcome to the world's most impactful summit on digital health. Keynotes that went beyond insights towards real impact. A global platform bringing together global leaders, innovators, policymakers, and change makers, all working towards one goal, transforming healthcare. This is where collaboration meets opportunity, where vision becomes reality. Join us on 20th and 21st of November at Bharat Mandapur in Delhi for GDHS 2026. Theme: Implementing Artificial Intelligence, AI in Action. Be a part of the movement that is shaping the future of healthcare.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare already use those minutes with the health element. Are you? Research proves it. 70% higher retention with daily micro-learning. 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead it. You don't need more hours. You need smarter minutes. Learn smarter. Grow faster. Lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, policymakers, and industry leaders in a shared digital space. The app offers a robust set of features to empower users: disease-specific communities, a unified discussion feed, access to authentic resources, voice-enabled support, and patient-reported outcomes, or PROs, a first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes, along with the ability to post anonymously. Fast forward to 2024, IPU held its annual conference, focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to NITI Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first IPU fellowship, designed to transform patient experiences into actionable policy recommendations. At the 2025 conference, held at the India International Center, IPU unveiled enhanced versions of the app, the fellowship, and the One Health report, reaffirming its commitment to patient empowerment and systemic reforms. Over the last 3 years, International Patients Union has been steadfast in its pursuit to create inclusive digital platforms for patient engagement, enable patients to shape and participate in healthcare policy, and drive systemic change through collaborations, advocacy, and storytelling. Join us and become a part of the Change Initiative.
Academy of Digital Health Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online and self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace from anywhere in the world. More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 100 leaders trained. Executive Leadership Program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional Development Program in Digital Health for Nurses, accredited by the Indian Nursing Council with 50 CNE hours and 10 CNE credits. Professional Development Program in Digital Health for Pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. You're learning your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
तो मैं यहाँ पे longevity versus heal, welcome back. Then I'll say I request tech team to play the concerned video for the same. उस पर वीडियो प्ले करनी है.
वही वाले है ना वो बंदा पार्लियामेंट में
वो इंश्योरेंस और सेशन ये longevity इसमें पेशेंट वो वीडियो अच्छी थी.
जेन्युइन
Minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, policymakers, and industry leaders in a shared digital space. The app offers a robust set of features to empower users: disease-specific communities, a unified discussion feed, access to authentic resources, voice-enabled support, and patient-reported outcomes, or PROs, a first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes, along with the ability to post anonymously. Fast forward to 2024, IPU held its annual conference, focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to NITI Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first IPU fellowship, designed to transform patient experiences into actionable policy recommendations. At the 2025 conference, held at the India International Center, IPU unveiled enhanced versions of the app, the fellowship, and the One Health report, reaffirming its commitment to patient empowerment and systemic reforms. Participate in healthcare policy and drive systemic change through collaborations, advocacy, and storytelling. Join us and become a part of the Change Initiative.
Academy of Digital Health Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online and self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace. More than 100 leaders trained. Executive Leadership Program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional Development Program in Digital Health for Nurses, accredited by the Indian Nursing Council with 50 CNE hours and 10 CNE credits. Professional Development Program in Digital Health for Pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. a 12-week global course. Diploma in Global Digital Health, online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. You're learning your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
This is not just a summit. This is where the future of healthcare takes shape, where conversations move beyond ideas and turn into real-world implementation. From powerful discussions to actionable insights, from innovation to execution. Welcome to the world's most impactful summit on digital health. Keynotes that went beyond insights towards real impact. A global platform bringing together global leaders, innovators, policymakers, and change makers, all working towards one goal: transforming healthcare. This is where collaboration meets opportunity, where vision becomes reality. Join us on 20th and 21st of November at Bharat Mandapur, New Delhi, for GDHS.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare already use those minutes with the Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning. 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours. You need smarter minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, policymakers, and industry leaders in a shared digital space. The app offers a robust set of features to empower users: disease-specific communities, a unified discussion feed, access to authentic resources, voice-enabled support, and patient-reported outcomes, or PROs. A first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes, along with the ability to post anonymously. Fast forward to 2024, IPU held its annual conference, focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to NITI Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first IPU fellowship, designed to transform patient experiences into actionable policy recommendations. At the 2025 conference, held at the India International Center, IPU unveiled enhanced versions of the app, the fellowship, and the One Health Report, reaffirming its commitment to patient empowerment and systemic reforms. Over the last 3 years, International Patients Union has been steadfast in its pursuit to create inclusive digital platforms for patient engagement, enable patients to shape and participate in healthcare policy, and drive systemic change through collaborations, advocacy, and storytelling. Join us and become a part of the Change Initiative.
Academy of Digital Health Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online and self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace from anywhere in the world. More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 100 leaders trained. Executive leadership program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional development program in digital health for nurses. Accredited by the Indian Nursing Council with 50 CNE hours and 10 CNE credits. Professional development program in digital health for pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. You're learning your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
Welcome back, everyone. We are refreshed and are ready for the third conversation. I would request tech team to play a video. So these are just some snippets that we have brought for you specifically, where we have asked patients about their experiences as a whole.
को कोलोन कैंसर है पेट का दरअसल में जब अपनी इलाज कराने के लिए आते हैं, इलाज तो सही चलता है, पर कई बार ऐसा होता है दवाई है बाहर से लानी पड़ रही है, कीमो का इंजेक्शन हो गया। अगर डॉक्टर सिटी स्कैन लिख देता है तो सिटी स्कैन होता है 2 महीने बाद की डेट मिलती है, वो रिपोर्ट मिलती है उसके 1 महीने बाद सिटी स्कैन के बाद, यानी कि सिटी स्कैन में पूरा 3 महीने लग जाते हैं। यही काम हो जाता है कि आप अल्ट्रासाउंड कराने जाओ, 1-1.5 महीने की डेट देंगे, उसके बाद 15-20 दिन बाद रिपोर्ट आएगी, तो पूरे 2 महीने लग जाते हैं। तो थोड़ा इन चीज़ों में प्रोसेस में सुधार होना चाहिए। बाकी डॉक्टर वाइज सही है, इलाज भी सही चल रहा है, पर अब कीमो की दवाई जो होती है, जो कुछ दवाइयाँ होती है कीमो की, वो बाहर से लानी पड़ रही है। तो नंबर ऑफ पेशेंट बढ़ते जा रहे हैं तो दवाइयाँ का स्टॉक कम है। तो यही है, थोड़ा दवाइयों का कीमोथेरेपी की जो दवाई है वो रेगुलरली आनी चाहिए, क्योंकि बाहर से कीमो का जो इंजेक्शन है वो काफ़ी महंगा आता है, 500 का आता है, तो एक साथ 12 इंजेक्शन लगते हैं, तो अराउंड अराउंड वो 2,500-3,000 के आराम से पड़ जाते हैं एक बार में हमारे। तो यही दरख्वास्त है कि थोड़ा सा इम्प्रोवाइज होना चाहिए सिस्टम।
So these are another patient stories rather. There are everywhere, every community has the patients. And with the next session, as we know, India is aging. And by 2050, we will have over 340 million people above the age of 60 years. And the question we must ask is, are we adding years to life or the life to years? HALE, Health Adjusted Life Expectancy, asks a hard question. Of all the years we live, how many are truly healthy? And for India, the answer is not comfortable. India is living longer, but is India living better? We rank 125th in the world for life expectancy, 3 years below the global average. And while our life expectancy touches 70, our HALE, the years spent in genuine good health, is just 60 to 62. That gap of nearly a decade is not a stroke, it's not a static. It is 10 years of suffering, dependence, and diminished dignity. With 340 million Indians set to be above 60 by 2050, this is not a future problem. It is an urgent and a present one. So today's panel, the next session's panel, brings together cardiologist, pediatrician, geriatrician, and research scientist to unpack the session, to unpack the questions and chart what India must do differently. This session is moderated by Dr. Dharmesh Lal sir. To discuss the session, I would like to invite on the stage Dr. Nitish Nayak, Padma Shri Awardee, Senior Consultant, Professor of Cardiology, AIIMS New Delhi. Sir, can we have you on the stage, please? Dr. Vinod Kumar, Senior Consultant, Aging, Geriatrics and Diabetes, Patron, Indian Academy of Geriatrics, former Professor, AIIMS New Delhi, former Professor and Head, Endocrinology, PGI Chandigarh. Sir, please can we have you on the stage? Dr. Neela Mohan, National President, Indian Academy of Pediatrics, Head of Pediatric Gastroenterology, Medanta. Ma'am, we request your presence. Dr. Dharmesh Lal, Scientist E, Indian Council of Medical Research, ICMR. Please give a round of applause for our panelists for this session. Thank you, panelists, for joining us for the session. Now I request Dr. Dharmesh Lal sir to set the context and take up the session.
Thank you very much, and good morning, everyone. So now this session is very, very important as far as quality of life is concerned. And as already said by Anchor, with the supplementation of lot of data, and that though we are living, now Indians are living around 73.4 years of life, there's a life expectancy. But the quality of life that is without diseases and injury is around 63 to 64 years. So full decade of life is not of quality life. So that is a big challenge coming up for us as an Indian. And though already we have other models in other countries like Singapore, which is having the highest hail in the world as per the latest WHO data, which is 76 years. And as I said, India is 63 to 64 years. So we have a decade to catch up with the topmost model before us. And then it is followed by Japan, not far behind, around 75 years. And the third is Spain, which is around 73.5 years. So as far as this gap of 1 decade is concerned, to meet the quality of life, there are certain issues which we are still grappling with. Though the government of India has introduced a program under Ayushman Bharat, particularly for rural India, where everybody 30 and 30 plus needs to be screened, particularly in the rural setup, for at least for diabetes, hypertension, and cancer. But we do not have still a system which is very robust system where we do have a universal quality health screening for each one of us. Even we people sitting in this auditorium may not be having that provisions for us, though we may be doing proactively on our own, but we do not have a systemic provision to get screened, to have a follow-up, and to ensure the compliance. So now the issue with this session is now how to come up with the intervention which can address these issues and challenges so that we narrow down the gap of a decade and come closer to the topmost country like Singapore. That is my wish and dream also. So over to Dr. Vinod Kumar sir. So over to Sir Dr. Vinod Kumar sir for your comments, and I would like to know, and the audience as well. So what could be the provisions for addressing these issues to reduce that gap of 1 decade, as I mentioned? Yes, sir. Yes, sir.
Firstly, my grateful thanks to Team IPU for making me a part of this mega event. Living not only longer but also better is the cherished dream of humankind. Is it on slideshow? Yes, correct. So, I think most people realize the complexities of giving care to elderly people. Starting from the caregiving strategies, you would probably agree with me that the geriatric population is requiring the maximum number of settings of care, beginning with self-caring, home caring, hospital caring, day caring, or end-of-life caring, hospice caring, palliative caring, caring in old age home, caring through rehabilitation, and so many other settings. So they are requiring care all over the various care settings. Secondly, healthy aging practices for living longer and living better are a lifelong process and not just at the time when one is stepping into old age. Thirdly, one of the problems with which the elderly people are to reckon with is the very costly treatment in the form of hospitalization, in the form of medication, and also in the form of costly insurance products, although they are the cheapest in our country. And also they are subjected to a very many unnecessary investigation which also costs money. So there is an issue about health economics for the elderly people. Fourthly, there is some kind of a societal discrimination, sometimes amounting to neglect against the elderly people across the world, not only in India but across the world. And also, there is a phenomenon called geriatricism, which is a dangerous institutional and professional aversion to caring the elderly people because it is not a very respectable and money making specialty. So I think there is a need to prepare trained geriatricians as we have wonderful specialists from other across the discipline. Then the last two I am going to briefly discuss here because they are concerned with living better and also they are important for creating an ecosystem for geriatric care across the country which is easily understandable and easily deliverable. This is the called 5 M's of geriatrics. This is a communication system through which geriatricians would like to disseminate the complexities and the priority areas which should be addressed in the geriatric care. I might like to add here that this communication system of geriatric care is not only concerning geriatricians, but we are always requesting the other wonderful specialties to adopt this system because most of their patients across various specialties are elderly people. So this is not only a domain of geriatricians, it is a domain of all the specialties. And to make this as a summary version, most important thing matters most. By matters most, I mean to say that we have to find out what are the aspirations and goals of the elderly people when he comes under your treatment. For him, intervention is not that important, rather independence is important. He has more importance to his functional independence rather than cure. He also wants to have the independent thinking about his future goals. He should be managed to find out what are his aspirations for things like advanced planning. Otherwise, if you delay it and when they lose their cognition and other facilities, then it is too late and their wishful aspirations may never be honored. So living will, advanced planning, all that comes under the matters most. Then mind. I think it is equally important for all the elderly people, whether they are with disease or without disease, they have to remain cognitively alert. That will prevent from occurring dementia and depression. Then mobility is very important. Many people are finding hard to walk properly. They may lose balance and they sometimes injure themselves and get fractures. Fourth, but not the least important, the medication. I think elderly people, because they are suffering from a number of morbidities, so they go to different specialists and they get medicine prescriptions from each one of them, sometimes duplicating, sometimes having drug interactions, adverse effects, and so on. So this polypharmacy has to be kept in mind in every specialty. Then multi-complexity. Multi-complexity means a elderly patient has to have most of the time multi-morbidity. He has more than one disease. He often has diabetes, hypertension, and many other diseases sometimes. And this together with his financial status, his social status is dwindling down. These are adding to his physical morbidity also. So they also have to be kept in mind. So these 5 M's are important across all the specialties as far as the elder individuals are concerned, and we recommend this as a part of ecosystem for geriatric care as a whole. And I think all governments of the state and center, all the NGOs, all the healthcare providers should adopt this approach There are intricacies for which we have no time, but they are all manageable to the best possible extent. That was as far as the system-based policy is concerned. Now I have this last slide about the individual-based policies. This particular slide was devised few years before, which I call as 10 commandments of healthy aging. This should be adopted as a part of policy to shoulder the responsibility on the aging individual himself. And I am very happy to note that some of the organizations, including Inspiring Foundation, Inspiring Senior Foundation, and very recently in 2025, in a document of 88 pages, subject on graceful and active aging, unlocking the secrets of longevity, this has been incorporated in that document. So these are very simple things to practice. And this is, for example, eat proper, exercise well, enrich socially, remain mentally alert, engage spirituality, and have a annual health checkup on every annual birthday, have a good and full sleep, and observe personal cleanliness and pollution, that is environment, both outdoor and indoor pollution. And finally, I have watermarked two more things. One is happiness and contentment, other is positive thinking, and what is called mild stress. Facing mild stress is useful for health and longevity. I am not for the moment telling that chronic severe stress is something which is not at all to be welcomed, because that shortens the life. But in the same breath, I am telling mild, intermittent, these stresses, when you get daily, these stresses may be physical, may be nutritional, may be psychological, may be emotional, sometimes spiritual also. These stresses, they trigger your cells to prepare for the larger stress. And in the process, these cells over time work. They remove the debris of what has happened in the earlier stresses, and they overcompensate and delay the aging process. We will talk about it someday later. There is a science behind this, and there is also a science behind happiness and contentment, because many medical experts would probably regard these two things as abstract advantages, but there is a science behind it, and all other that I have named, there is unmistakable scientific evidence, both from the modern science as well as the ancient science, to support this. So these 10 commandments of aging should also be adopted as a policy and wide across the country, both in the rural and urban landscape. This has to be promoted. So rest of the things I would talk some other day, but I think the question that has been posed, this is what I could summarize in these 4 slides. Thank you very much.
Thank you, sir, for highlighting some of the interventions, both at the level of community as well as at the level of individual levels. So now we move on to our next speaker, Dr. Nayak, who is a renowned cardiologist and done a lot of work in particularly cardiology relating to geriatric group. And now I would like to have his views, the role of increasing cardiovascular diseases in India and how it is going to affect the quality of life of our Indian population, and what could be the possible interventions, both at the level of community as well as at the level of individual. Over to Dr. Nayak.
So thank you so much. I mean, yes, we are seeing a surge in the numbers of patients who come to us with heart diseases. It's no longer surprising to see a person in his 20s and 30s to have a heart attack, which, previously you would not even think that this patient, such a person would actually come to your practice maybe 3 decades ago. But I think so, this is maybe to some extent largely fueled not by changes in our genes, but changes in our behavior. And these changes are largely to do with the external environment around us, our lack of exercise, sedentary lifestyles, using food habits that have changed dramatically, access to fast foods. These are what have contributed in a seemingly larger measure. Previously, you would see that rural areas didn't have access to all these things, but globalization has changed that as well. So I think so these are some of the key factors that have led to a surge in the incidence of cardiovascular diseases. And most societies do go through that. The less developed countries have faced that. They have had the incidence of epidemics and infectious diseases. Then you have non-communicable diseases like heart disease, hypertension, and we seem to be going through that. But the comfort that comes to us is that in all areas that you see, even in the developed nations, it is important to see that the incidence of cardiovascular diseases has come down. And this reduction has not happened by doing more angiograms, by giving more medicines. It has come through primary prevention strategies. And those strategies involved largely around what was talked about before Professor Reddy spoke about, decreasing smoking, improving physical activity, better diet, and obviously controlling your numbers when they go wrong. It's no longer adequate to say that, I've never had a checkup ever. In all, across all ages, when you go into college, when you take up a job, it's generally good to have your numbers measured. Blood pressure is called a silent killer. You may have very few symptoms till you land up with the problem. And therefore, many of these disorders now have to be checked early, because now there are effective tools, which can be deployed to prevent these things from happening in the future. Remember that cardiovascular diseases account for more deaths in a population than all other causes of death put together. So which is a huge number which needs to be acted upon, and most of these diseases can be prevented by acting early. Cardiovascular diseases, that means blockages in your heart arteries, brain arteries, don't start at the age of 50 or 60. They start in their 20s and 30s. So it's like, previously we used to talk of, when we look at a smoker, we would say how many pack years of smoking, how many cigarette packs has he smoked? And supposing he smoked 10 packets a day for 10 years, his risk of heart disease is more than a person who's been smoking, say, 2 packs of cigarettes a day for 10 years. So not that there is a threshold, but yes, the probability is higher. So similarly, if your blood pressure numbers have been higher, your cholesterol numbers have been higher, your sugar numbers have been higher for many years, the longer the years of exposure, the greater the chances that you have these problems, and therefore lifestyle becomes a very key determinant of reducing cardiovascular disease in the future, which has to be taken both at the community level as well as at an individual level. And there are very many ways that we can do it. Government has launched the wellness program, but I don't know how well it is being rolled out everywhere. But it is for us to, adopt all these strategies in our everyday life to make a change for the better. At the same time, I would like to say it is important when patients have got advanced heart disease in their later years, it is important that we seek medical attention early rather than late, and we at the same time don't get lost in this muddle of advanced care, because like was discussed in the previous session as well, there are many advanced therapies that are available that sometimes confuse what should be done both to the care provider as well as to the caregiver and to the patient. And therefore, you need to have clear discussions around therapies, what are affordable, deployable, and effective to patients. Because being a cardiologist, we often see advice being given which we feel is not realistic considering the patient in the picture. So it is important that whenever therapy is given, it has to be, you have to take a holistic picture of the patient, and therapies have to be designed around it. It is not that only the most advanced of therapies are always going to give the benefits that we hope that they will give to us. So that's my take on what we said. And
Yeah, so thank you, Dr. Nayak, elaborating the possible interventions as far as the increasing cardiovascular diseases are concerned. Yes, I agree with you that we need to focus more on the early diagnosis and early treatment as well, because that will be, as it is already evidence based, that if we are able to implement those strategies, that leads to huge reduction in both mortality and morbidity. So as far as I mentioned in my initial remark about Singapore being the topmost country as far as the HAIL is concerned, about 76.3 years of HAIL. So there, what they have done in Singapore, though it's a small country, we can't compare Singapore with India, nor we can prescribe the same solutions here. But what they have done in Singapore is that they have ensured the quality universal primary access of care to each citizen, irrespective of social strata, income, education level, anything. So because of those interventions, they are able to demonstrate, and we have a model in front of us. Because of those things, they are at the top. Now, as far as India is concerned, again, as I said, now we have started this, but I agree with Dr. Nayak that there are a lot of governance issues as in all the health programs in our country, which we are not able to implement in toto what was prescribed in theory. So there I would just like to humbly mention that 3 months back I have started one national task force projects on the same issue, where I'm planning to come out with a model in next 3 years, where every Indian is ensured to have a primary screening, whether it is in rural area, urban area, irrespective of the income level. So to have access to these primary screening strategies, as well as the timely compliance of the medication required, particularly to address the issues of quality of life. So let's see and hope that things come out better. And I hope to make this as a kind of a national health program. And I dream that every Indian have access to this. So now I would like to request Madam Dr. Neela Mohan, who is the President-elect of Indian Academy of Pediatrics.
Not elect, is it?
Okay, thanks. So I amend myself, ma'am. So now I would like to request President Dr. Neela Mohan, ma'am, President Indian Academy of Pediatrics, to share her experiences and expertise, how the children health is now going and transitioning, both in the rural urban areas and in both almost all categories of society, whether undernutrition, overnutrition, and what could be done at the earliest in the earliest phases of life, so that we do have a healthier adults and healthier elderly population. Over to ma'am, you.
Thank you, Dr. Lal. And it's been really nice that we started from geriatrics from Dr. Vinod and then went into the adults through and Dr. Nayak, because all the three speakers and Dr. Lal emphasizing Singapore. So that made it very clear, as I always say, that it depends on what seeds you've planted. I mean, if you plant a guava seed and then you expect mangoes out of it, you can't get it. Similarly, the other way I say is that आपकी सुई उधर घूमी है, but रोशनी इधर है, तो यहाँ ढूंढूंगी तो मिलेगी ही नहीं, because सुई तो उधर गिरी है. So something like that. What I want to start is, what a wonderful session, which is being absolutely the key for which I've been emphasizing for quite some time now. And as a public health voice, this is the key thing that is my interest, which is the healthy life versus the increased life longevity, which is the session title. So when it comes to children, wow, I can proudly say that in the last decade, we've really done great when it comes to survival. So survival means my under 5 mortality, which was 45, came down to 35, pan-India, and even there are places like infant mortality when we talk 39 to 30, and in Kerala we are something like USA with an infant mortality rate of less than 5 and a neonatal mortality rate of 4, but overall in India from 26 to 20. So we are patting our backs. That, wow, because our focus has just been survival, and we've been, which is fair enough. I've been working on survival, vaccination, infectious disease, reducing pneumonia, reducing diarrhea. So the whole focus of pediatricians have been just there. But in that, we just forgot that we never focused on thriving. Survival was a victory of science, but thriving is actually going to be the victory of human. I mean, we ourselves. So, what do I mean by that? What I mean is that we have always focused on illness, never focused on wellness in children. Yesterday, World Health Day, I made a video and circulated. When was the last time, parents, that you ever went to a doctor for wellness? I come for a checkup. Is my child overweight? Is he undernourished? Is he anemic? Is he obese? No one. Majority, whether urban or rural. So when it comes to the main burden that we are seeing now in children, it's no more the geriatric, which he was talking, and Dr. Vinod and Dr. Nayak in adults. Now we are seeing the double burden of issues in India. What do I mean? One side, I'm fighting, undernutrition with statistics which are pretty bad, like underweight 35%, stunting 38%, and the other side, I'm saying 8 to 10% are overweight and obese. So right now, India is at crossroads. On one side, there is underweight stunting. On the other side, there is overweight in that. And to add it to right in front of me, there is hidden hunger. So it's a triple burden. That means anemia is 67% in under 5 years, 55% in adolescent girls, 35+% in adolescent boys. So in India, it's a cycle. If you do not take care of nutrition in under 5 children, you can never achieve what Nayak wants and they want. First, I need to concentrate on the healthy habits development. You will be shocked if I tell you only 11% get the right minimal acceptable diet in India less than 2 years. So we need to focus on a behavior change. We need to make loud and clear, both in the rural and urban, what is the right nutrition, because as the Niti Aayog said, just correcting anemia can improve your GDP by 1.8%. And if I work in the entire nutrition and overall, I can improve the GDP by 3 to 5%, the entire global thing. So if you want to improve the GDP and work towards a Viksit Bharat and work towards the human capacity, I think we need to work on children right now. If you had money to give it to Nayak or to Vinod, they should be after me. Because if you want me to work for Viksit Bharat, these are the children I have to work right now, improve their nutrition, improve the lifestyle. How do I work with the environment? What about the pollution? What about the plastics? What about so I need to work. What is the screen time? 3 to 4 hours average screen time in children in India. Worst globally. We've beaten West. So that is the screen time. What is the activity? 30% activity in children in India. 30% only do activity. Play school availability in school, not even 50% have play schools available in school. So screen time increase, sedentary lifestyle, no playing, and the fast food he was talking about, which Dr. Nayak said is not only limited to urban, but there. Where did that habit come? It actually came in children and adolescents. Why do I eat healthy? I eat healthy because it's all the time in my mind, oh, I need to take my salad egg. So majority people don't know what's a normal diet. They don't know that 50% of your plate should be, of a child should be vegetables and fruits. What do? Give a 1 liter of milk, which is wrong. So the concept of 5 diets, that means vegetable, fruits, milk up to 400 ml, seeds, nuts, cereals, anyway you eat. What does a typical mother say? Beta roti mat chhod, chawal mat chhod. Does she ever say dal khatam kar, sabji khatam kar? So we need to change the mindset of people that you need to work on a healthy lifestyle for a child, because the road to India's geriatric and this thing is definitely preventing the chronic diseases, because I have moved from survival now to thrival. So there is an increase incidence of diabetes in children, fatty liver disease, metabolic steatosis in children. Everything is coming early. So what he's doing now is in 30s and 40s, and we are transplanting in 30, 40s. Those who don't know, I'm a pediatric by profession. Besides a public health voice, I'm a pediatric transplant expert. So it's like the whole thing is moving. So to me, if you want to sum up, I should say we need to focus clearly on children and adolescent, because it's a lifestyle. That is a adolescent girl who's going to be preconception into a mother. 20% mothers get the right food in India, just 20, and 50% are anemic. So adolescent to maternal to the first 5 years, and then comes through school. Singapore. So Lal made my life easy. Singapore is best because they succeeded through the school program in educating the children on healthy education. So that is what I would have to say. We need to move out of the hospitals into the community. We need to move from illness to wellness, and we need to move from adult focused diseases to focusing on early childhood children and adolescent, so that we reach there. And that would be my plea, to move from survival to thrival. That is the good quality of life, thriving well with less chronic diseases. We don't even check blood pressure in children. Wrong. We need to check at least once in 1 year and 3. So I'm coming out with an app, like he said, which is going to be released for it, where within that app, the 5 parameters should be there. The nutrition, so they should just show what food the child has eaten, and it will tell you what it is. Then I want in that the growth. They just have to say my age, weight, and the growth. It should say about the vaccination. It should say about the development, because autism is increasing. 1 in 100 autism now in India, which is due to environment changes. So that's my plea to you all, that if you want to make Nayak and Vinod and Lal happy, think about Neelam first. Thank you. And it's a pleasure to see yourself, Sir Srinath. Whatever I've learned a little bit about public health, thanks for reminding that I was the convener when we went in Aman Ki Asha. But big salute to him. He's taught me a lot about public health. Bless you, sir. Thank you so much.
Thank you to our panelists for sharing their insights on how we can focus not just on longevity, but HAIL is one of the important parameters as well. Now we open the floor for the Q&A. So if you have any questions, please raise your hands and our volunteers will bring mic to you. So can we have the mic?
Hello, good afternoon, everyone. And I feel privileged to be here. Last year also I was here. And my gratitude to Dr. Gupta. And I always say this is one of the best forum. We have patients also in this room. And my question is with Dr. Neelam ma'am. Ma'am, I am also an ex-Medanta. I'm part of COVID warrior. I worked with Medanta team. So my concern is that coming from a millennial generation, my parents are Gen X, and my, earlier I was about to ask you, what are we doing for Gen Z, Gen Alpha, and now Gen Beta? But you've already told that so many things you are doing from survival to thrival zone. I would like to ask on how are we doing that to reaching not just the tier 1, tier 2, tier 3 cities, even the 70-80% crowd, the kids in the village who are going to be part of the 2047, when we talk about the developed country. So I would like to check on that, ma'am. Thank you.
Yeah, thank you so much for the question. I missed your name.
Mithilesh, we are working on mental health.
No, what's your name?
Mithilesh.
Mithilesh.
It's an
Thank you
Optimum
so
for
much
which I'm
for
working.
that, because this is exactly would be my dream, and if anybody is hearing this, they need to adopt me and my thoughts, is that the paper that I created and the way I want to work is, I feel if I look into the 11 lakh Anganwadi centers in India, 85% are in the rural region and only 15% or so in urban. So if we are talking today on thrival over survival, then I need to include the urban population along with the rural population to march forward. And for that, that is why I feel that there needs to be a system which, though we say public private partnership, it's become boring to talk about that. I would put it in a new way, and I say that if there are certain, I mean, NGOs or whatever they're working, we need to complement what the government is doing. If you complement them and not go in a different direction, then it becomes ekorek agyara. And to be successful, it has to be an andolan. So how can I make andolan? That means, for example, if healthy eating is, yesterday I was on Ashtak on 1 hour session on diet because it was World Health Day, and where I'm just talking about what I mean by eating and all. So when we talk about that, Andolan is Vinodji talking the same, Lal talking the same, Naik talking the same, media talking the same. That's how we did polio. How did we that? So to make it an Andolan, we need to come together with no me but we, with no ego. Who gets the credit, he gets the credit, it doesn't matter. But the voice, the message has to be very clear. What I find is people spend their energies more in criticizing and negativity. If the same energy is converted to positivity in seeing what you're doing rather than not doing, that will make a difference. So to for the government, if, I mean, they are doing great, but if there can be some way that you can put us together through the NGOs, and we are able to do that. So I prepared a project which I can share with you all, but it is for Pan India. I want to work on through my, I can't release it, but what the project is about, and that will take care of urban, rural, through the first point of contact, which is a pediatrician. So the first point of contact should be talking healthy, and I need to work on adolescent, mother, child. Once I set that and get into the school, so the state chapter and the national chapter is creating a problem. If I go to him, he says it's not mine, go to there. So that is creating a problem. Somehow, if Modi ji can put a magic wand, so I call him Namo, and I'm Nemo, Nilamo. So if Namo can put a magic band, and that can be that I should be able to talk to them and to the school children, trust me, we can change their outlook later. So we need to know where to work. That's what I'm saying.
Thank you, ma'am. There is a following question to that, if I may ask. So, ma'am, there is a following question to that. Since I'm like, I have got to know that you've got such a huge vision, and I think it is commendable. And along with that, since you talk about healthy lifestyle, so what are we doing on emotional wellness? Because you know the stress is another.
Brilliant question.
Because,
Brilliant.
yeah, because
So first of all of you need to understand health is like not physical at all.
yes.
It is besides physical, mental and spiritual and emotional wellness.
Yes, ma'am.
And I love Amitabh Bachchan for that line, ye jeena bhi jeena hai landu. What a line he said, right? And I need others to talk like Shah Rukh Khan, main hoon na, because that mehuna is not there. 1 in 7 adolescents have mental health issues in India in terms of anxiety, depression, panic attacks, whatever. 80% are not identified.
Yes, ma'am.
So if a child comes to any him as a Dr. Nayak for say he's seeing a 14 years or a 15 years old patient with a cardiac, he's just focusing on the numbers and this. He forgets to have an eye to eye connect with the child and adolescent and realize कि वो आंख क्या बोलती है. I am able to do that because GI problems like pain, abdomen are commonest. So they come to me and I can make out the whole thing is a gut brain axis and all.
Which is the
So
second pain of
mental health can be improved a little, giving by the shoulder.
correct.
That is, mehuna. That's what they need to say. And as you said, the generation which you talked about, the problem is I need to explain him that the child is right. The child wants to go out for a club, fair enough. The child wants to speak. मुझे मालूम है तुम्हारे लिए क्या सही है क्या गलत है. Wrong.
Correct.
He's wrong. He needs to understand the attitude of that Gen Z because they want to be heard. And the latest alpha is amazingly rational.
Yeah.
Amazingly rational. You are able to explain to them, ये नहीं, they will know कि अच्छा रागी खाऊं मैं बाजरा खाऊं rather than roti खाऊं यार. He will understand what you are saying. So therefore, it's not about saying, it's about how you say, and never ever forget the mental and emotional well-being of a person, because including us, that last night I couldn't sleep because somebody spoke very rudely. So it disturbs you. That's what happens to them because their brain, the frontal area is not developed, and so they cannot have reasoning very well at that time. So, but once they become revolutionary, 80% will go. Do you know that an adolescent is obese, 80% he'll become obese, adult, if his parents are obese too? So this is where they lack to understand. And a lot of work need to be done. And I need people like you, the community, the NGOs, people who just want to do. Because if you give, 10 times goodness will come back to you. So give it and don't say ki mera kya. Just give it.
Thank
Yes,
you, ma'am,
ma'am.
for such
I
an
think-
astute response.
Yeah, I think thank
do
you,
we
ma'am, for answering that. That was amazing, and to have a conversation with you. Thank
do
you.
we have any other questions?
Yeah.
Yes, ma'am.
My question is to Neelam ma'am. Ma'am, very well said. You give very insightful points. There are my two questions to you. मैम हम ऐसा क्या कर रहे हैं कि जितने भी न्यूबॉर्न बच्चे हैं आज की डेट में
जी.
वी आर गिविंग बर्थ टू अ लॉट ऑफ ऑटिज्म ADHD चिल्ड्रन. ऐसा क्या कमी रह रही है
Excellent
ड्यूरिंग द
question.
प्रेगनेंसी?
See, three things we are going wrong. Number one, as I said, ki beach, seed. First, I need to work on the adolescent. That is what I'm saying. She's the preconception person I need to work. So once I work on the adolescent, then I work into, so what is happening right now, the newborns which are born, in India, we have the highest low birth weight and prematures. So by default, you know that low birth weight and premature are going to get obese and land up with him, because that science they will explain. I'll go beyond that. So we need to first understand to work on that mother, not to allow the identify the high risk pregnancy and not produce them. Second is the environment. And third is increasing awareness. Maybe autism existed always, but हमें लगता था ये ना थोड़ा सा बेवकूफ है, ये थोड़ा सा समझता नहीं है, ये अपने में रहता है. This is what we used to say. So there are three things that have made a change. Number one, probably due to the gut microbiome changes, there is a change in the genes, because autism is gene plus environment. Like IBD is gene. So IBD is increasing in India. TB is reducing. Allergies are increasing. Allergies 3%. TB is 0.6. So as TB is increasing, allergy is increasing. So autism is because of three. So you need to work on the environment, and not you. It is everyone. When he throws a plastic, when he throws, he should not think कि मेरा क्या जा रहा है. It's the whole generations which are. So we need to work on the environment. We need to work on the gut microbiome, and that's an Pandora which you've opened up, because gut microbiome is based on your diet, your environment, your mental health status, and your activity and your sleep. So आप बहुत अच्छे हो, लेकिन आप सोते So you need 8 hours of sleep for a child and minimum 7 to 8 in an adult. We don't do. We are scrolling.
मैम मेरा एक क्वेश्चन और है बस मैम एक मदर इंडिया में अगर उसके पास लिमिटेड रिसोर्सेज हैं तो शी थॉट कि अगर मैंने बच्चे को 1 गिलास दूध पिला दिया तो आई एम डन कि आवर फोकस इज ओनली ऑन मिल्क मिल्क एंड मिल्क व्हाट इज योर टेक ऑन दैट शी विल नॉट गिव द बनाना शी विल नॉट गिव द एप्पल शी विल गिव द मिल्क
सो वेरी सिंपल मुझे सिर्फ एक ट्रायंगल फूड पिरामिड हर एक जगह यही डालना है भैया ये 7 चीजें 7 में से 4 देनी है 4 क्या है माँ को बस रात में सोने से पहले सोचना है मैंने 4 या 5 दे दिए व्हाट आर दोस 5 1 वाज वेजिटेबल किचन गार्डन हर एक को बनाना चाहिए वेजिटेबल का मतलब आलू नहीं So that is the problem. Give any ghee thurai, indeed, beans, butter, palak, methi, saag ki sabji. They're all very cheap if you really think. Second, so it is. That's what I'm saying. That the diet, the taste has to develop in a child, not at that age. You know. So that is the focus number 1. Second, she should think एक fruit. मुझे महंगा नहीं चाहिए. अमरूद, केला, पपीता, सेब जो भी उसका सीजनल सस्ता फ्रूट whatever one fruit she has to give ज़्यादा भी नहीं because it's carb 1 fruit a day. Third एक मुट्ठी भर seeds and nut बीज कितने cheap है कुछ भी नहीं है बीज so just antioxidants for your brain so एक मुट्ठी बीज nuts ज़रूरी नहीं है बादाम और अखरोट even मूंगफली खा सकते हो so seeds and nuts 1 fist she should think. Third thing. Fourth thing she should think cereals, rice, ragi, millets, wheat and all. Fifth thing is milk. कुछ भी 400 ml दूध, दही, लस्सी, पनीर, kheer, whatever she wants, 400 ml of that because milk doesn't contain the iron. And 3 things you should tell the mother that love the 3 colors, red, green and yellow. Because ये अगर आपकी डाइट में है दाल हरी कलर की होगी तो सब्जी एक कलर की होगी 3 colors if you do your gut microbiome will improve so teach her this basic things that you do and the other 2 components were eggs and non-veg those who take good protein so not those who don't take pulses and legumes
Thank
an egg
you,
is a
ma'am.
holistic
Thank you, ma'am. Wonderful
Thank
answer.
you. Do
My
we have any
one-
other questions?
One question to Dr. Nayak.
Ma'am,
Dr.
actually,
Nayak. Dr. Nayak, one question.
ma'am, actually, we have other audience members as well. So we will, if any no other questions, then we will request you.
Good afternoon, ma'am. Myself, Vansh Sharma from LNMC Bhopal. I'm pre-final medical student. Am I audible? Sorry. Ma'am, myself, Vansh Sharma from Bhopal, LNMC Medical College. So my question is, while the sad reality of food adulteration and fake vegetables are passed around, especially all the fake vegetables are failing tests. Most reputed brands are failing the tests from FSSAI. Sorry. How do we improve on our nutrition? How do we counter that while this reality
brilliant
exists?
question thank you for asking nobody asked this question
Whom you are directing this question?
anybody you can take sir no he is asking you कि क्या करें हम adulteration खत्म करें
Before I answer your question, am I audible?
थोड़ा सा आगे
So before I ask your question, answer your question, I would like to say what Dr. Neelam Mohan has told. Every word of her is a pearl of wisdom, and she is advocating for pediatric and adolescent population. But at the same time, although nobody is asking question from me, I don't know why, but I am again carried away by the fact that people don't care about the aged people. So I would.
So I think this nutrition
in-
covers every age.
So in spite of pearls of wisdom that Dr. Neelam Mohan has told you, I would like this audience not to go away with an impression that old people are not as important as children.
yeah they're equally important pediatric and geriatric hand in hand
Now I would quote some statistics. Graceful aging and healthy aging and living better is not only beneficial for an individual older person or a person who is going to be old tomorrow. It is important for national productivity. The data says it is a robust data that in years to come, it is already happening, that younger earning population is shrinking in every country and the elderly population is going up. And in Japan, by 2050, there will be 4 out of 5 individuals who will be 60 plus. In South Korea, there will be 3 out of 5. In Italy, same story. So what will happen? If you are traveling in a bus, out of 100 people, 80 people will be doing like this with their stick. Who will work for the country? So it is very important that geriatric people have to undergo benefits of prospective policy changes so that they remain active, graceful, and capable of working and building the nation. Whatever pediatric or adolescent you may do, which you have to do because you need them, robust young people also. But social demography says that even then, within next 20, 30, 40 years, the younger earning population will disappear and only the elder people have to work for the country. So this is my take. Regarding adulteration, I am no expert. You can answer.
And so I'm very happy that he said that. So that will trigger us that if you are a healthy child, you'll continue to be a healthy adult because his habits were healthy as a child, and that's why he's a healthy adult. Now, what another thing is that we need to work on to robotics because if you're going to have everybody elderly, 80%, then robots need to be the young one who need to work for us. So anybody who's into technology, hey, you have great work to do and great future. So answering to your question now, very rightly said, the government focuses now on there. What is the government saying? It is the soil enrichment that they want to do. If you do not enrich your soil with the right minerals, whatever you are producing, like in India, zinc is very bad in the soil. So now the organic farming, the government is giving them, they are based on the assessment of the land, you will get individualized farming, and that's a work which is going on by the agricultural industry, which I'm very proud of. So that is one thing they are doing. They are encouraging and giving awards to the farmers who do not use pesticides but use the organic one, and this will be supplied. So that's a good step. Second step is that till then we all need to realize, I'm sure 90% in this room don't know that when you get vegetables and fruits, how to clean them. They don't know. So very simple. Everybody has baking soda at home. Everybody has salt water. So you can put them in salt water to clean it. You can use KMNO4. You can use vinegar, which is 5% vinegar. So like that, if we learn कि कुछ भी खाने पीने से पहले we do, that will be a good thing. दाल बना रहे हो तो सोक करो. सोक करके जब आप फेंक दोगे वो पानी, फाइटेट्स निकल जाएंगे, तो आपका आयरन एब्जॉर्प्शन जो सब्जी खाओगे वो बेटर होगा. खाने के साथ चाय कॉफी नहीं पो, नींबू डालो जो बड़ों ने सिखाया. These are all the ways to improve the quality, and the government is now fortifying not only rice with iron, but fortified milk. We have vitamin D, and now they're looking at fortification of millets and the wheat to answer your question.
Thank you so much, ma'am. Thank you, sir, for putting up this question. Though we are running out of time, but we will still take one question to Dr. Nayak.
Yeah, my question is to Dr. Nayak. Doctor, as you said about the heart disease in the people, you talked about the wrong lifestyle, wrong diet, and all that we don't go for the screening, etc. But what about the young people who are going to gym, who are eating extremely happy in their late 20s and early 30s? They are getting the heart problem. What precautions we can do for that?
That's a very important question as to why young people develop heart diseases, even though they seem to be exercising, gymming. We have really not got a great analysis of what has happened to them. From what we can see is when we compare this population of youngsters versus people who are older, what differences in risk factors do we see in them? I think so. One of the large majority, one of the most striking risk factors that that we see is largely related to smoking and tobacco use. Many of these people are using tobacco and and indulging in smoking, which is not appropriate. Also remember that some of the mental stress has not been quantitated, but that's an important, sort of factor that is sort of, the elephant in the room that we have not addressed very well. Yes, because many of these people are working lifestyle hours which are completely, non viable. They're working long hours. They have the day-night working hours, which is not correct. But I think so. One last thing that I would like to also add is, this emphasis on exercise is often coupled with the use of diets which are non-physiological. This thing of, pumping yourself with proteins, and not that we think that this is a risk factor, or not that we have research to show that, but there's also evidence to show that when you indulge on an exercise program that is super intensive, people running marathons without any checkups, some of these deaths happen because of exercise as well. Exercise that is disproportionate to your level of fitness and to your level of activity can actually precipitate heart attacks. So it's not that all exercise is good at all ages all the while. So these are risk factors that are real. It's not in any way to say that exercise does not reduce the risk of heart diseases, but yes, unrealistic exercise goals with unrealistic lifestyles can precipitate some of these problems. So these are all caution points in our life which we have to be careful about. And many other risk factors also are there which we have not really addressed. There are always emerging risk factors relating to environment and many other variables that we keep looking at. This question is not well answered as of today, but these are some of the points that we should take a note of.
What's your thought on AQI, sir? I mean, the environment AQI, does it have an impact on the
Yes,
heart?
I mean, yes, and environmental pollution is a very important sort of contributor to development of blockages. Professor Reddy sir has done so many studies and he's spearheading many such epidemiological studies that are trying to assess the contribution of air pollution. And it is a well-known fact that these pollutants travel not only to our lungs but into our heart arteries, into our brains. They're even found in children's hearts and liver. So there is no organ in the body that is immune from the effects of air pollution. And these have been known to incite acute heart attacks in patients who live to very near polluted industries. So yes, this is an important determinant, but not this. Fortunately, biology is such that no single risk factor can, overtake and create problems in your body. You have mitigating factors that protect you. But yes, this is one important contributor to heart disease as well.
Thank you, sir. The time is up. So if you have any questions, you can connect in the networking breaks, which are being followed. Thank you to our panel. The conclusion is clear. Longevity without quality of life is not victory. India needs a system built not just to treat the disease, but to prevent it. Thank you. Let's keep the momentum going on. You can scan the QRs in front of you or your lanyards to fill in the Mentimeter questions. Meanwhile, I request all the panelists to gather up in the front for a photo.
It was so wonderful to be with Please. Thank you so much, Doctor.
Thank you so much, everyone, for your wonderful insights. Ladies and gentlemen, Let's have a round of applause for our distinguished panelists for this session. Moving ahead, the kitchen is calling, and so is our body. We break now for the lunch, which is being served in the dining area outside. This is also the perfect time to continue with the conversations sparked in the morning. Exchange your cards, exchange your ideas, collaborate. This is your time, this is your moment. Please enjoy the lunch. Thank you. I'll see you at around 2 p.m. Thank you.
More than 100 leaders trained. Executive Leadership Program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional Development Program in Digital Health for Nurses. Accredited by the Indian Nursing Council with 50 CNE hours, 10 CNE credits. Professional Development Program in Digital Health for Pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health, online self-priced accredited by CPD Standards Office, UK. A one-year comprehensive course on digital health. World's best faculty. Your learning, your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
This is not just a summary. This is where the future of healthcare takes shape, where conversations move beyond ideas and turn into real-world implementation. Discussions to actionable insights, from innovation to execution. Welcome to the world's most impactful summit on digital health. Keynotes that think beyond insights towards real impact. A global platform bringing together global leaders, innovators, policymakers, and change makers, all working towards one goal: transforming healthcare. This is where collaboration meets opportunity, where vision becomes reality. Join us on 20th and 21st of November, Bharat Mandatory, New Delhi, for GDHS 2026. Theme: Implementing Artificial Intelligence, AI in Action. Be a part of the movement that is shaping the future of healthcare.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare already use those minutes with the health element. Are you? Research proves it. 70% higher retention with daily micro. 2x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours. You need smarter minutes. Learn smarter. Grow faster. Lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, and industry leaders in a shared digital space. The app offers a robust set of features to empower users: disease-specific communities, a unified discussion feed, access to authentic resources, voice-enabled support, and patient-reported outcomes, or PROs. A first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes, along with the ability to post anonymously. Fast forward to 2024, IPU held its annual conference, focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to NITI Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first IPU fellowship, designed to transform patient experiences into actionable policy recommendations. At the 2025 conference, held at the India International Center, IPU unveiled enhanced versions of the app, the fellowship, and the One Health Report, reaffirming its commitment to patient empowerment and sustainable outcomes. Over the last 3 years, International Patients Union has been steadfast in its pursuit to create inclusive digital platforms for patient engagement, enable patients to shape and participate in healthcare policy, and drive systemic change through collaborations, advocacy, and storytelling. Join us and become a part of the Change Initiative.
Academy of Digital Health Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online and self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace from anywhere in the world. More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 100 leaders trained. Executive Leadership Program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional Development Program in Digital Health for Nurses. Accredited by the Indian Nursing Council with 50 CNE hours and 10 CNE credits. Professional Development Program in Digital Health for Pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. Your learning, your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
Minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, and industry leaders have shared digital force. The app offers a robust set of features to empower users: disease-specific communities, a unified discussion feed, access to authentic resources, voice-enabled support, and patient-reported outcomes, or PROs. A first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes, along with the ability to post links. Fast forward to 2023, IPU held its annual conference, focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to NITI Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first IPU framework, designed to transform patient experiences into actionable policy recommendations. At the 2025 conference, held at the India International Center, IPU unveiled enhanced versions of the app, the fellowship, and the One Health Report, reaffirming its commitment to patient empowerment and sustainable outcomes. Over the last 3 years, International Patients Union has been steadfast in its pursuit to create inclusive digital platforms for patient engagement, enable patients to shape and participate in healthcare policy, and drive systemic change through collaborations, advocacy, and storytelling. Join us and become a part of the change initiative.
Academy of Digital Health Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online and self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace from anywhere in the world. More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 100 leaders trained. Executive leadership program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional development program in digital health for nurses. Accredited by the Indian Nursing Council with 50 CNE hours and 10 CNE credits. Professional development program in digital health for pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. Your learning, your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
This is not just a summary. This is where the future of healthcare takes shape, where conversations move beyond ideas and turn into real-world implementation. From powerful discussions to actionable insights, from innovation to execution. Welcome to the world's most impactful summit on digital health. Beyond insights toward freedom. A global platform bringing together global leaders, innovators, policymakers, and change makers, all working towards one goal: transforming healthcare. This is where collaboration meets opportunity, where vision becomes reality. Join us on 20th and 21st of November, Bharat Mandatory in Delhi, for GDHS 2026. Theme: Implementing Artificial Intelligence, AI in Action. Be a part of the movement that is shaping the future of healthcare.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare use those minutes with the health For you, research proves it. 70% higher retention with daily mindfulness. 2x better odds of career growth.
That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours. You need smarter minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, and industry leaders in shared digital forums. The app offers a robust set of features to empower users: disease-specific communities, a unified discussion feed, access to authentic resources, voice-enabled support, and patient-reported outcomes, or PROs. A first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes, along with the ability to post analysis. Fast forward to 2024, IPU held its annual conference, focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to NITI Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first IPU Foundation, designed to transform patient experiences into actionable policy recommendations. At the 2025 conference, held at the India International Center, IPU unveiled enhanced versions of the app, the fellowship, and the One Health Report, reaffirming its commitment to patient empowerment. Over the last 3 years, International Patients Union has been steadfast in its pursuit to create inclusive digital platforms for patient engagement, enable patients to shape and participate in healthcare policy, and drive systemic change through collaborations, advocacy, and storytelling. Join us and become a part of the Change Initiative.
Academy of Digital Health Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online and self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace from anywhere in the world. More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 100 leaders trained. Executive leadership program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional Development Program in Digital Health for Nurses. Accredited by the Indian Nursing Council with 50 CNE hours and 10 CNE credits. Professional Development Program in Digital Health for Pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. You're learning your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
This is not just a summary. This is where the future of healthcare takes shape, where conversations move beyond ideas and turn into real-world implementation. From powerful discussions to actionable insights, from innovation to execution. Welcome to the world's most impactful summit on digital health. Keynotes that went beyond insights and toward freedom. A global platform bringing together global leaders, innovators, policymakers, and change makers, all working towards one goal: transforming healthcare. This is where collaboration meets opportunity, where vision becomes reality. Join us on 20th and 21st of November, Bharat Mandatory in New Delhi, for GDHS 2026. Theme: Implementing Artificial Intelligence, AI in Action. Be a part of the movement that is shaping the future of healthcare.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare use those minutes with a healthy mind. For you, research proves it. 70% higher retention with daily micro 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours. You need smarter minutes. Learn smarter. Grow faster. Lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, and industry leaders in shared digital space. The app offers a robust set of features to empower users: disease-specific communities, a unified discussion feed, access to authentic resources, voice-enabled support, and patient-reported outcomes, or PROs. A first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes, along with the ability to post alerts. Fast forward to 2024, IPU held its annual conference, focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to NITI Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first IPU Foundation, designed to transform patient experiences into actionable policy recommendations. At the 2025 conference, held at the India International Center, IPU unveiled enhanced versions of the app, the fellowship, and the One Health Retreat, reaffirming its commitment to patient Over the last 3 years, International Patients Union has been steadfast in its pursuit to create inclusive digital platforms for patient engagement, enable patients to shape and participate in healthcare policy, and drive systemic change through collaborations, advocacy, and storytelling. Join us and become a part of the change initiative.
Academy of Digital Health Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online and self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace, anywhere in the world. More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 1 3 applications open. Become a certified hospital management professional. Professional development program in digital health for nurses. Accredited by the Indian Nursing Council with 50 CNE hours and 10 CNE credits. Professional development program in digital health for pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. Your learning, your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
I have it here. You can see it. Thank you. इसमें मेरा काम नहीं पा रहा है. Where is the pharma session?
Minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, and industry leaders in shared digital space. The app offers a robust set of features to empower users: disease-specific communities, a unified discussion feed, access to authentic resources, voice-enabled support, and patient-reported outcomes, or PROs. A first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes, along with the ability to post analysis. Fast forward to 2024, IPU held its annual conference, focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to NITI Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first IPU Foundation, designed to transform patient experiences into actionable policy recommendations. At the 2025 conference, held at the India International Center, IPU unveiled enhanced versions of the app, the fellowship, and the One Health Report, reaffirming its commitment to patient development and sustainable outcomes. Over the last 3 years, International Patients Union has been steadfast in its pursuit to create inclusive digital platforms for patient engagement, enable patients to shape and participate in healthcare policy, and drive systemic change through collaborations, advocacy, and storytelling. Join us and become a part of the Change Initiative.
Academy of Digital Health Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online and self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace from anywhere in the world. More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 100 leaders trained. Executive Leadership Program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional Development Program in Digital Health for Nurses, accredited by the Indian Nursing Council with 50 CNE hours, 10 CNE credits. Professional Development Program in Digital Health for Pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD Standards Office, UK. A 1-year comprehensive course on digital health. World's best faculty. You're learning your way. Explore all courses on web and app. To know more details, visit www.digitalhealth.ac.in.
This is not just a summary. This is where the future of healthcare takes shape, where conversations move beyond ideas and turn into real-world implementation. From powerful discussions to actionable insights, from innovation to execution. Welcome to the world's most impactful summit on digital health. Keynotes that think beyond insights toward real. A global platform bringing together global leaders, innovators, policymakers, and change makers, all working towards one goal, transforming healthcare. This is where collaboration meets opportunity, where vision becomes reality. Join us on 20th and 21st of November, Bharat Mandatory, unheard, for GDHS 2026. Theme, Implementing Artificial Intelligence, AI in Action. Be a part of the movement that's shaping the future of healthcare.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare use those minutes with the health movement. Are you? Research proves it. 70% higher retention with daily mindfulness. 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours. You need smarter minutes. Learn smarter. Grow faster. Lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, and industry leaders in shared digital space. The app offers a robust set of features to empower users: disease-specific communities, a unified discussion feed, access to authentic resources, voice-enabled support, and patient-reported outcomes, or PROs. A first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes, along with the ability to post analysis. Fast forward to 2024, IPU held its annual conference, focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to NITI Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first IPU framework, designed to transform patient experiences into actionable policy recommendations. At the 2025 conference, held at the India International Center, IPU unveiled enhanced versions of the app, the fellowship, and the One Health Report, reaffirming its commitment to patient empowerment and sustainable outcomes. Over the last 3 years, International Patients Union has been steadfast in its pursuit to create inclusive digital platforms for patient engagement, enable patients to shape and participate in healthcare policy, and drive systemic change through collaborations, advocacy, and storytelling. Join us and become a part of the change initiative.
Academy of Digital Health Sciences. Welcome to the future of healthcare education. At the Academy of Digital Health Sciences, all courses are fully online and self-paced, designed for busy healthcare professionals who want to lead digital transformation at their own pace from anywhere in the world. More than 750 enrolled and trained. Whether you're a clinician, pharmacist, or healthcare manager, we have the right digital health course for you. Postgraduate certificate program in digital health and diploma program in digital health. Become a certified digital health professional. More than 100 leaders trained. Executive leadership program for founders and CEOs of hospitals offered in collaboration with IIM Raipur. Tailored for hospitals to accelerate growth, optimize outcomes, and drive strategic digital innovation. Learn from the industry stalwarts. Make your hospital the preferred choice. Batch 3 applications open. Become a certified hospital management professional. Professional development program in digital health, accredited by the Indian Nursing Council with 50 CNE hours, 10 CNE credits. Professional development program in digital health for pharmacists. Essentials of Digital Health Certificate course accredited by the CPD Standards Office, UK. A 12-week global course. Diploma in Global Digital Health. Online self-paced accredited by CPD.
I request the audience who is out of the hall to kindly get back to the hall as we will be commencing with our session. Welcome back, everyone. I hope the lunch offered to you was not just a meal, but also I hope you guys had a great conversation as well. As we transition into our next session, I request our tech team to play the session videos.
गवर्नमेंट हॉस्पिटल में जो हेल्थ केयर फैसिलिटीज है, जो मेरा एक्सपीरियंसेस है, वो ओवरऑल इम्प्रूव हुआ है 10 साल में, और ये मेरा फर्स्ट विजिट है इस हॉस्पिटल में। जो भी होगा हम अगर आगे आप मिलेंगे तो मैं जरूर शेयर करूंगा। इससे प्रीवियस जर्नी बहुत अच्छा रहा।
ओवरऑल हेल्थ केयर पर्सपेक्टिव आप आज के टाइम पे कह रहे हैं कि बेटर
इम्प्रूव हुआ, बिल्कुल इम्प्रूव हुआ। मैं 2008 से दिल्ली में हूँ और गवर्नमेंट हॉस्पिटल विजिट किया हूँ, एम्स भी, सब डिवीजन भी। रिसेंटली 5 दिन पहले मैंने विजिट किया हूँ। बाकी मुझे बहुत अच्छा लगा। जो पिछले वीक का एक्सपीरियंसेस है, बहुत इम्प्रूव लगा। मैं इम्प्रेस टीम नीट एंड क्लीन, जो जिस हॉस्पिटल में विजिट किया हूँ, RSTC है नजफगढ़ में, नीट एंड क्लीन है। प्राइवेट ऑर्गेनाइजेशंस की कंपटीटर्स हैं, जो मेरा फील है, लुक एंड फील। क्लीनरी बहुत अच्छा है, स्टाफ बिहेवियर बहुत अच्छा है, हॉस्पिटल के जो इंफ्रास्ट्रक्चर है बहुत ही डेवलप हुआ है, डॉक्टर का जो कंसल्टेशन वे है बहुत अच्छा है। थैंक यू।
तो मेरा नाम उमंग त्यागी है, मैं गाजियाबाद का रहने वाला हूँ। तो अभी आज के मेरे पापा को बंदर ने काटा था, उसके लिए हम लोग हॉस्पिटल में आए थे, जीवी पर। ठीक है, तो सबसे पहले तो एक हमारी पर्ची बनी थी। ठीक है, पर्ची इजली बन गई थी, ज़्यादा बड़ा एफर्ट नहीं लगा था। उसके बाद में नंबर आने में थोड़ा टाइम लगता है। तो लगभग अगर हम 9 बजे आए थे तो 11 बजे पहला इंजेक्शन लगा था, तो 2 घंटे लग गए थे। अब मैं प्रॉब्लम की बात करूँ, पहले प्रॉब्लम है कि हाँ पार्किंग प्रॉपर नहीं है। ठीक है, पार्किंग प्रॉपर नहीं है, लोग बहुत ज़्यादा है, डॉक्टर कम है। ठीक है, अगर एक प्रॉपर फैसिलिटी मिल जाए कि मतलब डॉक्टर इजीली अवेलेबल हो जाए। ठीक है, और यहाँ पे मेरे को एक्सपीरियंस डॉक्टर मेरे को नहीं लग रहा, कोई सारे मतलब यंग डॉक्टर लग रहे हैं। ठीक है, तो एक तो पार्किंग की प्रॉब्लम है, दूसरे डॉक्टर कम है, तीसरे यहाँ पे फैसिलिटीज क्या कहते हैं, मेडिसिन इजीली अवेलेबल हो जाए। यहाँ पे मेडिसिन की भी थोड़ी सी कमी है, मतलब सबको इजीली मेडिसिन नहीं मिल पाती है, मतलब उसके लिए प्रॉपर अपॉइंटमेंट लेना पड़ता है ना। तो ये सब चीज़ें। बाकी आपका क्वेश्चन होता है।
Thank you, tech team. India is the pharmacy of the world. We manufacture 20% of global generic medicines, supplied to over 200 countries, and our pharmaceutical industry is valued at over $50 billion. And yet, patients in India often struggle to access, afford, or trust the medicines made right here. How is that possible? And what does it tell us about whether the pharmaceutical industry is truly patient-driven or profit-driven? I would like to invite our distinguished panelists to the stage. Dr. Rajendra Pratap Gupta, founder, International Patients Union. Dr. Raman Kumar, founder and chairman, Emirates Academy of Family Physicians of India. Mr. Sanjeev Navangul, managing director and CEO, Bharat Serums and Vaccines Limited. Mr. Abhijit Ghosh, Assistant Drugs Control and Licensing Authority, Department of Drugs Control, Government of NCT of Delhi. And Dr. Sanjeev Geeta Chaudhary, former Managing Director, SRL Diagnostics, former Area Director, South Asia, EI DuPont, India. To guide us through this session, I request Sir to take forward and moderate this session. Thank you.
responsibility word after lunch is a very heavy word. We have been always hearing this responsible AI thing. I sometimes wonder what is happening to our responsible real intelligence. And we all know that in healthcare, the most influential uh, part is pharma, not just by the volumes, but also the influence they have. And that's why we were thinking how to put them in a spot. And we had to coin this name responsible pharma, because if they did the job well, most of the things we have discussed in the first half would be addressed. And I can also tell you the good side or the right side of that. They are fairly good, well-meaning people in this industry, but very few. I would add that with a caveat. If I have to look at people in responsible pharma, 5 fingers would be a good number to think about. I'll give you a name. We had an experience for this conference. This is our commitment to healthcare, that we will keep hosting patients conference no matter how much loss we incur, and at a scale always bigger than the previous ones. We have been greatly supported by leaders who are there with us in the room, people like you who show up every year and discuss and ask the right questions that we want. We also have the luxury of having friends whom we can put on the spot. So while Sanjeev has been a friend for a fairly long time, he has never asked me what you are doing, what you want me for. He puts his word and money both at the same time, and I hope we have not let him down. Also, this time I had a good experience, someone whom we didn't know. I should put the name on record, so you should also get the good side of pharma. A company called Systopic reached out to us saying, here is our contribution. No matter what the number was, we didn't know them, we didn't approach them. So there are still people who believe that it is not just the patient. These are the people we are supposed to serve. So there are people like Sanjeev, there are people like Systopic owner. I'm sure there are many. We probably didn't reach out, but I must say that, in our endeavors, because what we run as initiative, every single minute we have a discussion going on. There is a cost that we have to pay to IIC or to organizers. So certainly sustainability is something that we all have to look at. So that's why we put responsible pharma in terms of what does the pharma industry do to address the issues of healthcare. While we talk about responsible pharma, we have been very vocal on the other side also of pharma advertising for products to make them OTC, for which I think the country will pay a price in the long run. That has also been a very serious cause of concern. But I'm going to start with my very dear friend, Dr. Raman Kumar, who has unflinching commitment to our initiative. Every time we ask him, he leaves his practice and shows up, spends time and happily and smiles, pretends to smile as well. So Dr. Raman, it's a pleasure to have you. On this topic of responsible pharma, as a clinician, you work with the pharma industry. How has been your experience in terms of saying how responsible has been the pharma industry in terms of addressing the issues through clinicians, outside clinicians with patients, and what would be your suggestions on that?
Thank you, International Patient Union and Rajendra Prasad sir, for inviting me over a period of years to this conference. And when I sit here, I sit with the responsibility that I'm employed as family doctor, family physician by the community. So my employers are my patients. So I have an obligation to serve their interest, because I'm not employed by government, I'm not employed by industry, by hospital or any pharma industry. But when I sit in my practice, on one hand, I have my patient and community whom I serve. And it is an overtly private environment where I do charge my patients for what service or consultancy or guidance or any intervention I suggest for. On the other hand, it is an open environment. It is not like Western Europe, or at least like, pretending to be, like in the United States, there are regulators and they work pretty stringent as what we do in India. On the other hand, we have industry representatives who meet us in our practice. There are hospitalists, hospital industry representatives, pharma industry representatives who wish to push or educate us about their services, products. And in a way, we have to keep a balance. I see myself as a regulator, a responsible person, because ultimately, what I said, that I'm employed by my community, the patient community. And at some level, even if there is push, I have to balance it with the interest of my patients, my patient community, and there is no way that I can, like a shopkeeper, if you आपने खराब दूध बेच दिया या कुछ ऐसा खराब दे दिया जिससे पेट खराब हो गया या सर्व कर दिया, तो अगली बार पेशेंट इज every consultation is your test, every patient is your test. Like I have 25,000 families in my practice attached to me, and I look after their healthcare in routine basis. And these all are educated people, high-rise societies, IT engineers who have traveled around the world, who know the things. On the era of AI, chat, GTP, everybody is informed and conscious about the choices that we suggest. So as a person for whom they come for a responsible answer for me, they are always curious, and they are also judging me every time. So even if there is push from the industry, there is no way I can evade the responsibility the community has entrusted on me, and ultimately I have to work in the interest of the community. So there are tens of visits of the pharma representatives, hospital representatives. I have to do what is right for my patient because I have to remain in business as a physician. And this balance, the entire ecosystem has to maintain. I mean, I'm talking about one practice, but the same applies to public health sector, private health sector, and in entirety on the entire country's policymakers, because there can be problems and leakages anywhere, from policy making to down into the implementation. So we have to be mindful that ultimately we are being judged on every action we do, and it is under scrutiny, not necessarily by the regulators, but also by the patient and the population, the voters, citizen directly. So we have to be mindful, and especially in the era, in the privatized environment, with the problem of overdiagnosis, overtreatment, where we have push for remaining one of the main contributors of the economic growth engine, pharma industry, which is the largest. So somehow, it has to be, auto-regulated, self-check and balance is important, and it cannot be out and out push and push. It has to be, introspection, and with the voices of the community is also important, like Patients Union. It is a very important forum for us to come together and virtually talk to each other and protect each other's interests. Most important, what we are all for, patients, community, and the population that we are serving. If that is our intent and ultimate purpose, we will all be safe. If we serve the interest of the companies, shareholders, boards, government, popular measures, this all may work on a short term, but on a long-term horizon, must serve the interests of the people, the community. Thank you.
Thank you so much, Dr. Raman. And I think the perspective that you bring out is that your employees are your patient. I think that's a very good perspective to have when you are serving, when you're in the field of medicine or healthcare. Coming to Sanjeev Navangul, whom I have known as someone who helps without asking, not just people in health outside. He's widely known, to reach out to help people. But Sanjeev, you also represent pharma. You are among, I would say from this dais, among the very few people in the industry left who think of the large canvas. You think about healthcare reforms and how to make a positive difference and an impact. Do we have this kind of leaders across board? That's first question. How do you define responsible pharma as a managing director of a large pharma company?
Thank you, Rajan. I think you have been a dear friend for now more than 20 years, and I've seen the amount of effort you have put in for India's healthcare. We all must be thankful to you for what you have done over the years. Responsible pharma is a very interesting term because it boils down most of the times to people saying that, are you making affordable medicines or affordability? Very narrow-minded, small part of the story becomes the largest discussion around pharma. I'll tell you why, and it is important to understand why, so that at least the people sitting here next time don't make it the primary issue. We have done enough studies, independent studies, to show that until about primary care and early secondary care, the problem we face in India is not so much of affordability as much as we have faced problems on access and reach. And please understand that access and reach has been much bigger issue for us than
affordability. If we have 70% women in this country with anemia and you have a tablet that costs 50 paisa per day, I think we must start thinking differently about affordability also. Secondly, India is slightly unique. And I don't get me wrong when I'm stating all these facts. It's important to understand all this. India is unique in terms of, if you take the top 50 economies of the world, 49 economies take citizens' healthcare expenses as their own and the government pays for it. In India, we are starting to learn that now. So we are still so far behind in understanding that healthcare is a government subject in terms of affordability. The social burden of affordability cannot be passed on to pharma industry. It's not the right thing to do. Yes, the industry needs to contribute and needs to do what it needs to do. Very important. But again, a responsible pharma company has to work on so many things. It has to work on access. It has to work on patient safety. It has to work on quality. It has to also work on ensuring that the awareness is created for the right thing. And, very fortunate to see Dr. Srinath Reddy here. He would remember that I actually coined the word responsible pricing when we launched Januvia in this country a long time back in 2007. The most popular diabetes drug of this country that we have seen. Yeah, and he helped us a lot at that time. No? We did a major course of about 12,000 doctors in the country. We trained on diabetes, how to treat diabetes. Because diabetes was an acute treatment disease in this country and how to make it a chronic disease treatment. So all these are responsibilities for pharma. All these are equally important from the pharma industry point of view. So many a times when we discuss responsible pharma, we need to understand that they have to serve a lot more things than what people think of. We have to look at unmet medical needs. Yeah, look, I think we have doctors sitting here. They will tell you that in hospitals, the amount of resistance to infections that is growing is tremendous. We'll keep bringing some new antibiotic, but it will take us few months or years and it will be resistant again. So these are issues that we face. So as a company, we are trying to solve for that. That doesn't matter whichever antibiotic, doesn't matter whichever infection. How can we solve a problem by which we can permanently say that, look, we can manage with the current antibiotics and still manage things. So now this is an unmet medical need to solve for. So as a responsible pharma, we need to do that. Yeah, so there are several things, there are so many diseases which treatments are imported in this country. Companies like us want to work and ensure that they are all made in India. Isn't that responsible pharma? To ensure that access improves because you make those medicines in India. So this is a much wider topic than what we think. And pharmaceutical companies generally think much deeper than what people understand. I think I want to make that into a very careful consideration for you people, that don't make it narrow in terms of affordability for a pharma company. In India, medicines are affordable to the extent that they can be. We are the lowest priced medicines country in the world, period. No other country, and you take per capita product, income from a PPP point of view, purchasing parity point of view, still you will find India the lowest. So we are not short of effort in affordability, but we are certainly short in understanding what pharma needs to do more and more in terms of patients. And the whole program now on Schedule M to ensure that all companies that work in this country have minimum quality standards that should be met is again a very important regulatory step that is being done, and industry is very supportive of it. Because we also don't want companies which cannot maintain quality should be part of this ecosystem at all. So these are important points from a responsible pharma point of view. On the other point that Rajan, you mentioned about, are there more leaders coming through? I think it's our duty to train them. And our job is to manage and train many people on trying to reach a point where they start thinking about healthcare in a much deeper sense. Yeah, and at least I continue to do my duty to ensure that a lot of leaders get trained in this. Ultimately, where they go, what they do is something that they have to build their own personality, thinking, approach. But our duty is to train them and help them, support them. That is something that Rajan, I can
assure you that I am doing it to the fullest. What comes out of it is what we will know with time. Yeah. But hopefully we will have great leaders tomorrow.
Thank you so much, Sanjeev. And I have no doubts that you're doing your best. In fact, he's come from Agra in the morning. He has to fly back to Chennai. I don't know which place. He has to rush from here. But I said, Sanjeev, I need you because you know what happens, and why I value these meetings. I'm sure there are a lot of leaders sitting here, which are on the back seat, they're in the front seat, they're on the dais. The energy in the room when you meet them, when you talk to them, when you get a chance to take them on the side and ask them question, you actually steal that nuggets of information that you won't get unless you meet them. The reason I get Sanjeev is he still remains a large canvas thinker. Whenever he will meet, he'll say, Rajan, what can we do? What is something that you're doing where we can help you? And then he will have his ideas. So I have no doubt Sanjeev is doing his best, but I wish that many Sanjeevs will come over a decade, who are sitting in the back. I have met you doctors in the third year, fourth year, nurses. And I believe that, if we can pick up discussions, not only responsible pharma, but responsible professionals is what will make a difference no matter whether you work for pharma, you work for diagnostic, you work as a regulator. Now coming to Abhijit Ghosh. Abhijit, you're a regulator. And what in your view is responsible pharma when you look at? Is it just the quality? It is going beyond quality? What exactly would that mean?
Very good afternoon. Thank you, Rajendra ji. It's a great honor for me to be here. And the topic is very interesting. As regulator, what is responsible pharma? We all are responsible. Regulators, manufacturers, both the chemists, all are responsible to make this, and the supply chain persons who are the retailers, wholesalers, all are responsible for providing good quality medicine to the patient. Regulators are always for the patient. Regulation of pharma is only for the patient to provide good quality, affordable medicine, safe medicine to patient is the most important responsibility of regulators. As Sanjeev ji has told, India is unique, really. In case of regulation also, India has a unique set, federal structure of regulation. Each and every country have single regulator. But in India, it's a very interesting and fruitful, robust regulatory system of central as well as state. It's most interesting that the state health is a state subject. And all the state drug control authorities are enforcing day to day, they are enforced how to provide good quality pharma product to the patient. Even today also, after leaving office, when I'm just entering the gate number 1, the call from some sub-inspectors of Kamla Market Thana that we are going to raid unauthorized, unlicensed premises. It is informed by some of our staff there. So immediate assistance is required from your drug control department. Just when I am opening the door, I contact my drug inspector and direct him, you have 1 hour to reach the DM office of Kapasera, because that person, sub-inspector, has no idea what is the location. So these type of activities are regularly going on. Even yesterday night in our Karkaduma office, the whole staff were busy to seize the items from different unauthorized licensing part. That is the work of a state drug control authority. It is not in Delhi. Each and every state, the state drug control authorities are looking after whether any substandard drugs are selling, is any drug without proper purchase bill are entering into the market, which is penetrated in the supply chain, spurious drugs are coming or not. So it's a good network, and that network is controlled by Central Drug Standard Control Organization. The smooth and peaceful coordination between all the state drug control authority and central drug control authority. Our drug controller of Delhi, Mr. Sanjeev Kumar, we are working under him, and Dr. Rajiv Singh Raghuvamshi ji is in state drug CDSCO. Even today, the 3 days working training is also conducting in Munirka, Health and Family Welfare Institute, for how the inspection of vaccine manufacturing units are coordinated and how the regulators can inspect properly. Today, regulators' work is not only enforcement, their work is to facilitate and to know how to improve the quality of the product and to know how the manufacturers are preparing vaccines and how the innovative product we can place in the market. Because you know all, the recent budget of 2026 and 2027, it has been clear that the Biopharma Shakti is the next future of India. And the Indian market is continually going from the volume driven to value driven sector. Pharmaceutical sector is now the basically value driven sector and innovation lead sector. So regulators also making themselves and upgraded themselves. Drugs and Cosmetics Act 1940 is a very old act and amended step by step and modified step by step. Medical devices are the new inclusion, medical device rule 2017. And not only regulators of state drug control and central drug control, the other central government's authorities are also there. Pharmaceutical pricing authority, the most important thing, what the patients are always aware, always asking question, maybe after that some questions for the pricing also. But the National Pharmaceutical Pricing Authority are playing a great role. They are now introduction some app of Pharma Sahi Dam app. You can easily track the actual MRP of the medical of your pharmaceutical product through this app. Recently, they are setting different PMRU, price monitoring and performance unit, in each and every state to check whether any company are pushing the more the price than the MRP as fixed by the NPPA. So regulators, from the beginning to end of a drug development, regulators are always stand for the patient and for the better pharmacy profession. Thank you.
Thank you, Abhijit, so much for enlightening us on that. And I think that's very critical for us, given the fact that we have around 7 lakh pharmacies or perhaps more. No one knows the real number. Now we come to Dr. Sanjeev. There are some people who create records and there are some personalities who are a record themselves. So for those of you who don't know the other side of his personality, he was the youngest PSU CEO in the country. A record of that will never be broken because the government changed the laws after that. So that is his guy. Second, he was also the CEO of founding CEO of SRL Labs. But I have not called him for these two. When he was the CEO of SRL Labs, sitting CEO of SRL Lab, I called him to a meeting. And that's where I called responsible professional. He went on stage to tell about the practices that were prevalent in the diagnostic sector when he was leading the largest lab chain in this country. And that is his professionalism. So Dr. Sanjeev, you have been a part of diagnostic sector, and that is one of the things in healthcare that most of the people go wrong. They keep running from pillar to post to find out what's the disease, and the diagnosis never comes through, but the treatment starts. Or the treatment doesn't start like we heard in the morning because diagnosis didn't come. What's your comments on the diagnostic sector in India? Is there any regulation that you know of or something that has come? So what's happening in the diagnostic sector, and how do we make it a responsible one for the farmer to be responsible? You can only have medicines when you know a problem.
Thank you. Life begins as a patient. A baby is a patient. The mother is a patient. In most cases, life ends also as a patient. So you start as a patient, you end as a patient, and of course, if you're lucky, then you don't become a patient in between, but that's very, very few. So congratulations, International Patients Union actually represents the mankind. There is no single human being who is technically not a part of IPU. We all belong to IPU. We wear different hats. We perform different roles and responsibilities. We are all an integral part of this. Health is critical. Over the past 3 decades, and I'm sure we have very senior physicians like Dr. Shrikant Reddy and many others who are here, the disease has become deceptively similar. There was a time when you could go to a family doctor and he or she will feel your pulse, feel your tummy, and probably diagnose you nearly accurately. That's unfortunately not possible anymore, not because the skills of the doctors have diminished. Skills have, on the contrary, risen manifold. The disease have become deceptively similar. A fever can be of 350, 400 types. A GI issue could come from multiple sources. There could be more serious problem than it seems to be on the surface. So you're right, Dr. Gupta, diagnostics are very important. 70% of decisions, that's the often quoted statistics, but I think the real number is perhaps 95%. 95% decision of a doctor on what he or she is going to do with a patient depends on what is the diagnostic output, what is the test report, what is the pathology report, what is the radiology report, or whatever may be required. Now, we are a very unique nation in this regard. I'm glad you didn't talk about affordability because I will only second what Sanjeev ji said. Our test prices in India are the lowest in the world, not by a small margin. We are lower than Pakistan, we are lower than Sri Lanka, we are lower than Bangladesh, we are lower than Nepal. Okay, so we can't get any lower. 3 things need to be done, and I am venturing into the domain of a regulator in some ways. Never ever control price of anything. There is no greater wisdom than the market forces. If I get elected as Prime Minister of the country, which is a very low probability, I would take away DPCO. We have compromised the quality of our medicines phenomenally. Our drugs are the cheapest in the world, but the brand owners cannot afford to manufacture it themselves anymore. It is outsourced, outsourced, outsourced. And because there is a price control, we come with a quality which unfortunately is not what the doctors expect. There may be some merits, I'm not denying that. But my job that Dr. Gupta referred to, I used to be chairman of a company called Modern Foods, which was India's largest producer of bread. And when I went for my first meeting with the then Prime Minister, late Rajiv Gandhi, he asked me, why is the quality of bread in India not good? Why is Britannia lousy? Why is Modern lousy? Why is Wibs and everybody else lousy? I said, sir, please remove price control. We will give you the best bread in the world. It took him 6 months of back and forth. The price control was removed. And I'm giving you a very small example. The moment you control price, what is the logic? There used to be a department in the government called Bureau of Industrial Costs and Prices, BICP. All the companies used to send data every month on what's the cost of raw material, what's the cost of labor, and what did they do with their data? Nobody knows. Eventually, we did not need the Tesla CEO. It was removed by the government as a part of the efficiency drive, the BASP, I don't think it exists anymore. So, if diagnostics have to do their part well, we need to regulate quality. Dr. Reddy has gone on record that if there is a registry of deaths in which misdiagnosis is also a point, we maintain registry of death because so-and-so died of cancer, so-and-so died of heart disease or whatever else. But in that list, there is no misdiagnosis category. And if misdiagnosis is put as a false diagnosis, misdiagnosis, whatever it is, because the point I'm making is very important, we have 150,000 testing laboratories in the country. 1.5 lakhs. Out of these, 50,000 laboratories exist inside hospitals. 50 or 55,000. The remaining 90 odd thousand or 1 lakh laboratories are what we call high street labs. And how many labs are accredited? Less than 3,000. 3,000 divided by 1,50,000. And who is the biggest culprit? The government. Other than PGI microbiology and now Sir AIMS microbiology, there's hardly any government lab that is accredited. So we do not know, I'm sure the experience is enough that people are giving correct results, but whether they are correct or not, we do not know. Accreditation is making sure that the equipment is running correctly, the calibration is happening correctly, the malpractices of using retired reagents, expired reagents is not there. So the task of the government is to regulate quality. So my one recommendation, sir, to you is that let accreditation be mandatory. No exception. Give 5 years, give 3 years, give time. And take NABL outside of Ministry of Science, put it in Ministry of Health. NABL is a common body for forensic labs, environmental labs, agricultural labs, material labs, and also medical labs. So you cannot get justice. There may have been an historic reason when Pandit Nehru devolved the creation of Department of Science and Technology as the first Prime Minister and put this as a subject under DST. It needs to be, I remember Shatrughan Sinha ji was the Health Minister of India, if some of you remember, and he went to CDC in United States, and he was told that we have an accreditation process, and he made a statement there, we have no accreditation in the country because it was not under Ministry of Health. He didn't know about it. And he really wasn't a literate politician to know what happens in the rest of the sides of the government. But glad his stint was not that long. The point I'm making is mandatory accreditation, quality testing, separate it from Ministry of Science, bring it under Ministry of Health, and if possible, bring health quality as a central subject. Don't leave it with the states. Let the states enforce the central. Because now there are so many variations. I have run a lab system which had presence in 30 states. And we had 30 different sets of norms to deal with, which is not the intention. It only adds to the cost of doing business. So let's get things right. Diagnostics are very important. Let's give them the importance. Whether you bring them under whether you bring them under the existing licensing system or bring a new regulator of which there is often talk, but please do not control prices of any tests. You're free. If you can't afford, you can always go to a government hospital. It's free. And if I am doing something different, something superior, I cannot be told what should I charge. My price doesn't suit you, don't come to me. You can go to any other lab. There is a lot of quality cost that is involved in testing. And therefore, let the wisdom of the marketplace in last point. The industries, the segments where India has become number one, dairy, because there is no dairy price control. Vegetables, fruits, we have become phenomenal because nobody tells you at what price you can sell potato and onion. Okay, so let the market forces, you may have 6 months of pain, but eventually the wisdom of the marketplace, and we are a country of entrepreneurs. If we find that SRL or Dr. Lal or Thyrocare is making enormous profit, many more will come in. Many more will come in. But let's do the right things. Thank you.
Thanks. Thanks, Dr. Sanjeev. I'm not sure if you would become the Prime Minister after these statements because price is a very sensitive subject. More than that, I think quality is an important thing when we talk of responsibility across healthcare. Price is also one of the responsibilities, that we know of. I'll go back for a few questions again before I open. I guess I'll have time for questions from the audience. So, Dr. Raman, I have a question for you. Last couple of days, I'm using the algorithmic, design of social media, and I've been scrolling some of the recommendations made by doctors. And the recommendations are, for this problem, this is the antibiotic, please take a screenshot. For this problem, this is the antibiotic. On one side, we are talking of AMR. Other side, social media is flooded by doctors saying, you can take antibiotic for this. For diabetes, this is the medication. This is the dosage. They've gone to the extent of telling even newer medications that you can start with micro dosing and keep increasing. So as not only as an individual clinician, but also as the chairman of a large body of clinicians, are we leaving that also to market forces, or are we self-regulating it? And what we should be doing for that?
I think the professionals are a very small part of the industry. I mean, they don't have much power to overturn the table. So I would say yes, I mean, because we are the most regulated part of the entire industry, physicians. I mean, if you go by healthcare advice on social media, anybody can give advice, all types of diet, all types of medications, all types of lifestyle changes, all types of interventions, what not to do, what to do, what to eat, what not to eat. And largely physicians, doctors, medical professionals are averse of idea of giving advice on phones and WhatsApp. Largely, in spite of being legalized after COVID, but still large number of doctors would not share their mobile numbers with the patients for medical advice at least. So still there is reluctance, I would say, not if there is some aberration, that is all because of the para-professional kind of, non-qualified people, digital quackery, that kind of thing is happening in the environment. But I said, coming back to your original question, physicians have very little power in the entire industry, or doctors as a whole. So we have to consider and think. And this empowerment will come if we make partnership with the patient community. And that is our power.
Would you have a code for doctors within your community that you run as one of the largest associations, that what not to do on social media is to start doing a digital prescription without understanding who the patient is?
I think we are covered by Consumer Protection Act and also our NMC code of conduct. So a separate code of conduct is not required. We need to simplify what is required to be done. A common judgment that we do for our patient community applies to same to ourselves, our own health of our practices. So we not expose ourselves risks to anything that is not, covered, because we are exposed. Consumer acts and patient rights groups, even the police action. Anybody can, we are exposed to all kind of risks. So code, of course, welcome, and it is already in force sufficiently on us. And a large number of doctors are actually afraid of practicing because of these codes and legal implications and consumer court implications. So we have to, they're already suppressed in the sense that it's not that they're trying to break those codes or doing something not required to be done. So we have to understand that when we ask physicians, they are already not in position to make risky choices. Code are welcome, and always welcome, because they are not going to change our practice in any ways, because it's all in the environment, ecosystem. Codes will apply to the professionals, and we do practice. If there are separate codes, most welcome. By the industry, more welcome.
So, this is one last question, and any of the panelists can answer before we move to ask, you can ask questions. One is, that this is not just pharma. If you look at diagnostic, they started commoditizing tests, saying 130 test for the price of 800. So please take. No one knows after that test what do you do, what comes out of the test. No one knows how to read a test. Then came the wave of course, as I said recently, maybe to get social media followers, they start putting prescriptions, and this has been blatantly on at least Instagram, where they started putting antibiotic prescription for cough, cold, and saying this is the azithromycin you can take for this much. So this is something that came from doctors. The last something that has been very bothering me is like pharma company going all out on ads saying you can do this. Now, which path are we taking? And that's why, our reason of putting responsible pharma was, and this I'm not putting anyone on the spot. If any panelist wants can take this to answer. How ethical it is for diagnostic companies to say, okay, these are the tests. You do a test when you have a need or there's a preventive care. So you say these many tests you can do for the price of 700, 800, that's one part. Then saying these are drugs. Some companies went to the extent of even, I think, commoditizing obesity, clinically calling it disease. I mean, I was shocked to see in Saket City Mall, 2 obese women being shown saying, this is a disease, go to a doctor, sponsored by this. So what extent will companies go to be still bracketed as responsible? And I'm surprised these were MNCs, not Indian companies. Yeah, so having said that, I would put this open to my panelists should they want, but they're absolutely at freedom to use the Second Amendment, as they call in the US, not to answer. So you are absolutely free not to answer, but if someone wants to answer, saying, where do you draw the line to be called responsible? See, money is important, but there was the quote of Merck's founder, which I like the most. He said, if you keep people at the center, profit will never fail to appear. But I think we have forgotten that.
Let me just take a. Yeah.
First of all, as Dr. Sanjeevji has told, for diagnostic purpose, whatever the regulations are there, and regulators are fully responsible, government is fully responsible. But one thing we should know, that regulators are controlling the product. In vitro diagnostics has a proper regulation in India under the medical device rule. And there are lots of companies that are manufacturing different medical devices, diagnostic devices, IVDs. There are lots of companies that are manufacturing blood pressure monitoring, BP monitoring item, sugar testing monitoring item. But that sugar testing monitoring item has the license. But the strip which is using for detecting the blood parameters, there is no particular regulation who are the person who are manufacturing that glucose strip, on which base, what is the platform, what paper is used, what are the metrics on it. The cost is depend upon that thing. Yes, so you directly giving responsibility to government that they are not checking, but it is also important the multinational companies using that platform, ETO platform. It's a high quality platform. That's a ETO platform. It's a very costly. The detection of blood parameters are very accurate there. Some companies, their local companies using some papers which is very low quality, matrix is very low quality, but using this machine for detecting the parameters. So if you test your own blood in different companies of strips, you will get different results. So that is not only the responsibility of regulators only to control, it is any diagnostic centers are not regulated by any particular drug authority. In vitro diagnostics are licensed by the department, state drug
My,
department.
my question was on advertising. So like guideline. So
no, one
Sanjeev, you
thing,
want to chip in on that? I don't want to
yeah,
put you on a spot, Abhijit. I know that
yes,
it is
that
sensitive for
is,
you not
listen,
to. But in fact, we had to ask the government to stall that because we had to request the government. This is not done. So we had to actually push the government. As health parliament, we said no, it's not acceptable. And I think CDSO has done a good job by saying you can't advertise like this.
Completely agree. The very blatant consumeristic advertisements by diagnostics industries are unethical. Okay, this is not a toothpaste that you can buy one more. All right, if you need 4 tests, we are pushed. My fraternity pushes patients कि आप ये सारे पैरामीटर करा लीजिए, ये सस्ता है. Buffet is cheaper than a la carte. Okay, so you're right. What to do with it? Do I need it? All of these are very relevant questions. I think we need to bring some degree of self discipline through Nat Health, through PHFI sponsorships, through the forums that the industry has, that let us stop. But the issue is these so-called health packages. I know for Dr. Lal Laboratories, it is 700-800 crore rupees brand. So it's a very serious decision. For ThyroCare, which had a test menu of only 100 tests for a long, long time, whereas on human body you can do 5,000 tests. But they had Swasthafit or something like that. That became 300 crores brand. So everybody has followed suit. So you do a DIY, that doesn't work. I recently saw a very beautiful cartoon. Somebody went to a doctor and said, वहाँ लिखा हुआ था 500 rupees consultation fee. So he said, lady doctor से कि आप 500 रुपया लेती हैं दवाई लिखने का? उसने कहा हाँ, ये तो बहुत ज़्यादा है. So the doctor said, आप अपने आप लिख लीजिए. So she said, मुझे कैसे पता लगेगा क्या problem है? What is? How will I know? So she gave one large Gray's Anatomy और big book. इसमें पढ़ के देख लीजिए. तो इससे क्या पढ़ना है? तो वो तो अब आपके ऊपर है कि नीचे आप 500 ले लीजिए, दवाई लिख दीजिए. The most difficult profession, and I'm glad the point that doctor made here, Dr. Raman Kumar, the most difficult profession is to become a doctor, a physician, a surgeon. Very, very difficult. Of all pursuits of study, this is the most complex and ever evolving. It's not one civil services examination that you pass and you're done for your life. No. Every day situation changes. New tests, new medicines, pharma. And again, I think it's not that the entire pharma, I mean, Merck put a principle there that you do the right things, profit will come. So onus of self-discipline is equally important, but I think if a regulation needs to come to stop all of this, we must put in place.
A quick point on it. First of all, none of us should be in healthcare because it is a business. We are in healthcare, therefore it is in business. But I don't think it's appropriate, and that defines the difference between what is right and wrong in our healthcare system. And therefore, what do we advertise, what do we speak is all about what impact does it going to have? Is it going to be primarily driven by my objective to increase my business? Or is it going to do it for patient benefit? Are the two different questions that we always need to answer. There is a completely irrelevant, I think the right word would be stupid, Magic Remedies Act 1954. Yeah, it's one of the stupidest act that India has, and which should be thrown in the dustbin. You know, the only place it deserves it to be in the dustbin. It has no relationship to what should be done today. It has no consequence to how these current media should be regulated. And I'm being very harsh on this forum, but it is the truth. Yeah, and we continue to have it. 1954, what was written is still relevant today. Yeah, but amendments also are, 1978 kind of amendments. I don't think they're relevant. Yeah. So, yeah, we have to redo everything. And I'll give you a simple example. What you mentioned about more tests or driving people to call for action for wrong reasons and business reasons is not something we need. But we also need to be, keep in cognizance the fact, for example, ours is an aging population. Adult vaccination penetration in this country is less than 1%. So if there are people who want to really work to improve adult vaccination through, through a program or through more awareness, I think it's a good thing that this country will do. It has public health good in it. So I'm just giving you one example. So we have to differentiate what is good for our society and what is not good for our society. And that differentiation regulation is not there.
Thanks, Sanjay. We can take two questions before we end because I think questions are important. So who has not asked a question should ask first? You have not asked? Let us give them a chance. Please take the mic to the last. Please tell whom you want to ask the question.
Good afternoon, everyone. I want to ask question to Abhijit sir. Abhijit sir, I wanted to know that how, as a regulator, how you can choose that patient-centric term is not just a marketing term for marketing firms, rather than it should be patient-driven term. That marketing companies are usually using we are patient-centric, but actually the truth is little bit different. So how, as a regulator, you can act upon that part?
I've already told that regulators are standing along with patient from beginning to last. But that's mean since the discovery, when the active ingredients are performing the companies performing clinical trial, that time regulators are there. And when the same product is supplying to a patient through a pharmacist from retail shop, that time also regulators are there. That is that is the reason the regulation is always patient centric, because trust and your quality and regulations, they are the most important part for the authenticity of the actual drugs, and patients want the actual drug, authentic drug. So regulators are the part of this, playing this important role to provide the authentic drug, the active ingredients which is accurately required for the patient to provide him. That's all.
Anyone else who has not asked a question wants to ask? Okay, go ahead. That's the last. You? Okay. I think one lady and we'll have the gender balance and then we'll close the session. But these guys are going to be around to talk to the yes.
Good afternoon to all of you. And first of all, I would thank to be a part of this Omega celebration for the patients, because it is for the first time that I have seen such a gathering for the patients, because I may not have been knowing this. So thanks, Gupta sir. My question is, I am a part of a responsible pharma. First of all, I would proudly announce, because I'm working with a company called Systopic for last 23 years. And I think this company has taught me in my personal values as well as professional values that how one should be patient driven. Because for last 23 years, we have been serving patients irrespective of the fact that whether profit comes or not. But yes, rightly said that when patient is in the center, profit will definitely follow. So my question is, sir, I have observed during my last 26 years in pharma industry that there are companies, there are brands, they are manufactured from the single unit, but prices ranges from, for example, 3 rupees to 25 rupees. One company costing a drug 25 rupees a tablet, one company getting manufactured at the same manufacturing unit costing 3 rupees or 4 rupees. Can we claim that that quality is inferior? Can we claim this? Sir, anybody can answer. All panelists are respectable for me.
As I told you, regulators are enforcing the rules.
Right,
but
sir.
Pricing is a subject of National Pharmaceutical Pricing Authority, as I already told. But your question is very important, but the common people has that idea which product I am getting in 3 rupees, same product, others company are giving me 25 rupees.
Right,
So
right.
obviously there will be a difference in quality. That's not a wrong thing, right? Wrong concept.
Yes.
Because you know, India is the number one in globally for supplying the generic product.
True, sir.
And government of India is promoting generic.
Right.
So now the Pradhan Mantri Jan Aushadhi Kendra, you are getting the item from Pradhan Mantri Jan Aushadhi Kendra, and the same item you are getting from any other multinational company's product.
Very right, sir.
Active ingredients is same.
True, true.
So that is the question. Others cost, sir is here. He knows very well more than me how the
Right.
packaging, how the labeling, how the total processing cost are increasing the value of the price of drugs.
Right.
So in case of generic product, the other part, they are trying to make it less.
Sir,
But
yeah.
the active
I
ingredients,
think
right,
we'll have
processing
to
is same.
call the discussion because we are over
Yes.
time.
Yeah.
But
That
I
is
think
the
this requires a separate session itself. I think
But
we have a
don't-
long way to
don't
go.
worry, the
Long way to
product-
go before we become responsible pharma.
The performance is same.
Thank you, sir. Thank you so
Okay,
much.
all the way.
Thank you so much. Over to Harsh.
Thank you so much to our distinguished panelists. Indeed, the pharmaceutical as well as the diagnostic industry has enormous power to heal or to harm, to empower or to exclude. Today's conversation is a reminder that with the power comes accountability to the patient. Now, I would request all the panelists to gather up in the front for a group photo. Meanwhile, I would request all the audience members to scan the QR code on their lanyards as well as kept on their desk to fill in the Mentimeter questions. Thank you so much. Can we have a round of applause for our distinguished panelists? And now, the segment that we believe is the heartbeat of IPUC, the open mic. All day, you have listened to experts, doctors, policymakers, and advocates. Now, we hand the stage over to you. For this session, I would like to invite Dr. Rajendra Pratap Gupta, founder, International Patients Union, and Dr. K. Srinath Reddy, sir, founding president, Public Health Foundation of India. Whether you are a patient, a caregiver, a healthcare professional, an innovator, or a policy enthusiast, your voice deserves to be heard here today. No invitation needed, just hand raised. Ground rules for open mic. Ground rules. Maximum 2 minutes per session. Please respect all perspectives. Feel free to share your perspectives and story. Ask questions or make recommendations. Our volunteers will bring mic to you. You just have to raise your hand. Thank you so much. Now you can start raising your hands so that our volunteers will bring mic to you. So can we have the mics given?
डॉक्टर साहब मेरा नाम गिरीश अग्रवाल है। जहाँ तक मैं समझता हूँ एज ए पेशेंट, ये रिफाइंड ऑयल जो है कोलेस्ट्रॉल के बारे में जो फाइंडिंग आई थी ओरिजिनली उसके कॉन्टेक्स्ट में आया था, जो बाद में रिवर्स हो गई है ऐसा मैंने समझा था। लेकिन अभी तक कोई रेगुलेशन नहीं है रिफाइंड ऑयल पे, जबकि ये कहा जाता है कि उसके ह्यूज मतलब साइड इफेक्ट है।
ये मालूम नहीं है कि मैं यहाँ बैठ के क्या जवाब दूँ, लेकिन what we'll do is, the whole idea of this forum is that you can put your suggestions, you can put your questions. Our team will collate with them. If they have to go to regulator, to the government or to the industry, we take it up.
सजेशन है कि इस पे रेगुलेशन
Sure,
होना चाहिए,
sure.
बैन होना चाहिए।
Sure. Dr. Reddy, you have any views on that?
Do we have any other question?
Good afternoon, sir. My name is Vidhu and I'm representing ICRIS Pharma. I'm a part of rare disease team therein. My question is relevant to rare disease segment only. And first of all, I must appreciate the theme for the conference. Looking to the landscape of rare disease in India, we appreciate the policy, the NPRD policy, which has come in 2021 to support the patients with respect to providing a grant, one-time grant of rupees 50 lakhs to the patients. But having said that, we find that most of the treatment cost goes much way higher to that. So talking about the concept of access as well as affordability, and having been into this segment where I'm taking care of the backward linkage, we are in no touch with the market authorization partners. We have been trying to reduce the cost, as the previous speakers were also speaking upon, that India, we are providing the lowest level of medicines. No, having said that, government has done their part. Don't you think the private partners should also come up with some of the policies, to support, to handhold the patients of rare disease, so that at least they should complete the cycle of treatment? So this is my suggestion, to you, to the policymakers, to the government of India, if we can do something on this. Thank you so much.
We'll certainly do that. There are three sides of this rare diseases. One is, the cost of developing a drug is not small by any standards. But also when a pharma company develops a product, it needs to have differential pricing. You can't have the same pricing for developing country, underdeveloped, and a developed country. So that is the job they have to do. As a government, I think whatever it could do, it said we could pay 50 lakhs, which I think is a fairly good step and a good amount of money. So I think all have to do their job. We can't say that bring it down to so low so that you stop R&D. At the same time, if they do their R&D, what kind of pricing it can, what government can do. I think from the government side, they have taken a good decision. Now it's for the industry to take a call. Do they want to sell for 14 crores or they want to sell for 50 lakhs? I'm not sure what suggestion we can give, because I'm happy at the amount that government is giving. It could grow, but it could also be that you could club CSR into helping some people.
That's what could be a possibility. Either we make it disease specific, patient to patient, because the gaps with respect to the treatment is quite high. So with respect to CSRs, or maybe some kind of mandate should come in this framework as.
So if you do compulsory pricing, you will kill that product. Simple as that. So I think I'll be happy to engage. You can engage with the team at International Patient Union, and they'll be happy to discuss with you the advocacy part. Dr.
We'll certainly do that, sir.
No, in the tea break we had discussed,
Yes.
and I also discussed CSR with her. That's it.
Thank you so much.
Thank you. Do we have yes at the back?
गुड इवनिंग सर। यहाँ पर मुझे कॉन्फ्रेंस में मुझे एक चीज़ फील हुआ कि यहाँ पर सब लोग पेशेंट केयर, क्वालिटी केयर, हर चीज़ के बारे में बात किया है। अच्छा लगा मुझे। मैंने अभी पहले बार सुना कि पेशेंट की कॉन्फ्रेंस के बारे में, इधर फार्मास्यूटिकल हो, गवर्नमेंट सेक्टर, वॉट एवर इट मे बी। आई एम फ्रॉम द नर्सिंग प्रोफेशन, एज अ नर्सिंग फैकल्टी आई केम हियर, बट व्हाट अबाउट द मैन पावर? मतलब आप गवर्नमेंट सेक्टर में देखेंगे, कोई भी प्राइवेट सेक्टर में देखेंगे, व्हाट आर द एम्प्लॉयज, व्हाट द इश्यूज दे आर फेसिंग। अब ओवरबर्डन होते हैं, इतना पे सारे पेशेंट्स आते हैं, तो हाउ कैन वी सेटिस्फाई द पेशेंट? पेशेंट आते हैं क्या, ये सिस्टर अच्छे से बात नहीं की, डॉक्टर बिल्कुल देखा ही 5 मिनट के लिए, तो मतलब पेशेंट वेल गिवन द क्वालिटी ऑफ द केयर, कोई भी मैन पावर का, कोई इनका एम्प्लॉयज का, इनका जो नीड्स प्रायोरिटीज कभी नहीं हो सकते। तो इज देयर एनी concern about the manpower, either pharmaceutical company or the health department, healthcare professionals? So that is my view. I did not concern this point. Conference is very, very thanks sir for giving this opportunity for asking this question.
आपने बहुत सही फरमाया है कि अगर डॉक्टर, नर्सेस, प्राइमरी हेल्थ केयर वर्कर्स, जो फ्रंटलाइन वर्कर्स हम कहते हैं, वो सफिशिएंट संख्या में नहीं है, प्राइमरी केयर में भी और हॉस्पिटल्स में भी काफ़ी शॉर्टेजेस है। कम्युनिटी हेल्थ सेंटर्स में स्पेशलिस्ट का 60% से ज़्यादा शॉर्टेज है। तो ये आवश्यक है कि हम ये हेल्थ वर्कफोर्स की संख्या बढ़ाएं, उनके स्किल्स बढ़ाएं, और जहां आवश्यक है उनका सैलरीज भी बढ़ाएं, ताकि वो लोग सिस्टम में रहें। तो इन सब चीज़ों के बारे में मेरे ख्याल से ध्यान दिया जा रहा है, मगर ये एक तो सेंट्रल गवर्नमेंट का भी जिम्मेदारी होती है और स्टेट गवर्नमेंट्स का भी होती है, दोनों मिलके इस प्रकार का स्कीमें बनानी चाहिए जिससे कि हेल्थ वर्कफोर्स में कमियां पूरा हो जाए। पर एक और बात है, हमें हर वक्त डॉक्टरों के ऊपर और पूरे फुल्ली ट्रेन नर्सेस के ऊपर डिपेंड नहीं होना चाहिए। ये सेल्फ केयर, फैमिली सपोर्टेड केयर, कम्युनिटी सपोर्टेड केयर, ये पूरे भी संभव है आजकल के डिजिटल टेक्नोलॉजी में, उनका भी योगदान हो सकता है। और दूसरा ये भी आवश्यक है कि हमें ये जो फ्रंटलाइन हेल्थ वर्कर्स को सपोर्ट करने के लिए डिजिटल टेक्नोलॉजी का प्रयोग भी करना चाहिए, इससे थोड़ा कमियां पूरी हो सकती हैं। मगर आपने जो मुद्दा उठाया कि इस पर ज़्यादा ध्यान देनी चाहिए, ये बिल्कुल आवश्यक है, क्योंकि हम जो एंटाइटलमेंट्स की बात कर रहे हैं वो कभी हम पहुंचा नहीं सकते बेनिफिशरीज के पास अगर स्किल्ड, मोटिवेटेड एंड प्रॉपरली डिस्ट्रीब्यूटेड हेल्थ वर्कफोर्स अगर हमें नहीं है।
थैंक यू सर।
और इस इशू पे हम लोग ने पेशेंट्स यूनियन में भी और अपनी दूसरी फोरम पे भी जो हेल्थ वर्कफोर्स है उस पे सेपरेट डिटेल डिस्कशन किए हैं, सिर्फ अभी के लिए ही नहीं, आगे क्या जरूरत है उसके लिए क्या करना है उस पे भी, और उसके पूरे कॉम्प्रिहेंसिव नोट्स हैं। इनफैक्ट आप अगर हेल्थ पार्लियामेंट की ऐप डाउनलोड करें तो उस पर आपको वर्कफोर्स ऑफ 2025 एंड बियॉन्ड मिलेगा पूरा। और हम लोग डिस्कशन करते हैं, अगर आप पूरे सेशंस भी देखोगे तो इंडियन एकेडमी स्पेशलिस्ट एसोसिएशन के प्रेसिडेंट भी थी, फैमिली फिजिशियन के, अब इंडियन नर्सिंग काउंसिल के प्रेसिडेंट भी आ रहे हैं। तो वी मेक श्योर दैट वी हैव representation of every person from the workforce on our panels. And not only that, in fact, since you said you are a nurse, and let me tell you, and this is very open and we are very privileged that this is one profession where we have seen overwhelming response. Anything we have done, we thought they were overworked, underpaid, but despite all constraints, I think I salute nurses that you have shown fantastic support to all these initiatives. In fact, we are conducting a study on impact of nursing and health in India. Till today morning, we had 748 responses. I don't think any professional in healthcare will get so many responses. Despite all odds, I salute you for your enthusiasm and commitment to health. Thank you.
Thank you, ma'am. That was quite a powerful perspective. Do we have any other questions from the audience members for our panels?
Good evening, everyone. Sir, there has been not a law, but a way in which NMC and the earlier organization used to advise the medical professionals to write generic names and probably capitals and printed prescriptions. And there has been flip-flops way back 2022, 23, there was something which came in and went back within less than a month. And I being in a similar field, I have seen more than 1,000 names, brands, which are used by multiple companies having different molecules. So if I go to one store for a brand, I might get a paracetamol, and the other store I might get an azithromycin. So there are more than 1,000 brands that I've seen. And more so if I start using the sound alike brands. Sound alike as in E and I difference hai, and the entire thing is different. So there are so many of them, and I see a potential risk which is there. And then still there is no law which is practically implemented on ground that molecules should be written, not the brands, or along with the brands as a mandatory, because it becomes extremely difficult if we at our level are not able to understand. I don't know if patients at their level will have any idea. As you rightly said in the opening, that hardly 76%, or not even 76% of the patients do not understand the prescriptions. So this is going a couple of steps forward from there. So this is one of the big problems.
Well, I fully agree with you that drugs should be prescribed in generic forms, and the prescription should be written in as decipherable manner as possible, preferably with capitals. That's what I used to do when I was in All India Institute, and occasionally when I still read any prescription, I do that. The problem about writing generic drugs, or at least the generic name of the drug, which is the ideal solution, is also potentially open to exploitation by the pharmacist. Because there are a number of formulations with the same composition. Some are generic drugs purely, some are branded generics, and branded generics of different companies. So the pharmacist can exercise his or her own judgment to tell the patient that I'm giving you this drug, but choose the highest priced branded generic. So you're transferring the power of the doctor to the power of the pharmacist. Both can be, erroneous in their approach. So we'll have to find a solution for that. One of the possibilities is, yes, everybody must write generic drugs in the generic formulation, must write in capitals, but every pharmacy should have a digital display on which the patient can say, okay, if this is the drug that I want, these are the formulations available under different names of different companies with different prices, and choose from them, so that the pharmacist is not taking the patient for a ride by suggesting that this particular branded generic is much better than that particular branded generic. So you have to empower the patient not to get exploited. But certainly the point that you have made, that making doctors habituated to writing the formulation in a generic format is important. Though sometimes it gets complicated because of the names of the chemicals, but still we can do that by some suitable abbreviations and others. If you have any suggestions, please let me know.
So you run a pharmacy chain, right?
Yes, I run a pharmacy chain.
Yeah, I was interacting with you. See, what he has made is a very interesting dimension that most people ignore. His point is right that if you leave it at the mercy of pharmacists, I mean, not everyone may be like you. So you are shifting the challenge from a doctor to a chemist now. Now he could play much more different level altogether.
I completely agree.
Now,
with you.
how do you answer that? I think what government has tried to do, though unsuccessfully, is stop promotions with doctors. Let doctors choose the brands, but don't give them those foreign junkies and all. I don't know whether that's going to be the right way, but certainly, I mean, a middle path between leaving the chemist to decide which brand to give in the name of generic versus which one doctor will give. At the end of the day, it's from frying pan to fire, whichever way the patient will get to. It's a tricky one, though.
I don't disagree with you completely, because I know, despite having run a pharmacy chain, I know there are more than 8 lakh pharmacy stores in the country, and how many of them are actually doing justice to their name. So I'm not proud of it, honestly. But what I can very clearly say that the way there was an effort to practically root out all the non-compliant pharma manufacturers in the country, which was a hats off to that task, no doubt about it. I think it is time that pharmacy as a business or pharmacy as a vertical of healthcare also needs that cleanup by introducing a far higher level of trace and track. When I say trace and track, I have seen countries like Nigeria's of the world, the Africas of the world, where there's a trace and track. I have each and every tablet getting tracked, that this tablet was manufactured at X place, transferred with Y supplier to Z distributor to A retailer and to B patient. That is the level of trace and track they have in a lot of African countries. That can be done now that the pharmaceutical manufacturers have been upgraded. That is something that can be very realistically done, and that will effectively root out a large part of the pharmacies which are not doing justice to their name. But I don't know if this is a solution which will take 3 years or 5 years, but I think that's a big step in the right direction.
Certainly from quality and safety monitoring point of view, that's very, very important. But I think expansion of the Janaushadhi chain is also going to be very important in making sure that the generic drugs are widely available for purchase.
That is available, sir. Today it is absolutely easily available. There is no, when someone said access today is no longer a problem. You can get whatever drugs, wherever in the country within 2 to 3 days. So trace and track will solve, I think, the next level of problems. Yeah, but
Thank you, Dr. Rajendra, for curating such a wonderful learning platform. On the issue of responsible pharma first, I wanted to actually put in a point to Dr. Sanjeev Chaudhary, who probably is he there in the audience?
Just left, I guess. Maybe out.
Yeah. So because you asked very pertinently about when the free market dynamics should prevail, and somebody, Mr. Sanjeev, the other Sanjeev, actually pointed out the public good action as a part of responsible pharma. And what Srinath Reddy sir has taught us actually is that there are those times when responsible occurs in at least the most essential fields. I mean, the diagnostic chains are pushing for what makes the profit grow, and when it comes to the real clinical testing, which is needed actually to support a decision making, I mean, they then, take it out of the roof. So, and the case in point was about the COVID testing, and we all know the history of it, the way it was misused probably by the diagnostic chains. So that was one point I wanted to make at that point. And yes, in continuation with the Jan Aushadhi, yes, I am a beneficiary of one of the Jan Aushadhi stores in my neighborhood. And Dr. Reddy, I'm using it also. But yes, the availability is a challenge, because I think some of the things, for example, I'm using the Urimax 0.4. The fellow says it is not coming from. So, I mean, likewise, I was just to share that the challenges are, of course, of the availability of some of the most essential medicines which are required, at least for people like us, or there must be other molecules also. So I think the encouraging step taken by the government on Jan Aushadhi is, I think, most welcome. It is reducing the cost impact. Economic cost is coming down, I think, vis-a-vis the availability and other factors. So these were the points I wanted to make.
Just on the diagnostic tests.
Yes, sir.
One of the points that is not frequently discussed is when diagnostic labs offer multiple tests,
Yes,
saying that, okay, we'll give you 15 tests, 20 tests, is that every test has a 5% probability of a false diagnosis.
Absolutely.
And when you do 20 tests, there is statistical probability of at least one test being false positive. That leads to a fresh round of further investigation.
Absolutely.
I think this caution has to be very clearly provided that the more tests you do, particularly unnecessary tests, you are actually leading the patient on a very wrong path.
It's a Pandora box, actually. You are just opening.
Why we put up this panel is that I ordered, as we do everyone's test once a year, my test, and the guy came, and then while you are chatting, this phlebotomist opens up to tell me that, sir, I used to work for this lab earlier, but we used to sell the entire package for 500. But when I sat like this, I would tell, sir, this also you should get it done. It is important for you. By the time I walked away, it was 2,500 for you. But my ad was all tests for 500. So then you understand, when you start talking to those people. One person who came to me, he said, sir, I got fired by a company because I knew my test was expensive. I told them, cancel this order, go to this company, good quality test at 1/3 the price. Obviously, when the test got cancelled, they got a feedback call. They said the person who came, he said, go from this lab to that lab. He said, I lost my job. So for telling the truth, the guy lost his job. But the fact is that the people at the bottom have conscience to tell. He said, I couldn't see a poor lady to pay me so much for a test which I know that company would do a quality test for 1/3 of the price. And that's the reason if every professional followed their instincts and conscience, we probably don't need IPU. But I think otherwise this discourse is very important. We need to bring people to the room and talk and follow up through. I mean, I have friends sitting here, but I have questioned them that how can you advertise, this is not done.
Absolutely.
And I had to finally put on my LinkedIn and then ask the government saying, you will accept this? I'll have to question you then.
Yeah, you.
And at the end of the day, then they has to say, we will not allow this kind of, and they came down heavily. We're going to still follow up. If they still start advertising semaglutide and all, we'll go and file a case. Very clear about that. You cannot make it a business, blatant business where profiteering is done. Profits are not bad. Profiteering is bad. So when you start profiteering at the cost of people, that's dangerous thing to do. We are not going to accept that. I think none of us, me and Srinath didn't partner to start doing, we are not conference people. But I think this is an important discourse for us to have with the right people. And luckily everyone shows up so far. So our goal is, let's get things right. We can't be silent. Most of us are victims because we are not raising our voice. That's the only problem.
I think hats off to you and Dr. Reddy, I must say that. And as I say in my native language, carry on, Jatta. This is the spirit, and you have to take the bull by the horn.
Till someone knocks you down.
No, nothing will. At least life has
Don't
not
worry
knocked
about
me
it.
down, sir. I can only share that. No, life has not knocked me down. I'm still there to fight, and to stand up and.
Any questions?
Thank you, sir. Yes, sir.
Those who have not asked, please.
Yeah. So my name is Dipanshu, and very much a techie or a digital person. I think everybody's talking about AI these days. So sir, my question or my suggestion is very simple. I head the digital and AI for Medanta Group. And I think from an outsider, non-healthcare background, what I see is if you can help us standardize all the investigations, right? Because, and that's a very genuine problem. Like every hospital has their own ways of prescribing medicines, lab investigation, diagnostics, and genuinely, patient health record is not even transferable to any other hospitals because everybody maintains their own standards. So I think though international, we have SNOMED, we have lawing codes and etc. But I think it's very important to have a standard investigations or standardized medication codes, at least from Indian perspective, so that it helps interoperability.
You said you're not from healthcare background, right?
Yes, sir. This is
It
my
appears
first.
so now. Because if you really understood who writes for what and why hospitals or doctors don't want to use digital health because they don't want to be tapped for most of the things. That's the honest thing. But Dr. Reddy, you want to chip in. And then Vindhya.
Basically, I think what you're emphasizing is the need for not only standard treatment guidelines, but also standard diagnostic test usage guidelines. Now, ICMR has started preparing standard treatment guidelines for a number of conditions, and they're already being distributed. Whether they're being utilized or not is a very different issue, but they have that. And we should make them mandatory across all healthcare systems in the country, not only for the government sector, but for the private sector. But standard diagnostic pathway guidelines have not yet been developed. ICMR has a list of diagnostic tests to be utilized at primary, secondary, and tertiary care levels. But which tests to be used when, whether to be used sequentially or simultaneously, all that has not been really set out. I think we need to fill those gaps. I think once we set those guidelines, we can at least try and standardize them over a period of time. Of course, there will always be some exceptions where clinical judgment will have to go beyond the guidelines. But then whenever you go beyond the guidelines, you write a justification, and that justification can be examined. But I think that kind of standardization is important.
Thank you, sir.
So please. Time, right?
Yes, sir.
Oh, thank you.
So since we are running out of time and we just have one short video, it was being specially sent for this open mic session. So I would request the tech team to play that video. It was sent by Mr. Zoali Khan, sir. He'll be joining us for one of the session today evening. Thank you, sir.
मेरे बच्चे का नाम अभिनव है। वो 4.5 साल का है। वो न बैठ पाता है, न बोल पाता है, न चल पाता है, खड़ा भी नहीं हो पाता है। उसको झटके भी आते हैं। खाना भी नहीं ठीक से खा पाता है। बहुत ज़्यादा हाइपर होता है। वो मारता है, नपकता है, दाँत भी काटता है। सब एक हाथ से कुछ पकड़ नहीं पाता है, एक हाथ उसका काम नहीं करता है। वो समझता भी नहीं है। वो वॉशरूम भी नहीं जा पाता है। उसको हम डायपर पहना कर ही रखते हैं, बताता भी नहीं है। टाइम टाइम से वॉशरूम लेकर जाना, उसको खाना खिलाना, कपड़े उसको भूख भी नहीं लगती है, खाना भी नहीं खा पाता, सो भी नहीं पाता है, नींद उसको नहीं आती है पूरी। हम बहुत परेशान हो चुके हैं इसको लेकर। बहुत जगह लेकर गए डॉक्टर के यहाँ लेकर गए, डॉक्टर यहाँ लेकर गए। उन्होंने ये कहा कि ये बच्चा ठीक नहीं हो पाएगा, चल नहीं पाएगा, बैठ नहीं पाएगा, बोल नहीं पाएगा। बहुत जगह जा जाकर थक गए थे, बहुत नाउम्मीद हो गए थे, बहुत परेशान हो गए थे। कोई उम्मीद नहीं थी। फिर हमें पता चला एरा का, पता चला यहाँ ऐसे बच्चों का इलाज होता है।
Abhinav, diagnosed with cerebral palsy, with significant developmental challenges since birth. When he first came under our care, his condition affected both his physical and cognitive abilities. He was also dependent on multiple anti-epileptic medications. He was enrolled in a comprehensive, multidisciplinary care program at ERA's Wellness Word that include medical management, physiotherapy, personalized nutritional support, and continuous caregiver guidance. The goal was not only to manage symptoms, but to improve his overall function and quality of life. Over time, gradual but meaningful changes began to emerge. In the early phase, Abhinav started acknowledge voices and showing of awareness. In the mid-phase, he began responding to verbal cues and following simple commands. His hand function improved significantly, and he started grasping object with better control. From being unable to stand, he progressed to standing with support, and eventually brief period of standing independently. As his condition, let's hear it from his neurologist.
We were able to stop all the antiepileptics one by one. First, the ultrasound was stopped. After that, sodium valproate and in the last, we were able to stop all his antiepileptics and all his fasting medication.
Today, Abhinav demonstrates improved cognitive responsiveness, better hand-eye coordination, and enhanced motor function with early mobility. His journey is a reminder that progress in cerebral palsy is possible. With timely intervention, consistent therapy, and a committed care ecosystem, children can achieve meaningful improvements in function and quality.
पहले खड़े नहीं होते थे, अब तो चल रहे हैं। समझते नहीं थे, समझ भी रहे हैं। आज तो कुछ चीज़ें पहचानने भी लगे हैं, बोलने की कोशिश भी करते हैं। पहले तो कभी जाते थे शादी वादी में तो बहुत रोते थे। ये कहीं भी जाते थे, किसी भी पार्टी में जाते थे रोते थे। अब रोते होते नहीं है। पहले डीजे या भांगड़ा वांगड़ा बजता था तो रोते थे, भागते थे वहां से। अब उसमें कूदने लगते हैं, डांस करने लगते हैं।
What we have heard in the last 30 minutes is more valuable than any policy document. These are the voices that IPUC was built to amplify. We will compile the key insights shared today by panelists and by all of you into an outcomes report that will be formally submitted to the Government of India. Now, moving ahead, a short 15-minute break. Stretch, refresh, and connect. We have a powerful stretch ahead, back at 3:45 p.m. sharp. Do not miss our next two sessions. These are the game changers. Thank you.
लोग हैं, 4 है, 2 चेयर और कर दी बस। आप पीछे कर दो, ठीक है,
ठीक माइक मैडम होगी सिर्फ आपके 4 पे आप भी कितने 4 के लिए टीम दी करवा देंगे कुछ 6 के करवा दो वो ठीक है, हो गए कहते हैं मैडम जी। अगला बजा ये
Thank you, sir.
I request the audience to kindly take your seats as we will be moving into our next session. I request the audience to kindly take their seats as we move into our next session. Before we move into our next session, welcome back firstly. I request the tech team to show us the session video before we dive into the next session. Thank you.
मेरा नाम ममता है। मैं आई थी, मेरे को ना वाइट मनी की प्रॉब्लम होती थी बहुत ज़्यादा। तो मुझे किसी ने बोला था कि सर हॉस्पिटल आपको आना है। यहाँ आई, मैं यहाँ मिली, डॉक्टर से मिली, डॉक्टर ने अच्छे से मेरा इलाज किया, चेकअप हुए मेरे, और आज मेरे पर कोई भी वो नहीं है। मुझे ग्रीन शीट मिल गई, बिल्कुल फिट हो, सब ठीक हो गई यहाँ आके। और डॉक्टर्स भी इतने अच्छे हैं, कोई बदतमीजी नहीं, कुछ नहीं, सब अच्छे से बात करते हैं, अच्छे से समझाते हैं।
Thank you, tech team. A quick question before we start, which we have to reflect and which we have to ask ourselves. When a doctor gives you a diagnosis, how much of what they say do you actually understand? And how much do you remember correctly when you leave? Studies suggest patients retain less than 50% of what their doctor tells them, and that over half is recalled incorrectly. This is not the patient's failure, it is the system's failure. In a world where patients are Googling symptoms, consulting ChatGPT for dosages, and choosing Ayush over allopathy without clinical guidance, patient education is no longer optional. It is absolutely essential. For this important conversation, I would like to invite our esteemed panelists. As I call your name, I request the panelists to kindly come forward and join us onto the dais. Ms. Mavish P. Vaishnav, President, International Patients Union. Dr. Ravinder Singh, Scientist, Deep Non-Communicable Disease, Indian Council of Medical Research. Dr. Abhishek Sen, Co-founder, Butterfly Learnings. Ms. Malti Jaiswal, Founder, Inspiring Seniors Foundation. I request the panelists to join us on the stage, and audience, I know there's less numbers. I request the volunteers to ask the audience who are standing outside to kindly ask them to join us in, and a round of applause to our panelists. This session will be moderated by Ms. Mavish P. Vaishnav. Over to you, Mavish.
Good evening, everyone. We witnessed something very important this morning when Eben asked how many of us have used Google or ChatGPT, and most of the people raised their hands. That one moment actually captured a fundamental shift in healthcare. Patients are no longer passive recipients of care. They are the active participants in this. They actually informed, curious, and increasingly digital. But the concern is access to information is not the same as access to the right information. And information alone does not translate into empowerment. Today's session is about answering one critical question. How do we move from information-rich patients to empowered decision makers? For this, India is at a very unique intersection. We have 800 plus million ABHA IDs. We have telemedicine at scale through eSanjeevani. We have tools like clinical patients where they use ChatGPT. AI models have been part of this, yet awareness gaps remain. Misinformation spread faster than science. Preventive care is still underutilized. I would now like to move to our panelists, Dr. Ravinder Singh, Scientist D at Indian Council of Medical Research. Dr. Singh, drawing from your experience at the Indian Council of Medical Research, Patients today are increasingly navigating both allopathic and Ayush systems of medicine. In your view, how can patients make informed, evidence-based decision on when to rely on each of these systems? And how can the two be effectively integrated to achieve better overall health outcomes?
Thank you, Mavish. You rightly said that now, in the era of AI, the patient is really empowered and lost lot of time. They earlier they used to Google, now they do AI. So after doing that, and then they come to the doctor, and that this is what the AI says. Do you agree? And shall I? I just want you to write this treatment for me. This has, both plus points and negative points, because uh, see, the doctor, with the knowledge of a doctor, and especially in the field of healthcare, nothing is static. It's all very dynamic process, and the decision on the part of doctor is taken on many points. The patient may come informed, but still the decision of a doctor is much more valuable than what AI says. But it's good that they are informed and they get empowered, because an empowered patient will help in more compliances of the treatment written by the doctor. This will also reduce the cost, and that will also improve the outcomes of the health conditions, as well as also if the patients are empowered, we can say that they will fall less sick, because they can do the prevention, they can do the health promotion also.
Thank you so much, sir. That's a very important perspective on navigating multiple systems of care. Building on that, let me bring in Dr. Abhishek Sen, co-founder of Butterfly Learnings. From your experience, Abhishek, what does the typical journey of a family with a neurodivergent child in India look like today? And where does the system fail them in this journey the most? Families often receive multiple, sometimes conflicting opinions from doctors. So, how can parents make informed decisions without getting overwhelmed?
Great. Thank you, Mavish. So I'll speak purely from the perspective of pediatric behavioral health or neurodivergent kids. And I think currently there are multiple gaps in the system. We are almost failing our kids at every single stage that we possibly can, right? Unfortunately. Starting with the age of the first diagnosis, right? Or, 1 in 8 kids in India today is neurodivergent. And if you look at age of when intervention starts, it's typically 4 years of age. Now, for kids, the plasticity of the brain, the neuroplasticity is maximum in the first 3-4 years of life. So we are essentially starting intervention after the plasticity has gone down. So first is the age of first diagnosis, which again can be broken down into two parts. One is better ways to diagnose. We are still using techniques that have largely originated in the West and are not completely, I would say, adaptable to local conditions. We don't have much innovation happening there. We've just started getting newer diagnostic screening technologies and diagnostic technologies which can catch it as early as 12 months of age. So that is important. Second is, even if you do that diagnosis, the parent goes in denial. So there has to be a support system that helps the parent understand that, listen, this is not a life or death affair. But if you act now, the cost and the benefit to the child will be much more than if you start 3 years down the line. So that support system has to be created between 2-3 important stakeholders. One is the parent, one is a pediatrician, one is a school or a preschool, So that these are 3-4 sort of people who are coming together. The good part about our field is that people are very information hungry. So access to information is not a problem. Access to misinformation is also not a problem, but people are generally very willing to help each other. So that's the first place that is going wrong, which is diagnosis and early intervention. After that, as a kid gets some sort of therapy, we don't have enough therapists. So there is a huge amount of capacity building that we have to do in India for at every level, at the therapist level, at the developmental pediatrician level, at pediatric neurologist level. We just don't have enough capacity. So we need to create that. Third is when the kids start going to school. Our schools are not neurodivergent friendly. So, a typical class teacher has a ratio of about, say, 30, 40 to 60 kids in one class, maybe 30 in some schools. But if you have 2 neurodivergent kids in that class, the teacher is completely, doesn't have the skills and doesn't have the time. So how do these 1 in 8 kids cope with our schooling system? So that is something that has to be figured out. Taking it forward, as these kids get older, you have to figure out vocations, you have to figure out companionship, and there are some subset of these kids are really kids with profound disease. So how will they age? Where will they stay? Do we have quality residential facilities? So this entire longitudinal journey, unfortunately, of neurodivergence, everywhere there is a gap.
So Abhishek, you have a platform, the BLS. How do you inform patients or educate patients or the parents of the kids about this journey?
Sure. So, we do webinars, we do social media, we do everything that everybody does. But what I feel is most important is we have round tables of parents. So there are kids who are further in the journey, जो 2-3 साल से treatment ले रहे हैं. There are kids who have just been diagnosed. जिसका बच्चा अभी diagnosed हुआ है, उसके 1000 question है. And they are receiving like 2000 opinions from doctors, relatives, babas, homeopaths, allopaths, everybody under the sun, right? They don't know how to process it. What we have seen is more, the doctor has to say what is evidence based. But beyond that, the empathy really comes in from a peer community, which we are trying to facilitate. So right now, we are probably the largest therapy provider in the country, and hence we also have a parent community that is very engaged and very willing to give. So I think both in pediatric as well as in seniors, I think this peer community is extremely strong, which needs to be leveraged.
So Abhishek, I've visited your clinics and I've seen like you have videos, simulation kind of a thing where you actually teach patients' families how to handle those kids at home.
Absolutely. So we feel, any good therapy center or any good intervention center cannot say that I'm going to intervene for 40 minutes in a day and rest of the 23 hours you figure out what to do. So the family, the kid is there, but along with the kid, the family is also central to what you do. You have to help the child learn skills, but you also have to help the family cope. So we look at the unit as a full family, where the kid is in the center, obviously, but we talk to the parent, we talk to the mother, grandparents, if they are there. We treat them as one unit. Yes.
Moving on to elderly, I would now like to move to Ms. Malti Jaiswal. Ma'am, you work with Inspiring Seniors Foundation, gives you a very unique lens on patient empowerment among the elderly. Despite availability of adult vaccinations, cancer screening programs, preventive health initiatives, uptake remains low. In your view, what more can be done to effectively educate and motivate people to adopt these preventive practices and lead to a better quality of life?
Thank you, Mavish. At Inspiring Seniors Foundation, we work on healthy aging, healthy and active aging. That is the core that we want to work on. And for the seniors to remain productive and purposeful and use their knowledge, skill, etc. The question about the, why don't they access, if they are aware? So from awareness to action to behavior to impact is a long journey. So it's not that I'm aware that this vaccination is good for me and I will straight away go and act upon it, and then have the benefit of that. Uh, Regarding vaccinations, I would say that I was around 6 months back or so, I was chatting with few doctor friends as well as a pharma company, famous pharma company, who are into adult vaccination. So even for adult vaccinations, even the doctors' awareness about recommending it like they used to, they do for the children, is not there as yet. I mean, their own recommendation to the patients is I think slightly low. And the reason for that is that the delivery mechanism of those vaccinations is also not fully in place. I came to know later that you have to have a, like for the children vaccination now, things are delivery, supply, consumption. I mean, everything is very settled. For the adult vaccination, starting from awareness to action by all the stakeholders, not just by the consumer, not just by the public, but by the providers as well, is completely not in place. Why do, I mean, let's look at it from another perspective. Uh, Vaccination is part of prevention, let's say, or early detection or prevention, right? It's a bigger, it fits very in the bigger ecosystem of healthy aging, as I call it. So there is always in the senior citizens, as maybe with the parents of the young children who are detected, there's always a fear psychosis, like क्या होगा ये detection हो गया तो फिर ओहो, I mean they like you bury your head in the sand and then think that danger is not there. It's kind of it's a little bit like that. So the encouragement by the doctors, the encouragement by the family, nudging of behavior change, making vaccination part of your maybe annual birthday cycle, or linking it to some occasions in the family. There are multiple ways about making it more receptive. And I would say that this fear, the fear factor, so if this was presented not like इन्होंने करा और इनका ये हुआ, that a little more fearful, अच्छा इनका detection हो गया, that is how she got detected at the early stage, and so it should be, I think, more positive reinforcement that let's look at this as part of your healthy aging package, just like you're maintaining your diet, your exercise, vaccination, preventive screenings are part of that whole ecosystem, part of that whole message that should be there. This is my personal view, and then speaking to some of the seniors or maybe my own parents earlier. So that's one thing. And then I think one very big issue is about trust. That I think in the social media age, the trust has been the biggest casualty, I would say. It has built so much of misinformation, so much of lack of trust. So whom to trust? When a doctor is saying that this is good for you, is a doctor driven by commercial interest or my interest? So that question is always there. As he said, that people are now coming after done chat GPT and AI. Now chat GPT and AI is also built on foreign models, Western models, right? The data that they would have gone would be the Western, in fact, we had experience in our own family. My son-in-law got detected with a low bone density. You would not believe that the test range was white male. We discovered that where is the range, what. So I'm saying so much of, things need to be in place for the trust to happen. How do you use this? It's not patient awareness. I would call it public awareness. Somebody is not a patient as yet, right? You're trying to educate the public about, about this. So it's public awareness campaign. And in my view, how do you build trust for the public, by bringing key stakeholders together rather than one messaging, pharma company messaging, Ozempic is good, right? I mean, I'm just giving one example, but bringing all stakeholders together and giving one message that your health is our prime concern. My health is my prime concern also, right? When somebody will tell me that this is part of my healthy aging, I would tend to listen to it rather than saying ki, oh, breast cancer itne age group mein itne logo ko hota hai. I think that's a little fear psychosis versus a positive reinforcement that as I want to increase my health span along with my lifespan, this is part of the normal routine that I should be looking at. So this messaging, action, trust, then behavior change linked to, some personal milestones, which are easy to remember, and then, doctor's education, some of these things, come to my mind. That's it.
Thank you, ma'am. I would also like to ask each one of you, like in the field of this technology now, majority of people actually looks after ChatGPT or Google it. They also trust on the videos that we see on Instagram. So how should they be taught or make them understand that it is not the right way to learn from it? So self-medication is something they should not start doing from it. So what should be the message for them that understand the situation, go to a doctor and then take the treatment and not start self-medication?
I think this is a very tough thing, right? I mean, it's like a tool. The ChatGPT, your search engines, all of these are tools, and overdose of even a medicine could be poisonous, right? So I think there's really not much that can be directly done by us other than maybe public health initiatives, uh, which which kind of drive home points like these. So I remember growing up, there was this fantastic Pulse Polio ka campaign by Amitabh Bachchan, right? I still remember it. So I'm sure if such investments are made, uh, the newer generation will be much more circumspect.
He took the example of Amitabh Bachchan. He gives advertisement for shingles vaccination also. But the polio campaign had a bigger impact because it was backed by, government. It was a public campaign. Shingles is, I think, is not that of a public campaign. I think it's a pharma company which is, doing it. So you see the impact difference between a government, when government says, because people's trust and faith in the government campaign would always be higher, because government's due diligence, government's adoption of things would be after scientific rigor, after seeing what is in public health, which majorly impacts, I mean, the public in the positive way. So that's where the same actor campaigning for two different things would have a very two different. Number one. Number two, the public that pulse polio followed by a very rigorous delivery mechanism. It was not just a campaign which happened, but there was a delivery. Having worked with PMJ, delivery mechanisms matter, right? If you have a fantastic campaign but nothing available, accessible and available on ground, it will fall flat. So same about shingles. There is an advertisement, but if I go to a doctor, he doesn't speak about it. He doesn't mention it, that आपने वो लगवाया, क्यों नहीं लगवाया, आप सोच सकते हैं. The problem is also that patients are going with ChatGPT knowledge. On the other hand, doctor has very less time. So वो पेशेंट पहले तो अपना ChatGPT का ज्ञान बताता है और तब तक वो डॉक्टर का टाइम खत्म हो गया होता है. So I mean, so I'm saying the doctors, attention span, doctors are receiving calls as you sit with them, right? Their attention span is equally at a loss. So they are hardly spending 10 minutes, out of which, बीच में एक दो कॉल भी आ गया, बीच में मैंने ChatGPT में 5 minutes waste कर दिया. So I'm saying the campaign plus delivery and the trusted, trust factor is very, very important. Yeah.
Yeah. So, see, the knowledge is in the hand of the people. It's a whole world. This mobile phone with internet facility is much more powerful than what I can say or tell my patients or the people at large. But the thing is, still we have the opportunity when they reach a health facility. So then you can, teach them. We have behavioral change communication. There are various other method of communication which I used to teach. I'll give you one small example which I keep on quoting again and again, how you change the behavior. I was teaching a MPH class in Chennai, and then suddenly I asked them to go out and take a break for 5 minutes. They, after 5 minutes, they came. I asked, "Did you see any unusual outside?" They were blank. I said, "Again, you go and then come back." No, because they knew that I am going to ask the question that whether you have seen something unusual. They kept on observing, and then once they came back, their behavior was different than previous one. This is simple, and now uh, from the childhood itself, we know that time we used to say, रथ का घी लेके आना है, ठीक है, या डालडा लेके आना है, या कॉलगेट लेनी है. You are not talking about the content, you are talking about the name of the product. That was how much influence is on your mind, the campaigns do. So similarly, the campaign for the positive things also has to be the same impact which we want. So we have to start that, and there was a beautiful policy by government of Gujarat on mental health mission long back that depicted the beautiful roadmap how to change the behavior of the people. We can do that, but the will has to be from all of us.
Very rightly said, sir. Yes, the trust is very important that everyone has to have in the system, as well as the understanding of the things that's happening. Access at scale is actually meaningless if it is without the awareness at scale. We would now like to open it for the question and answer from the audience.
So if you have any questions, please raise your hands and our volunteers will bring mic to you. Do we have any questions for our esteemed panelists? Yes, ma'am. So.
Hello, doctors. I'm here as a dejected patient. I have been to multiple therapists. I was suicidal and I never found help. So when we talk about impact on a larger scale, I think so much of it is riding on a lack of medical arrogance, which I've seen from a lot of doctors. And I know I'm going to be offending a lot of people here when I say this, but I've looked it in the eye, the medical arrogance. The doctors are refusing to hear what we have to say, and that is why the patients are, looking on the internet, because they don't want to be point blank when they're talking to a doctor who's anyways not going to give them the time of their day. So I don't think it's as much a question, but I'm someone who's working on a suicide prevention helpline, and I would really, really like to know what is it that I as a person can do to avoid said medical arrogance when I further reach doctors, to just get with the program or just become a part of my program. So what can I say to them that will make them a little nicer is the question, I guess.
Yeah, you have raised a very important question. I tell you, because of assaults on the doctors, lot of people talked about bringing in the legal provisions or some law. But I was against always that. It's not required at all. What is required is the behavior of doctors and the communication skills. If a communication skill with doctor breaks anywhere, it is going to create chaos. It's very, very important. I always say in the communication classes that write what you say what you write. Explain. That means you explain in detail what you have written. Like Dr. Srinath Reddy said before, that the legible or the written prescription of a doctor, handwriting, has to be very clear. Even Supreme Court has said that they should even type it rather than so it's or in capital in a clear manner. So those things are very small things but very important. So that will instill, lot of confidence in the patients. And active listening is also very important. I'll give you the example of one of the ENT surgeons. Because in the private they get a lot of paid by payment for just listening also. So she says that I get money just to listen to the patient. After they stop, or if they don't stop after half an hour, then I say, no, you listen to me. I will listen to you, now you listen to me. And for that they pay me. I can even scold them, but they will happily accept it, because first you have already let them vent out their whatever they want to say. And most of the older person, they just come to just talk. Yes. They don't have nobody at home. So yes, they find that doctors are the best one to go and do whatever they want to say.
I'll actually add from a mental health perspective. So if you look at where we are as a country, our infectious diseases is going down, our non-communicable diseases is going up, and our mental health issues are going up, right? And that's typically what you would see in almost every economy or society that develops, so to speak, over a period of time. Now, while this is happening, we have an acute shortage of psychiatrists. So if I don't have the exact numbers off the top of my head, but it's absolutely dismal. So when you have so few psychiatrists, what the psychiatrist has in his head is, I have to, one, do a diagnosis, B, do a medication. That's it. That's my role. So my question is largely, you cannot change the number of psychiatrists overnight. But what we can do is create multiple paramedical cadres that are trained and skilled, not in prescription writing, but in, say, different forms of therapy. It could be CBT, it could be something else. And then, verticals which are like suicide prevention. This is a national infrastructure that has to be built, honestly. So creating, for a lack of another word, barefoot doctors, where you're kind of saying that these skills, you don't need a specialist to deliver these skills. And can we create an entire cadre of people who are giving these skills? In this case, it would be therapists who are trained in techniques of active listening, CBT, that they can help counsel a patient. Can we do that at scale? Currently, if you look at it, the number of clinical psychologists are also dismal. So creating that paramedical layer is extremely important, because you can't create psychiatrists overnight. Third is just specific tech-enabled verticals like suicide prevention, etc. Creating these sort of wedges wherever things are broken. That is all that we can really do. And of course, hope that doctors are nicer. But beyond that, of course, sorry.
So to this question of how do we enforce a behavior of a doctor, right? That was a key question. How do you enforce behavior in anyone? So it could be the goodness in the person, or the system is such which ensures the behavior is good, right? How do we ensure in children? How do we ensure in any institution? So we do not have, dashboards, patient voice kind of dashboards, like where we vote by our voice. So, I mean, it need not be an emotional outburst, but it could be on a very specific parameters. Did the doctor hear me patiently? Was the doctor, communicative, was attentive or polite? I mean, there could be various ways. I think I just have an example, like in PMJ, they tried to do it in patient experience study in Tamil Nadu. And there were criteria, even a curtain in a public, space made the patient feel better, right? The patient experience was better. So I'm saying, how do you enforce behavior? There can be ways and mechanisms for it. And and sitting here in this forum of, International Patient, Union, I would suggest let's create those dashboards where we have outcomes, where we have experience, where we have behavior, so that it's a non-partial kind of a platform where people can rate the doctor. Right now, the same doctor, people keep on going because nobody knows what was the experience of the previous patient, right? So I think that would be one way of ensuring behavior prompt attention or whatever we are seeking as a patient from the doctor's end. Yeah, that would be my, suggestion on that. Yeah.
Thank you so much, ma'am. And thank you to all the panelists. Do we have any other questions? Yes, ma'am. Can we pass the mic to her?
Hi, my name is Dr. Shalyanan, and I'm standing for everyone now. I run a foundation known as Mileage Initiative Trust. Being a dentist for the last 30 years, and now a health economist and a healthy aging expert, I promote healthy aging through health literacy. I know Malti ma'am, I've spoken to her. First of all, I must say it was very commendable, your question. There is a lacuna out there, but I am also a health professional. I'm a doctor, as well as I'm also a patient advocate. So health literacy is the ability to ask information, find information, assess. And then I feel ChatGPT, Google, because I've been asked questions like that too. They're very important because when a patient gets just 5 minutes with the doctor, they should be aware of what they want to ask. I always tell my patients, make a list of questions so that you utilize that time really, really well. But trusting that information completely from ChatGPT would be wrong. So having a respect for the doctor profession and shared decision making through doctors to the patient is, I think, very critical. And health literacy is the way to go. So thank you for creating this session. Empowerment is through education, and this is commendable. Thank you.
Thank you so much, ma'am, for your inputs. So,
good evening, everyone here. My doubt was similar to what ma'am actually addressed. Dr. Abhishek said, AI is just a tool, right? Everybody searches through it, everybody searches the symptoms. But AI is not always accurate, and not everyone can afford the pro models, right? They are searching through the free models, and they are actually trusting it. Many are just curious. I guess that's a major concern because AI models will hallucinate details. And there is another side to the coin, I guess, where AI will be incorporated into our medical systems, like China is already doing it. So what I really want to ask is, do we have any regulations for that? Are there any policies or are there any regulations for AI or any interventions that we would like to introduce in public system or education system that makes public aware of how to use AI and how much trust doctors? And in future, if AI is incorporated into the medical system, do we have any way to regulate it? Because AIs are known to go rogue. We have cases of that. So that's just my question. Thank you.
So anyone in the panelist?
Qualified to answer it. I'm aware of ISO 27001, HIPAA standards, GDPR, and the National E-Health Authority. I don't think, apart from passing mention, there is any deep dive on AI that is there. Also, I think this is much needed. So this will come in the foreseeable future. But if you look at it, this entire AI wave is not more than a year and a half old. So regulation in healthcare always lacks innovation, always lacks. So, and especially when models are improving by the month. So if you look at it, if you use ChatGPT, hallucinations have gone down. A lot of models are really, getting better by the day, by the minute, by the month, right? So I am not aware of any regulation as of now, but just from first principles, it's not too far away. It has to come in. But in India, I think before we talk about AI, our fundamental issue is actually interoperability. If we talk about healthcare, data is still in silos. Your AI system will only be as good in personalized medicine if it has access to your data. So I think while we talk about AI and how we safeguard it, our data channels, our plumbing is still being installed in a way. And the Abha ID is for example a great initiative, but there is still some time for it to really translate into outcomes. That's my perspective.
So I think somebody spoke about interoperable in the previous session also. So I think just like ABHA ID, that Ayushman Digital Bharat Mission, ABDM, also has set interoperable standards. The only problem is that the adoption by the healthcare professionals and providers is not there for various reasons. I mean, there's always an inertia to change, and there is always a whether incentive or disincentive to make that change. But those interoperable standards very much exist now in India. AI regulation, I think it's still being debated in Europe and USA. I'm sure we will take some time, but then what government has already done is the data protection. So AI builds on data because it needs data, it feeds on data. So if your data is protected, that way there is some little bit of safeguard there. But I'm sure in very near future, human intelligence will be back in business compared to artificial intelligence. I'm 100% sure of that. People would want to read something written by a human than by a machine very soon.
Thank you so much, ma'am. I mean, that is something which we should strive for, that human intelligence should be of similar value as the artificial intelligence. Do we have any other question, or else I'll...
Am I allowed to ask for a follow-up, please?
Sure.
Ma'am, as you said that AI, sir said AI will be incorporated, the pipelines are being laid, and you said humans will start coexisting with AI. But my question is, as we are UGs, we are still in our medical schools, first year and third year. What should we be prepared for? What do you think we should be looking forward to, or what should actually be studied so that we can be ready for what's coming?
No clue, honestly, because I speak to my radiology friends, and the way AI models are getting better, chest X-ray is almost there, right? To average radiologist, maybe not to a very good radiologist. So I think if you want to get into practice, is that your question?
Sir, my question is that soon AI will be incorporated. Like very recently, Gemini was, showcased that it is reading
Yeah.
MRIs now.
I would just say keep your fundamentals solid. If you're in your first year and third year, just keep your fundamentals solid. Things will change every 2 years. If your fundamentals are solid and if you are open to learning, you will figure it out. But your fundamentals of anatomy, pharmacology, biochemistry, physiology, those are important. I think just focus on that. Don't worry too much about AI. Time hai aapko.
Yeah, I agree, because in our medical college we used to say फंडे clear करो, बाकी सब हो जाएगा. So if your fundas are clear, and I'll tell you one more thing. See, you have to learn AI, just not to just for use it, but to understand what does it have in future. Another thing is that we were also debating on the what a kind of specialty will be replaced by AI. That will be level 1, level 2, level 3. Okay, so level 1 will be obsolete, of course, no doubt about it. AI is going to replace all of them. Like in the computer age, I can tell you in 80s or 90s, there were a lot of apprehension that computer will change, whole of the scenario, people will be out of their jobs and all that kind of things, but nothing happened. Similarly, we have seen historically also when the sewing machine came, when the locomotive also came. So in Punjab, people used to say this will kill the cows and buffaloes and all those kind of things. And even in Bhakhara Dam, the people used to say they will suck out the electricity from this water and there will be nothing in the water. So similarly, those kind of things happen with any change, and AI is also the same one. But as a doctor, as a medical professional, one has to keep their knowledge up to date, because the basics would be same, and over that you can add on to whatever you want to add. And the skills or surgeon's skills, they will never be replaced. Okay, so some of the repeated, like pathologist and microscope taking picture and doing diagnosis, that can be done by the AI or by the softwares. but certain things will not be replaceable. Definitely.
Thank you, sir.
Thank you, sir.
Can I say just a short comment? I think no doubt AI is going to be very complementary, but we as medical student must remember medicine is a science, but the practice is an art, and no AI can do an art. Art is always with the going to human being.
We have another question from ma'am. Can you please bring a mic to ma'am?
Observation and sharing in response to changing the attitudes of doctors. This is somewhat in defense of doctors also. While I'm today working in the community, I wear the hat of a doctor. I think one of the things lacking in our medical education is exposure to all these, and doctors are so busy learning all the time what they should be doing with patients that those experiences are lacking. And I would say 2-3 things can be done. All doctors can have an internship as a part of there with different organizations dealing with population groups, including mental health organizations, and that's when they get exposed to. And to share a personal experience, because when I started out, I wasn't really thinking of children with disabilities as much as from a pediatric neurology background. And when you're in a busy clinic, you can't really talk to patients for long. And I would say refer to so-and-so place or so-and-so organization. But when I went into solo practice, it so happened that I was working with NGOs, and there I had a lot of learning and unlearning to do. And in fact, the first thing I learned was when I said, where is the next patient? They gently nudged me into saying, where is the next child? So I think this empathy and attitude, it develops on learning from others. The experiential learning is as important as education, but as a part of our curriculum, maybe medical students should do these internships where they can learn from these groups. Thank you.
Thank you so much, ma'am. Yes, sir. Can you please have the mic?
Just to get back to the question from the medical students as what they should be doing in the age of AI, you must remember that context matters a lot in medicine, in diagnosis as well as treatment. The algorithms that have been developed, as has been well said, in Western populations do not automatically transfer to Indian population. Even within the Indian population also, there will be considerable variation. So when you're interpreting a chest X-ray, are you interpreting based on a Western population-based algorithm where they have not seen much of tuberculosis, they have not seen silicosis, they have seen not seen many other conditions. So your differential diagnosis is extremely narrow over there. So what you need to do is to pick up the clinical skills through observation in your clinical teaching from people who are definitely experienced among your teachers, but your own practical observational skills. And then also focus on research to try and develop large enough and diverse enough databases in Indian populations so that you can develop your own algorithms which are much more relevant for the country. So not automatically absorbing whatever is coming from the West. So that critical thinking is what you must develop as medical students.
Thank you so much, sir. And thank you to our panelists, as well as the audience members, for a richly layered conversation. Patient education is the vaccine against misinformation, and today we have begun administering it. I request all the panelists to gather up in the front of the stage for a quick group photograph. Meanwhile, I request all the audience members to scan the QR code for the Mentimeter questions. The QR codes are being placed on your lanyards as well as in front of your desks. Please feel free to answer the questions. Can we have a quick round of applause for our distinguished panelists? Thank you, everyone. May I request Ms. Mevish P. Vaishnav to kindly remain on the dais as we now move into another special segment of our program, To welcome our esteemed guest of honor and share a brief introduction, I now hand over the mic to Ms. Mevish P. Vaishnav. Over to you, ma'am.
Thank you so much, Dr. Harsh. It is my privilege to introduce our guest of honor, Ms. Manmeet Nanda, a distinguished officer of the Indian Administrative Services and currently serving as Additional Secretary in the Department of Empowerment of Persons with Disabilities, Government of India. With over 2 decades of exemplary public service, Ms. Nanda has consistently driven transformative initiatives across governance, industry, and social development. From her leadership roles in the government of West Bengal to key positions in the government of India, including the Cabinet Secretariat and DPIIT, she has demonstrated a rare ability to translate policy into impact action. Today, she is at the forefront of advancing inclusion through flagship initiatives such as the Accessible India campaign and the implementation of the Rights of Persons with Disabilities Act, shaping a more equitable and accessible healthcare and social ecosystem. A recipient of the Prime Minister's Award for Excellence in Public Administration and multiple Best Electoral Practices Awards, Ms. Nanda embodies integrity, innovation, and purpose-driven leadership. Her work continues to empower millions, ensuring that dignity, access, and opportunity are not privileges but rights. We welcome you, ma'am.
So very good evening. I believe you've had a very long, extensive, full of deliberation day, and I'm sure you don't want to listen to what I have to say, and I'm sure I'm the least experienced, not as educated as many of you here in this room, and I definitely have not got that vaccine that the gentleman earlier was talking about, patient education. So I missed something in that, and please ignore if I have said something or I will share something that is repetitive to what you all have read or heard during the day. Firstly, let me begin by thanking Dr. Gupta for inviting me here and Ms. Mevish for that elaborate introduction. Indeed, very, very elaborate enough. It took me back to many years where I started my career as a bureaucrat down at the Mufassal towns of West Bengal, and many subdivisions and places which I can't imagine many of us in this room would have ever visited. And that brings me to a very important point and juncture that I am in complete gratitude to be able to be addressing an audience like yours, and to the IPU for building such a strong platform that dares to do what most systems often cannot. That is to bring the patient's voice into the same room as the policymakers' ears. And I believe that the World Health Organization's Director General, Dr. Tedros, had personally endorsed this organization, and he was signaling something very important to the world by placing patients at the center of health governance, and not an option that we all can ignore anymore. The department that I represent today, the Department of Empowerment of Persons with Disabilities, is the custodian of the rights and opportunities for some of India's most ignored population, I must say, persons with disabilities, including persons with intellectual and neurodevelopmental conditions. Even our own ministry also is responsible for the senior citizens and the older generation people, and those navigating substance abuse. That all comes under the Ministry of Social Justice that we are a part of. And so in today's discussion that you may have had here about patient-driven healthcare, we must have also spoken about the cost of care and the need for educating and empowering patients themselves. It is very important that we have realized that patients are not the peripherals to any of this conversation anymore, and they are at the center of it. the gap between policy intent and policy outcome or health outcome for persons with disabilities is probably one of the most consequential silences in the Indian public policy today, something that I upfront agree to accept. Because it's important that we realized that there is a large population that is still not a part of the more active population that gives back to the GDP of the economy. And that's primarily because we need to work a lot on their early identification, on providing them relevant therapies, or providing their support systems and their families the correct care, comfort, and timely intervention, so that they also get empowered and become active members participating in the country's economic growth. The national study on neurodiversity that is titled as Unseen Millions. I was going through the report. It was shared by me, by the organizers. I have read that report, and what struck me most was, not as a bureaucrat, but someone who believes that data, when it is honest, has the power to change the world, make us uncomfortable, make many of us in this room uncomfortable, but confront us, and that's important, I think. We all are aware, I think it brought out the numbers very strongly, about the number of children and people and adults who have lived through a life of autism spectrum disorder and ADHD. It is about how we would have reacted to such individuals and how they, with their daily struggles of learning, communicating, working, and participating in this society. And yet, despite their lifelong impact, ASD and ADHD remain persistently understood, under prioritized probably, and inadequately addressed in our entire health, education, and social welfare systems. And I think it very plainly and starkly reports to us that we need to look at neurodiversity in a very, very strong manner, positively, almost defensively, and address it with actually complete convergence at the ground level. Convergence of ministries, departments, not just in the government of India here, but right down at the district level. At the district magistrate, I am head of many committees where the CMOH plays an important role. I am also the responsible for the social welfare department and the work that happens there. And I think the entire culmination of convergence that should be shot off from here finally goes down to that district as a nutshell. And I think it's very important that if the district magistrate of today understands how important that convergence activity it is, it will help journeys of many families slightly less difficult, as has been for many that have been a part of that survey that the report was made up of. That study has often told us that about 56-57% of caregivers, the first to identify that their child has developmental differences, has not been a doctor, neither has been a teacher, sadly, not a health worker, not a frontline worker, not an Anganwadi Didi, but it's actually been a mom, a grandmother. More importantly, it's been the female member of the family more than the male member of the family. And in most cases, they have always reassured the mother, saying, "ठीक हो जाएगा." कुछ देर के बाद बोलते हैं बच्चे. I remember my mother also telling something like this, similar to a story that's pretty close to what we have discussed like this. And then when we visit a general physician and go on to meet pediatrists, etc., we rarely receive clear signals of what has gone wrong. So we are also aware, and the report has also brought about very strongly about how the report, though I have seen that the study primarily is more urban centric, but I think what has really brought out that aspect also is that the low-income families in the rural areas, in the remote areas, the missing middle families, that is the families who are probably do not fit into government schemes, but they are not earning enough to qualify to be able to sustain private therapies and their cost. Especially the girl child, she remains or is brought to assessment far later than a boy child. And even adults, they've been, if they have moved from different school years or have been regarded as stupid or bevkoof, they've never ended up getting the correct intervention to help them progress and help them become an empowered member of the society. And I'm aware that ADHD has not been explicitly included in the RPWD Act. And there is a very scattered and inconsistent recognition, fragmented across how ASD and ADHD are defined in our Ministry of Health and Family Welfare, in the policies of Social Justice Ministry, even in the policy with special education or the Ministry of Education. And that all leads to further confusion, further duplication, further gaps, and everybody not treating this as not their ecosystem to address to. And India definitely faces this profound shortage of trained professionals. We see that considering the fact that I think there are only about 5,000 plus clinical psychologists in the country that get passed out every year. And they also, because of the education institutions offering not very relevant programs in terms of occupational therapy, speech therapy, these are also very few and unevenly distributed. Annual output of these trained professionals run low. The good ones move out of the country. They are always urban-centric. We have very few of them located or providing services to the really marginalized and the tier 2, tier 3 areas. And there is a need for the Rehabilitation Council of India to extensively understand how we need to scale up this profession immediately, and also ensure that we adopt global best practices as to ensure how we can have more of these professionals. And also the special educators in the education department, the mainstream schools, how it's mandatory to equip them also, train them specifically of how to deal with neurodivergent learners meaningfully in the correct way. I think those are very important aspects that are required. I also have read in your study about what happens, how the family members react to most of these. And I think that also brings about a greater requirement for awareness generation and advocacy. I think that's an important aspect that we should address. And I think at our department level, we will like to take that up very, very strongly. On the infrastructure bit, we know that we have some of the best institutions like AIIMS, IBHAS, and NIMHANS there, but we need to stretch that fold larger. We also have our national institutes, some of them that have been working on this, and I think we need to make their work amplify largely. We need to ensure that national institutes collaborate with state governments to help and train the frontline health workers. We also need to find out 6-month or 1-year short-term courses where that we can take up with the special educators to ensure that they are also are able to deal with special learners in a big way till the time this deficiency of professionals gets filled up. I think that's an important aspect that needs to be looked into. I think what you have addressed through your study in a big way, and what you have probably discussed in the conference today, it brings out very strongly that DPWD, along with Ministry of Health, the ICMR, needs to now increase the cross-ministerial coordination strongly. And we do not need to just maintain our ministerial boundaries. We need to really strengthen our conversations, our communications on this, include family members who have experience this all their lives, understand what they can do about it. And of course, we can't afford to waste any more time in that. What I say today is not ceremonial. It's just something that I feel very strongly about, and I speak directly from my heart wherever I do intend to speak. And I think it's important that we all come together and actually be the voice that brings about action, and an action that can lead to some kind of impact here. I would, through this medium, also would like to directly speak to every parent and every caregiver and every neurodivergent individual, wherever this voice can reach up to, that your fight is not your personal failing. It has been the systematic failure, and we as a government have to take the responsibility to it. And I believe that we as government will make sure that we move ahead on this constructively and more positively and directly. And that we hope that the future of this country is not where you have to navigate a broken system alone. That is what we owe to you as a policymaker. And I think that the Ministry of Social Justice, and more importantly DPWD, intends to work towards this with complete urgency and accountability. And we hope that your voices will always be there to guide us. Thank you for so patiently listening to me. I hope I've not gone beyond what a bureaucrat was expected to speak, but this is something I truly believe, and I hope that we can together make an impact that is required, and something that was to be done many, many years ago. Thank you.
Thank you, ma'am, for those profound and inspiring words. Your presence here today is in itself a powerful message that the highest levels of the leadership are listening to patients and prioritizing their voices. What ma'am has mentioned about a report of the neurodiverse children we are going to launch in the next step. Today, the International Patients Union proudly launches the report Unseen Millions, a national multi-stakeholder study on autism and ADHD, a groundbreaking document that maps the healthcare gaps, communication barriers, and systemic exclusions faced by neurodiverse patients and their families in India. This report is a call for healthcare systems, educational institutions, employers, and policymakers to build environments where every mind is accommodated. For the official launch, I would now like to invite Ms. Manmeet Kaur Nanda ma'am over the dais, as well as Dr. Rajendra Pratap Gupta sir, founder International Patients Union, Dr. Abhishek Sen, co-founder Butterfly Learnings, Dr. Sabya Kulshrestha, project associate International Patients Union, Ms. Mevish P. Vaishnav, president International Patients Union. A huge round of applause. With this report, we are not just naming a problem, we are charting a path forward, because neurodiversity is not a disorder. It is a different, beautiful, and equally valid way of experiencing the world, and our systems must adapt. I request Dr. Rajendra Pratap Gupta sir and Manmeet ma'am to stay on remain on the dais. I now request Dr. Rajendra Pratap Gupta to kindly present a memento to our esteemed guest of honor as a token of our gratitude. Thank you, ma'am. It was a pleasure. For our next session, the next session is perhaps the most urgent conversation we will have today. Before launching the next session, I would request the tech team to play the video.
क्या वीआईपी मूवमेंट के लिए एम्बुलेंस को रोकना जायज है? क्या किसी की जान से खिलवाड़?
ये आपने ट्रैफिक किसके लिए रोका है? कौन सा वीआईपी मूवमेंट है? किसका है? चीफ मिनिस्टर का है? गवर्नर मैडम का है? तो ठीक है, ट्विटर पे डालते कि आप एक एम्बुलेंस को रोक रहे हैं गवर्नर के लिए। पेशेंट है वो नहीं, आप पक्का ये वीआईपी मूवमेंट गवर्नर के लिए है कि नहीं? एम्बुलेंस चला हुआ है, ये मूवमेंट बताइए। आपने बोला ये गवर्नर का मूवमेंट है, ये बोल रहे गवर्नर का मूवमेंट है। किसका मूवमेंट है पहले ये बताइए। आप सिर्फ एम्बुलेंस को रोक जाने दीजिए। कोई भी वीआईपी मूवमेंट एम्बुलेंस के आगे नहीं हो सकता।
So this video has demonstrated something which is urgent, which requires immediate attention. When a patient dies because an ambulance didn't come in time, when a woman delivers her baby on a hospital corridor floor, when a golden hour of emergency is lost because no one knew which facility to go to, who is ultimately responsible, who is said to be accountable. This session asks who really guarantees care when the healthcare system fails, not to assign blame, but to build a better, honest answer. Our discussion will span rural accessibility, medical education quality, emergency response infrastructure, NABH effectiveness, and the promise versus the reality of Ayushman Bharat. Our panel together brings voices from medicine, medical education, nursing, and nursing. I request that the panelists to come on the stage. This session is chaired by Dr. K.K. Talwar, sir. Our panelists are Dr. K.K. Talwar, Padma Bhushan awardee, former chairman, Medical Council of India, former head, Cardiology, AIIMS, New Delhi, former director, PGIMER, Chandigarh. Dr. T. Dilip Kumar, President, Indian Nursing Council, Board Member, International Council of Nurses, former Nursing Advisor, Government of India, Dr. Prem Agarwal, Founder, Medical Director, and Consultant Cardiologist, Sanjeevan Hospital, Chairman, Medical Dialogues, Mr. Zoali Khan, Founder and CEO, Criterion Tech Private Limited, Dr. Dipit Divyanshu, President, Medical Students Association of India. Please join me in warmly welcoming our panelists. Can we have a quick round of applause? Now I request Dr. K.K. Talwar, sir, as a session chair to lead the session. Over to you, sir.
Good evening, everyone. I think first I must express my gratitude to Mr. Gupta ji for this opportunity. And I think particularly seeing the International Patients Union, I think so patient-centric. We are mostly professional-centric, but I think that's important to see how, I mean, ensuring that the patient's importance and what are his needs, what are his requirements. I like as a professional, I mentioned to you one thing that we often, as a medical practitioner, the patients are so loyal to you. I mean, they will say you ask for a consent that you want this procedure to be done. And this was like a blind trust. Doctor साहब जो आपके लिए जो आप अच्छा समझते हो वो करिए. But there's such a blind trust in this profession. But unfortunately, something which are happening around, this blind trust has now become like a somewhat mistrust. And I think for that probably we have to relook at professionals, what has happened, how we have to gain the confidence of the patients. But now I think coming on to I was asked also to comment upon that recent that the NEET examination that we have for the medical college for PG examinations. And I think recently you must have come across that the cutoff, there is always a cutoff for any kind of interest as and how this cutoff can have to go to 0. So question is whether how kind of professional doctors we are going to have it. I like to mention to you that if you look at the NEET examination, NEET came because that time I was in the medical council. I'm sure most of you are aware of that what was happening in the private medical colleges. If you actually look at at the time when I the decline in medical education or standard became around 94, 95, when the private medical colleges flourished. Before that, it was not so. So the NEET examination became a necessity because of the capitation fee issue, which I'm sure you must all be aware of it, that private colleges, they have their own control on entrance, admissions, and you could get the seat by paying a huge amount of money. And that was the reason to create some kind of a entrance test which will be merit based. The student should get, the meritorious student should get into the a system by sheer of their merit, not by because of any other reasons. The recent happening that I think in PG entrance tests, the cutoff kept a cutoff around 40 percentile. It was also mentioned that you can reduce it to another 5% if there is a vacant seat, discussion within medical council as well as discussion with the government. Why it has happened that you find they're not, they're going so low? There used to be earlier a fees control committee in every state. The Supreme Court has given a direction. It was not a order, I'm told. It was more of a recommendation that each state must have a fee structure committee which will fix the fee of private medical colleges. So what happened after this, I think it was only a recommendation. None of the state now has this fee structure committee. The private colleges now have hiked their fee to the extent that many meritorious students who cannot afford it don't join there. This, I think, is the biggest reason why we are going to go down, because students who have a merit but they don't belong to the family that they can pay so much fees, they don't join. And then I think same thing when I was when the NEET was being considered and we were trying to implement it. I used to say that what is we talk about reservation. We say the reservation it became a reservation for the riches, and now again with this kind of fee issues, it is becoming a reservation for the riches. So I think this is one issue in medical education. We need to look at it. I think the fee structure committee should come back. There should be some kind of direction, number one. Number two, I think it's important that those students who are meritorious but cannot pay fees, whatever may be the amount which are fixed, there should be a possibility of some kind of a help to the students, like interest-free loans, which are happening in some of the Western countries. I think there should be some, so no meritorious students, because he cannot pay, should be deprived of this, and that's one way we can maintain our standards. Of course, no doubt, the medicine is not now an attractive profession among the bright students. Students are moving to other professions for various reasons. The remuneration. They're so, I can share with you, I had a colleague who did his MD, DM in cardiology in AIMS, and after that, he was working as ad hoc in one of the major institutions in the Delhi, and was hardly getting 85,000, 95,000 rupees. So you can imagine. So these are some of the things that I think we need to look into. If we have to revive this, the attract bright youngster, and I think in this profession, there is no choice. You need good doctors. And there is a kind of a saying, it's better not to have a doctor than a bad doctor. So I think with these views, I'd like to now start with my panelists. I know Dr. Dilip has been, I have been associated with him when I was in the medical council. He was the president of the nursing council. I think probably who has been for a number of years, you have tried to sort of look after this particular paramedical institution. I like to ask you, Dr. Deepak, Dilip, what is your concrete recommendation to help nurses reclaim their rightful place or trusted, empowered, and respective? There has been some, apart from the many of the nursing, what I see in most of the hospital, they try to now go abroad because they have a professional strength. But for some reason, they are more attracted to go out rather than staying here. So will you like to share your thoughts and what should be done? Because this is a very important part, professional part in giving care to the patients. Over to you, Dilip.
First of all, greetings from the Indian Nursing Council to all of you. I think this is one conference which motivated me when they first attended the inaugural ceremony of the Patients Union. And also, I think Guptaji's best way of inaugurating any global conference, not having any VIP on the inauguration, having only the patients in the inaugural session. That is one of the things which being a nurse, which has a lot of because we are the patient advocates. Nurses are the patients advocates. We spend a lot of time with the patients. We take care of the patient needs. So always in any functions, we have VIPs to inaugurate whereas in these patients, all the ex-patients were telling the story. The whole conference starts from there. I think that is the extraordinary. Even when I sent the draft committee for the National Nursing and Midwifery Commission, which one of the recommendations was sent by us to have one member in the National Nursing and Midwifery Commission, patient advocate, and the patient's representative should be one of the members should be there in the regulation. I think they should, not only with the nursing council, in all the health regulatory councils, because ultimately they are the people who are receiving the services from the different professionals, and they should have a voice while making the regulations in the councils. So in that perspective, I was very it touched my heart how important this conference is giving to the prior to the patients. Coming to the issue which you asked the question, why the nurses are going abroad, why this profession? I think the health system, we are the major large human, about 55% of the human resource happens to be the nursing professional in the healthcare delivery system. So when such a large system which is there in the health workforce, the why they are going abroad? See, they are I think you all know that about 30% of the healthcare sector, which is in the government sector, and about 70% is in the private sector. So I think when the pay commission was there, I happened to work very closely with the WHO in Geneva. One of the principles they told us that how to attract for nursing, how to retain for nursing. So these are the two principles which were told by the WHO. When we went to the pay commissions, I think I happened to be there at that time as a nursing advisor to Government of India. So these two principles were argued and made this. Now the government nurse, when she get a job in any central government institutions in India, the first month's salary itself is about 1 lakh. So that is the level of the government has recognized the services of the nurses in the government sector. Whereas in the private sector, the highest well-recognized corporate sector, I am using the very cautiously, the very recognized, renowned corporate sector is not paying more than 25,000. So therefore, definitely, so much time they are spending, the hard work they are putting, they are not being properly commensurated. So therefore, they have to go for the greener pasture.
Dr. Dilip, you are very right. I think you have to look at the remuneration. I now there's one more focus question which I think that is, I think, what has contributed to the trust deficit between patient and the nursing community? Is there any something?
See, this is again the patient trust. If you get into any district hospital in a night, near a 200 bedded hospital, how many nurses are there? 3 or 4. The nurse patient ratio, which is approved by the government of India under the Ministry of Finance, we got it approved. No state government is following the nurse patient ratio. One nurse has to take care to 20 to 30 patients. Different unit doctors, consultants will come, take your rounds, get the indent, and give the injections, and so much.
Then you think
therefore, but at the same time, our own nurses trained from India, they are best sort in the world. Best sort in the world, because there they have to take care of one patient, only 3 patients, with the same working conditions.
So I
She
think
is doing extraordinary.
what is the, I mean, because if the government has already laid down the rules, this should be the ratio. Finance, you also said that it has been sort of approved. So why then it is the state governments are not trying to?
Sir, when we see, you can imagine in the government of India, we took this resolution to the Central Council of Health. Highest policy making body of the Ministry of Health is the CCH, and which is headed by the Union Health Minister and the state health ministers. They are all signatory to the resolution. When it is sent to the state government, due to financial constraint, you can't implement.
So I think
therefore, there are so many issues, but at the same time, with all the issues and the challenges which the nursing sector facing, the level of the appreciation in the developed countries, for example, the developed country like Canada is coming to India to give the dual degree. So that itself shows our curriculum, our standard of nursing education. But India is being a large country. I think quality of nursing education is also concerned. So we are working on a simulation, because now we are more focusing on the simulation is one of the best way, and we have developed a state-of-the-art simulation center. Many of the simulation experts have come and seen the simulation center which Indian Nursing Council established. They have told that they have not seen, because the world, one of the published study says is 50% of the curriculum can be implemented through simulation. So we are following that method.
So what I get that as far as our training programs are very strong, and we have very good professionals. Only thing is, I think, remunerations, as well as, of course, the educate number. That's very agree with you
in
that.
This perspective, I would like to take 1 minute to say that I think Srinath Reddy is here, one of the member of the SON report, State of the World Nursing Report, where the WHO and the International Council for Nurses, the 2020, they put up this to the governing body of the WHO. They declared 2020 as the International Year of the Nurse and Midwife, to recognize the nurses and midwives' contribution in the healthcare delivery system. So they came out with the 4. Lord Nigel Crisp, at least fortunately, he was happened to visit. Srinath Reddy was there. I was there to meet him, because the Lord Nigel Crisp happened to be the ex-Secretary General of the NHS. So he took the initiative how this nursing sector is making an impact in the outcome of the patient outcomes. So therefore, they came out with a report, and in that, just I am telling that report says 4 themes. That 4th theme is, they are telling to all the countries, the WHO has made a resolution, investment. The investment is not happening to the nursing. The second theme which has been woven in that report is creation of the nursing position. Because it is a music to ears to me, because while working as a nursing advisor, I could not implement the nurse-patient ratio, what we have finalized. So global report and WHO is telling to all the countries, creation of the nursing position. The third is the leadership, because there is they have captured the various studies, since nurse is working with the interprofessionally with the various experts, and she is the only one person nodal coordinator to the patient. If her leadership skills are given more, she will be the impact and outcomes are going to be better. That's what they are telling the leadership skill. The 4th is the service delivery. So this is the global resolutions has come to all the countries. Now we are working with the government, how best we can implement, at least as an Indian Nursing Council, we have brought this, the best global leadership for change program to India. We have trained about 40 nursing experts in the leadership skills so that they are going to train the future, the nursing leaders. So I think though the issue is very important, but the Ministry of Health is also seriously considering the issues and challenges to address it.
Thank you so much, Dr. Dalip, for all your, sort of emphasizing, I think, what needs to be done. And in the interest of the patient care, we need to have adequate number and attract the bright ones to this profession. Dr. Agarwal, I think, is a player to, I think the doctor, the patient charter jointly endorsed by DMAI and NABH enshrines every patient's right to timely and quality care. Yet in reality, when a patient, especially in rural or underserved areas, faces a medical emergency and access to a functional facility is limited, the question of accountability becomes critical. Even in a city like Delhi, where major hospitals are concentrated in just a few districts, accessibility remains uneven. In such a situation, who is ultimately accountable when lack of access leads to adverse outcomes? I think, I must say, Dr. Agarwal, you have been not only a very eminent professional, but you also have been a sort of a leader in sort of establishing a good hospital. So I'd like to know from your views, and also about as someone leading a, like you, private hospitals, the challenges around schemes like Ayushman Bharat in private setting. I'd like to, over to you, Dr. Agarwal.
I think I must congratulate Gupta ji for taking the issue, patient union and patient concern, having participated in hundreds of issues where I talked as a doctor. I want to talk as a patient today. Because policy making has to come from the patient, what patient is painting. If I consider myself as a patient, suppose I get a stroke at this moment. Anybody can get. So what I require? I will require a urgent recognition, urgent transfer, urgent CT scan, urgent thrombolysis, and maybe mechanical thrombectomy. So in this situation, where I'm sitting in the heart of the city, in the most elite club of the Delhi, surrounded by the biggest doctors, the chances of my getting treatment is less than 1%. In time of stroke, the nearest hospital in this district, the Cherak Hospital and DMC Hospital, is not equipped to take a stroke patient. The other hospital, which is big hospital, is Ram Manohar Lohia Hospital. I go there and get a full treatment till mechanical thrombectomy, not possible. The radiologist is not there. Interventionalists are not there. The place, Ram Manohar Lohia Hospital, 2,000 bedded hospital, is not ready to take a stroke patient. I go any hospital in Delhi except All India Institute. My stroke will not be managed. Then where do I go? I go to Apollo, Max Fortis, the corporate. The greed for profit requires 3 lakh rupees to be submitted on the spot and 7 lakh rupees for the procedure. So people like me, if I get a stroke, there are less than 1% chances that I will be getting the treatment. Then who is responsible? That is the word he asked me, and I was really shaken. First I had to find out that whether responsibility is one person, whether responsibility is so many people, that it practically has disappeared, sir. There is nobody responsible. The doctor says that I've done the best. Within my capacity, I don't have the system. The hospital says that we don't have the infrastructure. And the corporate says, I've got my shareholders to look after. My share has gone down from 800 to 700. I have to pay more. I listened to the people, they were talking about patient as a cow, as a profit cow. If somebody was talking about 300 crores brand and 800 crores brand, I was a little shaken at that time that I'm a patient. Today I'm talking as a patient.
Who is caring about the patient? Where is the system? What we are talking about system. System never fails, sir. It is a designing of system fails. System is working. When I go to a patient, today I'm talking stroke, I'm talking heart attack, I'm talking accident. Similar thing will happen. This happen in IIC, in NDMC, in Lodhi Road, where all the VIPs are staying. I'm saying that less than 1% chance you get a stroke and you get mechanical from it. No. I'm just saying, please. Now, similar thing will happen. What will happen to the road, high road? What will happen to a village? So the treatment system which has been designed is been designed in such a way that we are creating islands of treatment which are very elite and calling them very high profile, and the most of the services are not available at all. If there's somebody who's going to buy a CT scan, government sector is going to buy 256 slice, dual slice. But what I require is a 16 slice everywhere. Every district having more than 20 lakh population requires a basic infrastructure dealing with time, services and things like this, which has not been thought about. The patient is not at the helm of the planning. The planning is done by people who are nowhere concerned with the patient. They are thinking that I want a shirt, you want to give me a coat. You say I will give you quality. Somebody is talking about quality. I will give the best quality in the world. Either I will give that, either I will not give that. And who will give that? That can be only given by the corporate because the budget constraints. And corporate gives a price because they are exclusive. Now today in my hospital, sir, you are a senior most person with us, working. आपने देखा सारा. मैं अपने अस्पताल के अंदर इंटरवेंशनल रेडियोलॉजिस्ट रखना चाहूँ, रख नहीं सकता क्योंकि वो कैप्टिव है कॉर्पोरेट पे. Corporate will not allow him to go outside. He's paying. So this is a racket which has been created of the healthcare where the patient is a profit cow. So patient को किस तरह center करके आप करें? That is what excitement I got when you talk to me.
I like to know.
You
are a very experienced. Can you give some kind of a solution to this?
Okay, that I'll talk a little later. मतलब पहले बता दूं मैं कि मैं क्यों एक्साइट हुआ जब रंजन गुप्ता ने मुझसे कहा कि पेशेंट यूनियन बुला रहे थे. मैं कहा पेशेंट की बात कोई करता ही नहीं यार. आज तक मैं देखा ही नहीं किसी डॉक्टर को, बड़े से बड़ा डॉक्टर जो पेशेंट की बात कर रहा. मैंने इन्वायरमेंट के पेशेंट को नहीं देखा. सर ने कहा कि नर्सिंग काउंसिल बुला रहे हैं, पेशेंट आता ही नहीं वहाँ पे. जो पेशेंट आता है वो भी आता, हाई प्रोफाइल पेशेंट होता है, वो अपनी बातें लंबी चौड़ी कर रहा होता है. In the name of quality, sir, the country is fleeced and the quality is not given. वो NABH की बात कर रहे थे, NABH वाला नहीं है ना, नहीं है. NABH की बात कर रहे थे. NABH is the only authority which will give the quality, and that quality which is required will be at the cost, can only be given corporate. My no district hospital is NABH. That means that we are not giving service. I mean, the concept is going towards a solution. सर ने कहा मैं तो ग्राउंड लेवल का वर्कर हूँ सर, 3 लाख मरीज देख चुका हूँ, एडमिट कर चुका हूँ 3 लाख पेशेंट मेरे अस्पताल के अंदर. 40 साल के अंदर मैंने ICU किया है. आपके स्टीफेंस के पास भी मेरा अस्पताल है छोटा सा. मैंने देखा है पेशेंट को, मुझे पता है उन्हें क्या जरूरत है. आयुष्मान इज ए वंडरफुल स्कीम which has come up but it has failed, not in the concept but the administration. अब आयुष्मान आपने दे दिया हमको. दिल्ली में कितने हॉस्पिटल आयुष्मान में है जो काम कर रहे हैं? They are giving 12,000 crores has been passed on to आयुष्मान from Delhi budget. आज दिल्ली में LNJB हॉस्पिटल पे 3,000 करोड़ निकालने के बाद बजट नहीं है अब दवाई खरीदने का. आयुष्मान चला गया. अब 12,000 करोड़ खर्च करने के बाद में आयुष्मान सर्विसेज अवेलेबल टू फ्यू हॉस्पिटल्स. No corporate is taking, so services are not given. Stroke is not taken, heart attack is not taken, cancer is not taken. I've got a cancer patient, हमसे आयुष्मान में करना नहीं कर सकते. Administrative failure, sir. We are suffering from administrative failure. The system never fails. The system is designed in such a way that patient is not patient-centric. Today, Gupta ji is talking about patient. We should talk about patient. अगर ये मुझे आज दवाई नहीं मिली, इलाज नहीं मिला, मुझे स्ट्रोक का मैनेजमेंट नहीं मिला, आपने क्या कहा? डॉक्टर ने कहा मेरे को गलती नहीं है, पॉलिसी मेकर्स ने कहा हमने तो पॉलिसी बना दी है. मैं काउंसिल में मेरे पास आते हैं, मैं कहता हूँ सब स्टैंडर्ड बने हुए हैं, हमने स्टैंडर्ड फॉलो क्यों नहीं करे? बट ऑल दोज थिंग्स आर डिफरेंट. आई एम एज ए पेशेंट हैज फेल्ड. आई हैव नॉट गॉट द ट्रीटमेंट. That is what is concerned me. So today I want that every district should have at least the minimum facilities, treating with the emergency, treating with the life-saving management. Today, मुझे 255 स्लाइस का CT स्कैन रामगढ़ लोहिया में जो कि 7-8 करोड़ का आ रहा नहीं चाहिए सर, 30 लाख रुपए का 16 स्लाइस का CT चाहिए, लेकिन वो हर डिस्ट्रिक्ट में चाहिए, हर डिस्ट्रिक्ट के अंदर 4 बेड का ICU चाहिए, मैनेजमेंट चाहिए और रेफरल सिस्टम चाहिए. But this system has to be designed keeping a patient in center, sir. That's my concern. That today, from this platform, to Gupta ji, I would like to say that patient should be at the center of the treatment. जो लोग बैठे हैं पॉलिसी बना रहे हैं उनको मैं ब्लेम नहीं कर रहा, बहुत दिल से काम कर रहे हैं, लेकिन उनको पेशेंट के बारे में पता नहीं है सर. वो बेचारे वहाँ पे बैठे हैं, पढ़े लिखे लोग हैं, सीनियर लोग हैं, लेकिन पेशेंट को क्या कंसर्न है, क्या चाहिए उसे और क्या नहीं चाहिए. वेरी इंपॉर्टेंट, क्या मुझे नहीं चाहिए. मुझे नहीं चाहिए इतनी बड़ी बड़ी मशीन है, मुझे चाहिए बेसिक रिक्वायरमेंट, इमरजेंसी ट्रीटमेंट, timely treatment which you said. That is what is required. I do not get the timely treatment, sir.
Actually, what I think Dr. Agrawal is trying to emphasize that probably system is important. Monitoring the system, you may implement in monitoring. I also, I mean that is one thing we do lack. We create a policy, we create something, but we don't monitor it properly. I know many of the programs as such, but I think the health issue is, I think, better to strengthen the public health structure, but you rightly said the district hospital, the community hospitals, because the scheme that he said, Ayushman, is a very noble scheme, but unfortunately, when it's not, so I think the same, maybe probably.
दिल्ली में जरूर वोट मिल गए होंगे, वोट मिलेंगे जरूर, मुझे काम भी मिला होगा, पैसे भी खर्च हुए 13,000 करोड़ पे. Conceptually, it is great. But whether it has created an impact on the patient's life? Few patients, yes.
Probably spending more on the public, like said, making it more accountable, monitoring the system, I think is very vital. If we have to, of course, I think there are certain kind of therapies which can be tailored, as he said, of the stroke, acute myocardial infarction. We say, why not in the periphery you give in one place some kind of a thrombolytic drugs, then may shift to a center where something like thrombectomy will be there. So I think as far as the quality, NABH mentioned, but I have my, I'm not very sure, AIMS, we never had a NABH. When I went to PGI, somebody asked me, why not you go for it? I said, why should I waste money on NABH? I will spend that money on my facility. It's my challenge. How I give the services of a particular facility to the quality to the patient. Why I have to look at them? Because that needs a lot of money to pay to them. I mean, I know I'm not, I have my concern because AIMS is never an NABH. And PGI, when some people want, I said, why you want to go for an NABH? Make a quality that they look at you rather than be looking at something. I mean, there should be no doubt accreditation bodies, I'm not against that. But it should not be that you have to spend money for. I mean, there has to be a system that I think if you pay to them, then it means you have to some way get it from the...
Give a comment about quality, sir. The quality is highest standard quality. They want to compete with the JCI and things like this. And that is not maintainable by even LNJP hospital. तो उसको ऐसी क्वालिटी की बात क्या करनी जो मैं बेसिक मेंटेन नहीं कर सकता और उनको मेंटेन करने के चलते है मैं सर्विस ही नहीं दे पा रहा. Now these things are system oriented. Now system is made like this. The people who are making system are responsible that they are not thinking about the patient. Patient needs a basic care. He requires an emergency care, life-saving care, and that he must get.
I think that's the, I think when I always tell my colleagues that as a professional doctor, when a patient comes, think that you are a patient in front of him. What you will expect from a doctor? What will you expect from a system? And that should be your attitude because you are a patient. And what Dr. Bradley said that if you look at from the patient angle, we all have to look at from that angle that if I'm a patient, what will I be expecting from the doctor or from the system? Thank you, Dr. Agrawal. I think we don't have, I think Dr. Dalip Singh is not here. Mr. Khan, I think you have a very sort of a very highly technical sort of entrepreneur. You have founded a criteria Criterion technology in 2019 with the clear mission. I think we like to hear more from you. There's so much written about you,
Yes,
but
sure.
I will be
So I think from the perspective of the
patient care.
discussion that's going on around accountability, uh, I'd just like to start with that technology can perhaps be uh, an enabler when it comes to setting the accountability, because we've been developing many systems for hospitals. One of the most impactful solutions that we developed was the eICU dashboard, where we connected all the patient monitors, ventilators, ABG machines, and infusion pumps, all of the ICU equipment, to a centralized dashboard. So you're getting all of the data on a minute-by-minute basis. Usually, the manual charting that is done, that happens on an hourly basis generally, and that can create a lot of blind spots, because obviously if you're getting a minute by minute, or rather on patient monitors, you get a second by second data generation or measurement. So that means you're getting a data value every second. So 60 seconds into 60 minutes is 3600 data points, and out of that only one is being sampled for manual charting. So that that's why, to identify any trend in which direction the patient is going, can take 2-3 hours, because to plot a best fit graph or a trend, you need 2-3 points. So we brought that down to a matter of minutes. So in 10-12 minutes, you can see exactly where the patient is headed, or sometimes even lesser. So you can prevent a lot of deterioration early on. And also, of course, because you're getting a continuous stream of data, so this completely changes the paradigm. Like earlier, these kind of snapshots that were happening at a hourly basis, they can be compared to like looking at a Polaroid or a photograph. So you're looking at individual photographs and trying to make sense of what's happening. Whereas this current technology that we deployed, particularly in COVID-19, it helped us a lot with several hospitals. So this gave a live stream. So compare a Polaroid to a live stream. So of course, in a live stream, you'll be able to see continuous data flow, continuously where exactly what things are going. And you can even rewind, in a sense, all of that data and see exactly what is the point of precipitation, what went wrong, or what could have been done better, what could have been prevented. So this automatically gave rise to another system that we developed, which was the death audit system. So we did this for a medical college. We have our own medical college in Lucknow. So we started doing death audits on a daily basis using our own system, because we were capturing data in such minute details that we were able to bring academic discussion, or enable an academic discussion around every death that happened at the hospital, almost on a daily basis. So that system is still going on. But my point being that technology, if used correctly, can greatly empower our healthcare workers, and first of all prevent unnecessary deterioration or unnecessary adverse events. And secondly, if anything does happen, so it opens the doors for review and improvement as well.
Well, so I think no doubt technology has certainly has been a very asset to the particular medical profession. I'd like to, but there's another aspect to it also, affordability, and it all increases the cost. The question is the technology, if it's affordable technology, that it doesn't, because indirectly, particularly in the private hospitals, whatever the cost occurs, it passes on to the patients. So I think that is the issue again, that, I mean, then we must have for a technology that you have very good evidence to show it has permanent. So I think you are looking at that death that you
Yes.
mentioned, but can you share with us that how that has will come out?
Sure. So we have case studies published where we've demonstrated how this kind of a technology can increase the ICU capacity 4 to 5 times without increasing the number of specialist doctors or nurses. So in that sense, it makes a lot of commercial sense also to invest in a technology that can increase the abilities of doctors or reduce their workload. Because otherwise you have to hire or train specialist nurses, specialist doctors. So instead of that, you can have some of the generalists. You would still need hands. You can't do without hands in an ICU, but because you're doing a data-driven patient prioritization, so you're continuously triaging the patients. So your specialist can be focused more on the most emergent cases or the most out-of-the-box emergencies. So that helps.
You're right that I think only thing is that whatever I think technology brings is it's certainly very useful, but I think we
In
must
terms of
make sure
cost, that's the case I
we
was
have
making.
a technology which is cost effective also,
Right.
so
And
that I think we can have a benefit to also
one more reason why technology would have a cost benefit over manpower any day would be because technology is scalable. Usually when you deploy something like this, once you've deployed it, it's much cheaper to scale that compared to the equivalent amount of manpower that you would do. And the case study that we published over there, if we were to backtrack and calculate the savings for manpower, so we calculated it was coming to about 58% lesser cost in such a system where you have technology that is empowering doctors compared to just a completely analog or manual system.
Thank you, Mr. Khan. I think we have very important panelists now, and Dr. Deepith Divyanshu, is it okay? I think you are very special today because you are the future of the profession, and he is, I think, the president of the All India Medical Students. Which year you are? Just for my interest.
Sir, I recently. So I recently graduated from MBBS this December, so I'm a fresh graduate right now.
Okay, good. I think you have all the experience then. You have gone through and you are entering the profession in a way. So how do you see, I mean, these challenges, whether it's a quality to the patient, access of care to the patients, and affordability also important. And so I think that then the Indian patient will ever fully embrace a technology-enabled doctor over a human one. And this we have been talking about AI also to some extent. So I'd like to hear from you guys. You are your feedback is going to be very, very important because you have seen as a student how the patients are being sort of taken care of, because that is the time when you have you are full of passion for patients. So over to Dr. We'd like to hear from you. What are your concerns and your
Thank you so much, sir, for the question. Like it's obvious that I'm still stepping into the healthcare scenario of the country, and obviously have the least experience of how the system actually works. But what I would say, and what I think all of you would agree, is that I come from a generation of people like the millennials and Gen Z, if nothing, are people with one of the most the strongest opinions regarding things out there. So, and I personally feel that if not all, then some of these strong opinions are going to shape the future of healthcare in the country when we talk about young people stepping into the healthcare field. Uh, when we talk about accessibility to healthcare, I would like to give a little context. I completed my MBBS from Jawaharlal Nehru Medical College, which is an Aligarh Tier 2 city. Not a lot of options for patients when it comes to tertiary care there. So I have a really personal anecdote when it comes to accessibility to healthcare. It was, I think, the third year of my MBBS when around late night, me and my friends were returning from a movie, and on the roadside we saw a guy on a two-wheeler with another person sitting on the back, and who was slouching on the person who was driving the scooter. Like from far we thought, okay, it might be some like random alcoholic. But when our car approached the two-wheeler, we realized ke, nahi, there's something wrong. When we stopped and asked the person if like everything was all right, we came to know that the person who was driving the scooter was the son of the person who was sitting behind him, and he told us कि नहीं ये मेरे पिताजी हैं और इन्हें अभी अटैक आया था, तो इन्हें हॉस्पिटल लेके जा रहा हूँ. So as so like something kicked in me and all of my friends. We immediately got out of the car, checked the pulse. His father was pulseless. We put him in our car, started CPR, and drove him to our emergency as fast as we could while continuing the CPR. We like since we were students at the hospital at the medical college, we tried to get the guy treated as quick as we could, as expedited process as we could, but unfortunately the guy didn't make it. After talking to his son, we realized that he had been like after his father got the attack, he had been traveling for the past 20-30 minutes before meeting us, while his father was like sitting behind him, unconscious probably and pulseless for a very long time. Then we realized like a death like this death and multiple other deaths like this could have been prevented if he had access to good quality primary health care near to where he lived. And the issue with this, like my personal issue that I have with this is, we talk about primary health care and the referral system in the country, and we are taught about it, and it's a part of our curriculum. So it exists in the MBBS curriculum. It is the part of the policies that are being made. But when it comes to the ground reality, unfortunately, the primary health care in our country is near to non-existent, which should not be the case when we are talking about one of the biggest economies in the world and one of the most up and coming developing nation globally. And like if you're talking about infrastructure of primary health care, we as interns are placed in rural healthcare centers for 2-3 months as the part of our MBBS, and we've seen like the state of the primary healthcare clinics out there. In the months of June and July, there is not even a fan to like help the people sitting there. So if a doctor even does not have any incentive to go and work at these places, who is going to take care of the patients? And the infrastructure is not going to improve until the like interventions are taken from by the government on a central level. And if we talk about like interventions on for taken for the primary healthcare, it is actually sad to see the small like how minuscule the spending on healthcare is when it comes to our annual budget. It's around like 3 or 4% of the annual budget for our country when like we compare it to other developed nations whose economies are comparable to ours, who have like healthcare funding in double digits. I feel like moving forward, if that step is taken to increase the funding of primary healthcare and to increase the expenditure on healthcare as a nation, accessibility is something that could improve, and with that, the quality of healthcare would definitely improve as well. And when talking about like the quality of healthcare delivered, we've talked about improving the infrastructure, but like there is another pillar of it which comes into play here. And like I would like to quote a sort of study which people say that in pilot regulations, the pilots who fly commercial airplanes, they are not allowed to fly for greater than 12 or 16 hours because that would be detrimental to the people who are traveling in the aircraft. If the person is working for so long, the aircraft might get into an accident. My question to the system today would be, why is such a discourse not taken into account when we are talking about young doctors who are managing the healthcare scenario of the country? When it comes to doctors working for 36 or 48 hours continuously as young doctors is like glorified and not taken care of. And if you look at numbers, the general average life expectancy of people in our country is around 70 to 75 years, and for doctors is an abysmal 60 years, which should not be the case. And if the healthcare provider is not taken care of,
I have few,
yeah.
I mean, you have already raised, the no doubt that primary health center, I think should be the main focus, and public sector, I think government has to, the quality, the profession need to, you see, but why younger doctors sometimes don't want to go to the primary center? I like to, when we were in the medical council, after the need that we notified, the other issue was that we must have adequate number of seats of PG so that every undergraduate should go to the PG. There should not be that I have, but then we also made a kind of it was approved by the government that every graduate will go and spend 1 or 2 years in the village, and of course after that he'll get into MD. And this was approved by the government, this was notified. Unfortunately, the IMA raised their hands. I was surprised. And it was also fixed there that they will get so much emolument. It will be done by the central government. He will be given a laptop. He will be mentored by the district or special. This was made in that proposal, all of this. But when it came to implementation, the IMA raised hands and then ministry withdrew. But I mean, as a nation, I thought, why not that each one of us must spend, then we will be more exposed to the kind of medication or medicinal environment our rural population is facing. So why you as a youngster? Because if this, suppose this kind of things is again raised, will you be willing to go? Or your colleagues will be, or there are certain concern about that?
So I'll be like very honest about like this. If talking about like people from my generation and their perspective, number one, regarding like the compulsory bond that is there after MBBS, you have to.
I won't say compulsory bond. It's a part of the training that you spend 2 years in rural community. You learn about the rural medicine. You must be paid well. It was mentioned in that. Amount of money was mentioned. Accommodation was mentioned. It was also mentioned that they will be attached to a medical person as a mentor. So kind of, it was not only that, it was mainly for the purpose of exposure to that, but and then after that, you are sure to enter to MD or MS depending upon your score, whatever you have, especially that. So this was all planned in that. So it's not that, I mean, it was only a bond. There's no, it wasn't a question of bond. It's a question of exposing our younger people to that kind of environment of medicine. That's what
ये लंबा debate है.
So I think we'll, okay. I'd like to ask, let me ask now, Doctor, about the technology that we have been talking, affordability and all that. What you have anything, observation on that to say, Doctor?
Yes, so like regarding like adoption of technology, as the last part of your question was, would the general population be willing to accept a technology driven doctor rather than a human one? I personally feel like there are some shortcomings when it comes to the framing of this question, because as young people, we need to realize that even if we are talking about AI and how it is disrupting every field out there, including healthcare, we need to realize that at the end of the day, it is a tool. And I want to take like one very specific example when it comes to adopting technology as part of our practice. Imagine if like a patient comes to an OPD and there are two types of doctors. The first one has the paper, the OPD card in hand. He's listening to the patient and just like not even having eye contact and continuously writing, okay, presenting complaints are these, duration is this, provisional diagnosis this, investigations and so. Active listening to the patient is absent from all of this interaction. Whereas if we like compare this to a doctor who has, let's say, with the buzzword AI driven like note taking machine which is in there, which just like transcribes the whole conversation between the doctor and the patients and automatically generates notes after the consultation is done, which the doctor just has to like proofread and edit. So that doctor will be able to have a more intimate conversation with the patient and have a more human connect with the patient. And I feel if technology is implemented in a way where doctors are allowed to be more human, then yes, the average Indian patient would be willing to like embrace such a technology
I
driven
think they
doctor.
say now that the medicine, the practice is an art, and we always learn from our seniors. And I think there's a popular movie I have not seen. They say Doctor. This was a novel written by a doctor who was a very famous rheumatologist. And so he became sick. He said, I was at the same hospital where I was working for 50 years. I could realize that what difference it is when you are lying on the bed or when you are standing by the side. So I think the patient issues are there, but thank you. I think we are
Yes. Yes.
crossing time.
Yes. Yes.
And
We are
so
out
we
of
sort of,
we are out of time.
well,
So
thank you
we
so much, Gupta ji, for this particular very interesting, and I think Patients Union International, I mean, I'm sure it should be more and more advertised. The patient know that there is some forum that they can approach you even. Okay, these are the things that we are going through, how that can be sort of taken care of to make their life better.
Thank you,
Gupta sir.
thank you, thank you, panelists. I request the panelists to join us for a group photo. Unfortunately, due to time constraints, we won't be moving forward with Q&A. I request the audience to kindly scan the QR for the Mentimeter poll. Huge round of applause once again for our panelists.
I must congratulate Gupta ji that this type of meeting of patients, I think a voice has been raised by the patients, but nobody listens. जो बना रहे हैं ना policies, उनको patient नहीं है सर. And finally they themselves become patient. No? Gupta उठाएं आवाज.
Thank you once again, panelists. Thank you. We move into our next interesting session, the Pathfinder Award session. At IPUC, we believe recognition is the fuel that sustains change makers. The Pathfinder Award honors individuals and organizations who have gone above and beyond, not for recognition, but despite the absence of it, to empower patients and transform lives. Our Pathfinder Awards 2026 jury has brought extraordinary care and rigor to this year's selection. Our distinguished members, our jury members are Dr. Indubhushan, former CEO, National Health Authority, Ms. Sujaya Krishnan, former Joint Secretary, Ministry of Health and Family Welfare, Dr. Atantra Das Gupta, Southwest Asia Head, Samsung SME, Ms. Jyoti Patil Shah, CEO, We Care Foundation. I now invite Dr. Dilip Kumar, President, Indian Nursing Council, to please come forward to present our first set of awards. I request Dr. T. Dilip Kumar, sir, to join us onto the stage. We are honored to present our first Pathfinder Award to Dr. Ronak Pradhan for his pioneering aligned with Ayushman Bharat Digital Mission, whose work stands out for both its scale and originality. By strengthening digital health system and improving care delivery, for his contribution are playing a significant role in enhancing health outcomes across healthcare ecosystem. Congratulations, Dr. Pradhan. Over to you. Congratulations, Dr. Pradhan. I request sir to. Next, we have Asuman Health Tech Private Limited. For that, I would like to call upon Mr. Yogendra Pal from Asuman Health Tech Private Limited to please come forward. We are pleased to recognize Asuman Health Tech Private Limited for building an AI-powered healthcare platform that integrates ambulance services, ICU bed tracking, blood availability, and telemedicine. Thank you. Congratulations, sir. Next, we have Dr. Manika Kansal. I request Dr. Manika Kansal to come forward for her remarkable commitment to delivering healthcare in remote and underserved regions. She has impacted thousands of lives through consistent health camps and outreach initiatives. Her compassion, resilience, and dedication continue to bridge critical gaps in healthcare access for those who need it most. Congratulations, Dr. Monica. Next, I call upon Team Atovio. I believe we have two representatives from Team Atovio. We're delighted to recognize Team Atovio for developing a scientifically validated wearable air purification device addressing the growing challenge of air population and its profound impact on health. With over 50,000 users and a strong focus on affordability, their innovation stands out for its originality, scientific validation, and real-world impact. Thank you, sir. For the next set of awards, I would like to invite Dr. K.K. Talwar, sir, Padma Bhushan awardee, former chairman, Medical Council of India, to come forward and give away a set of awards. The jury of the International Patients Union, with deep appreciation and unanimous administration, has resolved to confer the jury award upon Dr. Rajiv S. Raghuvanshi, Drug Controller General of India. Unfortunately, Dr. Rajiv S. Raghuvanshi sir could not make it to the conference, so I request Dr. Harsh Agarwal to come and collect on sir's behalf. This award recognizes his exceptional leadership and transformative contribution to India's regulatory ecosystem through his visionary stewardship. His decisive action to strengthen regulatory standards and ensure the quality of safety of medicine have significantly reinforced public trust. Next, I would like to call upon Dr. T. Dilip Kumar, sir. Again, our jury has anonymously decided to confer the Pathfinder Award to Dr. T. Dilip Kumar, sir, for his visionary leadership, who has significantly elevated the stature of nursing in India and beyond. Through his work in education, policy, and regulation, he has strengthened the profession and positioned nurses as essential pillars of modern healthcare. His advocacy for digital health competency-based training and global standards in shaping a future-ready nursing workforce where nurses are not just caregivers but leaders and change makers in healthcare. Next, I would like to call upon Dr. Aqsa Sheikh. We are honored to present the Pathfinder Award to Dr. Aqsa Sheikh for her remarkable contribution in advancing LGBTQ+ inclusion in healthcare. Dr. Aqsa Sheikh has been a powerful advocate for equitable and respectful care for marginalized communities. Congratulations, ma'am. Thank you, sir. Next, I would like to invite Dr. K. Srinath Reddy, sir, onto the dais to give the next set of awards. The next award we present to Sachin Sarcoma Society. We are proud to present the Pathfinder Award to the Sachin Sarcoma Society for their impactful work in the patient empowerment and support for sarcoma patients. On behalf of Sachin Sarcoma Society, we have Dr. Rashi Kapoor, who will be collecting the award. The organization has significantly contributed to awareness, care support, and innovation in this rare disease space. The dedication has improved the lives of countless patients and families navigating complex and challenging health journeys. Give a huge round of applause to Sachin Sarcoma Society and Ms. Rashi Kapoor. Thank you, ma'am. Congratulations once again. Next, I would like to invite Mr. Arman Ali, sir, for his outstanding leadership in championing disability inclusion and rights. On behalf of Arman Ali, sir, we have Mr. Sumit Parikshit, who will be collecting the award on behalf of Arman Ali, sir. Mr. Arman Ali's work continues to create more inclusive and equitable care, healthcare, and social ecosystem for millions of Indians. A huge round of applause to the Thank you, sir. Congratulations. Thank you, sir. To every Pathfinder on the stage today who have received the award today, you remind us that change is possible. The care is deeply personal, and that compassion, when channeled with purpose and commitment, is the most powerful medicine to all. Congratulations once again on behalf of International Patients Union. Congratulations to all the awardees. As we approach to the formal conclusion of IPUC 2026, we turn to the President of the International Patients Union, a leader who embodies everything this conference stands for. Ms. Mavish P. Vaishnav has served as Vice President of India's largest publicly listed hospital chain in cancer care, served on digital health standards, committees across multiple ministries, and led the Innovation Working Group Asia set up by the UN Secretary General's Office. She has been National Coordinator for Patients Facing Health Initiative and has spoken at forums in India and abroad. One last time for the day, I welcome Ms. Mavish P. Vaishnav to give away the vote of thanks. Over to you, ma'am.
Distinguished guests, esteemed speakers, partners, colleagues, and most importantly, our patients and care seekers. Good evening. As we come to the close of the International Patients Union Conference, I stand here with a deep sense of gratitude and responsibility. This has not been just another conference. This has been a conscience center for healthcare, where patient is not at the periphery, but at the center. First, my heartfelt thanks to all our esteemed speakers, global experts, policymakers, and thought leaders. You did not just share ideas, you challenged the system, thought-provoking ideas, and inspired actions. You reminded us the healthcare is not about systems. It is about people, dignity, and trust. A special thanks to our guest of honor, Ms. Manmeet Nanda, Additional Secretary, Department of Empowerment of Persons with Disability, Ministry of Social Justice and Empowerment, Government of India. To our patients, caregivers, and patient advocates, this platform is for you. It belongs to you. These stories are not just experiences, they are the evidence, insight, and power. And most importantly, this is the most important reason why this movement exists. I would now like to extend my sincere gratitude to our partners and supporting organizations, National Human Rights Commission, Swawalamban, Bhashini, IBHAS, Internet Governance Forum, Bombay College of Pharmacy, Kaho, Bharat Serums and Vaccines, Sistopic. Your commitment reflects a shared belief. The healthcare must be inclusive, accessible, and patient-first. Your support is transformational. We are equally grateful to our media partners, Medical Dialogues, Express Pharma, and Express Healthcare, for amplifying these critical conversations and ensuring that the voices of the patients reaches beyond this room. As we leave this hall, let us remember, healthcare will not transform because of policy alone. It will transform when patients are heard, respected, and empowered. I would like to thank each one of you and a deep appreciation to my team at International Patients Union who work tirelessly behind the scenes. You have not just organized a conference, you have built a movement. I would now like to invite my team on the stage, Dr. Manpreet, Dr. Harsh, Sakshi, Akshita, Palak, Sabhya, Ambika, Hitanshu, Anshita, Ebin, Shubham, Yash, Erin, Sahil, Pratyush, Aditya, Dinesh. And this would have not been possible without the brain and heart behind this International Patients Union, Dr. Rajen Pratap Gupta. We want you all to be with us in this journey, and we look forward to seeing you in the next year again. Thank you so much.
Thank you, everyone. Ladies and gentlemen, what a day this has been. From the mornings, patient voices to the afternoons, accountability sessions, from insurance battles to pharmaceutical ethics, from longevity science to neurodiversity advocacy, from the AIMS model report to the Pathfinder stage. Today, this hall was a classroom, a courtroom, a parliament, and a celebration all at once. Join us now for the high tea and networking in the foyer. Continue the conversations, build the connections, and carry the mission forward. On behalf of the International Patients Union, thank you and have a great night. Thank you, everyone.